of a bone graft within the spacer is limited because of the small space in the spacer. And so quite a lot of people went for putting a direct bone graft, tricorticate graft like the iliac crest graft. But there are the automatic risk that comes with the iliac crest bone graft is the donor side complication. Some of the literature has complication rates going up to 49%. And obviously, a structural graft is better in this case as it provides a better distraction and reduction compared to a non-structural grafts. So we started taking the C1 posterior arch as a structural graft. The corticocancellous nature of the C1 posterior arch provides for both distraction and better fusion as compared to a spacer. And as the iliac, we are not harvesting the iliac crest graft, we are avoiding the donor side complications. This is the C1 arch in the video, and this is the C2. This is cranial direction, this is caudal. We are trying to expose the facet joint here. And here from the C2 side, we are exposing the facet joint. That is the facet joint. And we started drilling the joint. This here is a C2 nerve retractor. In all of our cases, we did not resect the C2 nerve root. We retracted it. And once we expose the joint space, we go ahead with the C1 posterior arch excision. Sorry. So we make the C1 posterior arch, we split it in two pieces, one for each facet joint, and each piece is shaped into the shape of a peg so that it can sit somewhat like this, so that it can sit into the joint properly. And this is placed into the facet joint. All the while retracting the C2 nerve root. So the objective of our study was to assess the viability of utilizing the excised C1 posterior arch for C1 C2 fusion and distraction. We had included 90 patients all the way from January 2010 to December 2023, and a follow-up was done and a follow-up imaging was done. Demographically, there was nothing significant in the study with a mean age of 40 years. The most common diagnosis was atlantoaxial dislocation, for which we did the surgery, and we also did it for basilar invagination, Chiari malformations, osteomyelitis, among others. This is a slide of the symptomatology. Most of them presented with neck pain along with quadriparesis. This was one of the cases which we had done, a Chiari malformation with retroflexed odontoid, and the patient had presented with quadriparesis, which had progressively improved on follow-up. This was a rotatory atlantoaxial dislocation where he had presented with recurrent posterior circulation infarcts, and we had done the surgery for this patient. This was another case where the patient presented with significant quadriparesis and giddiness. He had a syrinx all the way from the CV junction down to the dorsal spine. After the surgery, patient had improved significantly. We had done a foramen magnum decompression with C1 C2 bony distraction, facet joint distraction. A person who was having a quadriparesis and a giddiness who came to us in a wheelchair was significantly improved on follow-up. The complications in the 90 patients, one patient had developed CSF leak post-surgery. He recovered fully afterwards. 3 patients had poor respiratory drive. They underwent tracheostomy post-surgery. Coming to the outcome, most patients, almost 83 patients had reported an improvement in the presenting clinical complaints. Of these, 9 of them had reported almost normal level of daily life activities. There were no radiological signs of implant failure or bony malunion between C1 and C2 on follow-up with radiographs. 4 patients in our study had reported the significant persistent complaints. Of this, the most common was limb paresthesias, which were not being resolved with any medication. Three of our patients had expired on follow-up. One of them had a poor respiratory drive. He underwent tracheostomy, developed LRTI, and expired after a month. Two of them had expired. They had multiple comorbidities and expired several years later. This is a table showing the possible complications that occur with C1 C2 ganglion resection. And this group is a resective group, and this is the non-resective. This is in literature. In our study, the C2 nerve root was preserved, so the common complications like neuropathic ulcers or dysesthesias were avoided. To conclude, the study shows that the utilization of the excised C1 posterior arch for bony fusion and distraction of C1 C2 joint is a viable alternative to using bone grafts from other sites, and the added advantage of bony fusion within the spaced joints makes it preferable to a spacer. Thank you, sir.
In your study, did you come across any cases of hospitalization of atlas?
Yes, sir, we did, sir.
In that case, how will you harvest C1 posterior arch?
Sir,
Enough for putting it in the facet?
no, sir. In cases where the posterior arch was fused to the occipital bone, we avoided this.
You are avoiding.
Yes, sir.
How superior is this your procedure compared to iliac crest graft? Iliac crest graft
Is the
generally
standard.
tends to have it tends to be a better construct
Yes, sir.
compared to any other possible bony structure you extract, isn't it?
Yes, sir.
So how do you justify
Sir,
superiority of this one compared to iliac crest?
yes, sir. That was what we are planning next, sir. A comparative study with iliac bone crest graft versus this. We are doing that right now, sir.
Okay. What are the donor site complications?
Sir, multiple have been reported, sir. Usually the injury of the iliohypogastric nerve and
Oh, is it so severe that it has to be avoided? I don't think so.
Sir.
Audience? Your expert opinions.
See, generally the tendency to kind of give another incision and avoiding is one issue is there, because the graft site pain is something which is a concern always. So if you can use the graft from there is definitely something which is always appreciated. But in this case, like we said, the C1 graft, I mean, you have shaped that like a peg to place it into the C1 C2 joint.
Yes, sir.
So in a lot of cases, I mean, you may find C1 arch being hypoplastic and deficient. In pediatric patient, it's very difficult to get it.
Sure.
So what is the solution there? Because a lot of times when you do foramen magnum decompression too, so you get a good chunk of thick stud bone, and that is also being used. So that is one question. And the second thing is, you said like the bone effusions are good. So how did you assess the bone effusions in this? And what the literature states, how the bone effusions have been at C1, C2? And what is the long-term follow-up?
Yes, sir. So, common literature which has utilized the iliac pest bone grafts, they have reported good fusion rates, sir.
What follow-up and
So,
what percentage of follow-ups? Because C1, C2, it's far more difficult to assess the
yes.
bone graft fusion. So you cannot just you said like the radiographs we assess the bone
Yes, sir.
fusions. So what is the modality of the radiographs? I mean, what is the modality of the things that you used? Because X-rays, it's very difficult to appreciate at C1 C2 joint.
We had gotten an X-rays only, sir. Post-op follow-up X-rays. A CT scan is preferable.
How long did you follow it up?
Sir, a minimum of 6 months. We went up to 5 years in lots of cases, sir.
Okay.
Sorry, sir. Sir, majority of them, sir, more than 70. I don't have the exact number, but more
Why
than
he's
70.
asking? Because The idea is to put a bone graft is you if you put a cortex in between something that will not fuse.
So, yes.
The medullary graft, the idea is to make out of cortex, make it into medullary graft, then it will help to fuse. If you put a cortex and cortex in between two cortex, the fusion will be a pseudo fusion.
Yes, sir.
You know,
Yes,
that's why C1 arch was failed till date.
we had decorticated the joint and the drill the
C1 arch is very thin.
yes,
Where how will you decorticate and make it cortex to cortex? You know, that's a problem.
sir.
So rather, people have made that into small chips and try to pack it into the C1, C2's joints. So if you don't want to use it, like part of the bone from the C2 spinous process and other things, okay, but it has its own flip sides. So do you have any X-ray of where the bone fusion has been assessed? Because you haven't shown any picture of the X-ray like of where bone fusion has been assessed and where you said like, the bone fusion happened.
Yes, sir. I had put up an X-ray. They changed the presentation.
No, I mean in the presentation you don't have anything.
I had put up one, sir. Just a second, sir. Presentation. They had changed it, sir.
Its time is over. Yeah.
So thank you,
Thank you, sir.
Anish.
Thank you, sir.
Next, I would like to invite Dr. Sham for outcome of short segment TOLF and long segment TOLF.
Good morning, everyone. Respected pictures. Today, I'm in front of you to discuss the outcomes of short segment thoracic ossified ligamentum flavum versus long segment thoracic ossified ligamentum flavum. Coming to the introduction, the ossified ligamentum flavum is a rare degenerative disease of the thoracic spine and it causes a significant morbidity. Usually, the patient presents late and leading to poor neurological status and have a dismal outcome with significant morbidity and poor quality of life even after surgical intervention. So here I would like to discuss and compare the long-term outcomes of the long segment versus short segment thoracic ossified ligamentum flavum. So we also discussed the reasons for poor functional outcomes in long segment group uh, with regard to the prognostication and need of timely intervention for this patient. The aim is the comparison of clinical features and surgical outcome between patients with short segment and long segment thoracic ossified ligamentum.
What is TOLF?
Thoracic ossified ligamentum flavum. Coming to the materials and methods, thoracic ossified ligamentum flavum related myelopathy patients between 2010 to 2020 were recruited from our electronic medical records retrospectively and was analyzed. Subgroup analysis was done. After classifying the patients to two groups, that is the short segment thoracic ossified ligamentum as patients who are presenting with one or two contiguous level of involvement and those with three or more are being classified as long segment thoracic ossified ligamentum flavum group. And those with in between skip levels were excluded and those crossing the region was also excluded. We got around 33 patients and those who didn't have adequate follow-up were also excluded and a total of 28 patients were there with a minimum of 2-year follow-up with a mean follow-up of 6.4 years. So the outcome was assessed based on Hirabayashi recovery rate. It is the preoperative, postoperative JOS score minus preoperative JOS score by 11 minus preoperative JOS score into 100. This is being addressed because the cervical is being removed. That's why 11 is being taken. And we use the absolute percentage of the Hirabayashi recovery rate because in the previous studies were showing the range. That is, most of the patients are having recovery, but the defect which I could see in the previous study was it is being classified as different groups like good, fair, and all. So in the fair it will be 25 to 50%, and the good it is from 50 to 100%. So if it is patient is having 55 and 75, it comes out like good only. So there is definitely a difference. That's why we went on to look on that. So surgical procedures were simple procedure like laminectomy and adequate decompression of all the lesions. So In this chart, we can see that the duration of symptoms overall was 21 months. In short segment, it was 11 months, and long segment, it was 32 months. And the age group overall, it is 53 years, and short segment, it is 53.6, and long segment, and it is 52.7, almost the same. The male and female predominance, you can see here, male is 20 and female is 8. That is 71% of the patients were males. In short segment group, it is 60% male, and long segment group, it is 84% male. And the preoperative JOA was 5.4, and it has improved to 7.3 in overall, and in short segment it is 6.6, and it has improved to 8.9, and long segment we can see that it's 4, and it has improved only up to 5.5. So the recovery rate we have calculated, overall recovery rate, you can see that it's 38.8%. What when we are classifying and looking in deep into it is can see that 54.4% we can see in the short segment group, and it is only 21% in the long segment group. So definitely there is a difference in that. That is what we have seen. So other factors were also there. Intraoperative CSF leak and sphincter involvement preoperatively, and T2 hyperintensity in the MRI were also looked into, but none of them showed any relation with the outcome. So we have this is a chart showing the recovery rate and symptom duration. We can see here that with the progression of the symptom duration, the recovery rate is coming low. So and preoperative JOA also we can see that when the JOA score is low, the recovery rate is low. Probably the longer duration of symptoms and poor neurological status at presentation may be the predictor of poor functional outcome following surgery for thoracic ossified ligament flavum with compressive myelopathy. The patient with the short segment probably would have presented earlier. Even with poor neurological status, it is found that they improve substantially and regionally with a good functional outcome with the timely surgical intervention. So probably the long segment would have forming a distinct subset, possibly maybe due to some other clinical pathological spectrum, which is not known clearly. So this study will give a surgeon an insight to predict and counsel the patient and relative preoperatively regarding the outcome. And we can also tell that the patient who will present with the short segment should be early taken up for surgery to give a good functional recovery outcome to follow. Thank you.
Finished?
Yes.
What are your criteria for selecting long segment versus short segment?
Sir, over a period of 15 years, we only were able to get around 30 patients. So whatever patients who was registered and who didn't have adequate follow-up of 2 years.
No,
and
what do you mean by long segment? What do you mean by
Sir,
short
that is the
segment?
classification which we have made. The patients who are having 1 or 2 levels has been classified as short segment, with more than 3 and more were classified as long
Did you come across
contiguous.
Did you come across diffuse
Sir,
diffuse cases?
that were skip levels were there, cervical, and that was removed. Maybe around 5 cases we were forced to remove from the.
Okay, in people with long-standing symptomatology, did you come across card atrophy or myelomalacia changes?
Sir, that is there, sir. But in either group it was there. T2 changes were there, but that didn't directly correlate with the outcome in subgroup analysis. It was there.
Right.
So what total number of patient is
33 and analyzed only 28 because of the
23 plus 28, both the group, or only 23?
Sir, 28 total.
28
28 males and 8 females.
Total. Okay. So what I understood that you have divided into two group,
Yes.
long and short, and then you operate, and then you make a follow-up that which
Sir, it is a retrospective study. So
I know the retrospective. So what was your conclusion? Means in one level you decompress, and 3 level you decompress. The morbidity.
yes, sir. The patient who are either presenting with 1 level or 2 level, even if they are coming to us in a poor neurological state, they improve significantly. So they should be offered surgery at the earliest. But those who are coming to us with more than 3 level or more, even after doing a same procedure, the laminectomy and adequate decompression, they are not improving. So that
Not
is
but so you want to make a statement that if there is a long presentation, there is one option that you should not operate. Just wait. Is it so?
We can counsel the patient and relative accordingly, sir. If they are
Okay.
forcing.
Because all the literature and clinical practice is still that whatever the compression is there in the spinal cord, you should decompress,
Yes, sir.
right? But you are saying if there is a more than 3 segment and there are even though seriously compressed and patient having severe myelopathy, you should not going to operate
It's
because
not improving.
there is a poor outcome. Is it
Poor
you want to
Yes,
say?
sir. Yes, sir. Thanks.
What is the total follow-up?
Sir, we took only 2 years, but mean follow-up was around 6 years. But yeah,
Okay, 6 years. So someone with a poor neurological status, like I mean, at the presentation itself. So he has never improved well, is it?
yes, sir.
So they must have remained as someone still having bothered by the spasticity, plexospasms, and all those things, is it?
Many of them are bedbound, sir.
I'm sorry.
Many of them are bedbound.
Yeah, I mean, did you do any further therapy for those people?
Many of them are reluctant to come for follow-up. Most of the recent follow-up I could get over telephone, sir.
Okay, and before compressive myelopathy, what is your policy for patients? I mean, who just initially they present with pain. That is the spectrum of this disease, the back pain. So did you even include those people? I mean, at what level of neurological status? I mean, suppose reflexes are just exaggerated, patient is doing well. So did you still did you operate them or you exclude you?
Sir, JAS score actually it is an important thing. JAS score is good means we should operate. Small lower JAS score means
No, did you include those patients?
yes, sir. We included because most of the patient had problems. Most of the patients had neurological, not only sensory, but they had motor. Then only
Yeah.
most of the patient had later symptoms, sir, not early symptoms.
In those patients with long segment, long-standing symptomatology, most often it will be spasticity.
Yes,
Would you advocate baclofen pump?
sir. The problem is in our country, people is not affording 15 lakhs and all. Nobody is affording. They will go for.
So why not decompress them?
Sir, outcome is not significant. We can counsel them so that it's only a guide so that we can counsel the patient how it will be. If they are willing, we can definitely proceed, sir.
And associated fluorosis or any other anomalies like I mean which has affected
Sir,
the outcomes here.
I'm planning for a proteomic study, but we don't have sufficient numbers. We didn't come across that. This is a retrospective study. That is a limitation of the study.
Okay, so what,
Why this factor is important because this all OLF ossified like there is a belt like Gujarat in Maharashtra there are the belt in which this kind of
Yes, sir,
patient
I
found more because of fluorosis. If it is there, then you can ask them to prevent it.
Yes.
That you should have less, change the water and something like that. Any preventive strategy after study you make.
Preventive study?
Preventive strategy,
Okay.
Otherwise it will increase further level.
Yes, sir, understood. But it is from the southern part of India, Kerala only. The study is coming up from.
because the long segments
Understood.
associated fluorosis or some other triangle.
Yes, sir.
So and so did you find like I mean any correlation as well with the back? It's acid is more common, but for acid is do you have any
Yes, sir. What I have a hypothesis also. Want of time I skipped all those. Most of the patient had a lower thoracic uh, problems. Maybe probably, and it was in the male gender also. Probably the males who are going for most of them are manual labors. Probably a lifting weight and all a element of movement would have exacerbated it. Don't know exactly. It's a hypothesis.
perspective study based on the patient coming in rapidly? So did it correlate with any of this is a very common problem in so many of those. So
Definitely the fluorosis element we couldn't assess because many data were missing. We don't have this 15 years back data also, so that is not possible. But regarding the job, most of them are manual labors.
find no compared with what the river out.
Yes, sir. Thanks.
The third is by the cabbie, Dr. Bharat Raju.
Good morning, everyone. I'm Dr. Bharat, Resident Neurosurgery, KMC Manipal. I'm here to talk about caveats in sacral fixation for different sacral pathologies, balancing the benefits and the risks. Introduction. Primary sacral tumors are generally rare. They account only for around.
In award paper, you should not mention your institute.
Yeah.
That is the first principle. It may have a negative mark. Please remember, in award paper, do not represent your mentors as well as institute. Next slide.
Even slides has the institute name and other things. Please delete it. Yeah. I'm sorry. No mentor's name, nothing. You're completely blinded. Your title and your name.
Till you have a time, because it will have a definitely.
Please, yeah. Yeah, exactly. For revealing your mentor and you are biasing the judges. Like.
Okay, sir. Introduction. Primary sacral tumors are rare, accounting only for 7%. So mostly they are benign aggressive lesions, and they're usually diagnosed late because they are milder initial symptoms, and by the time they are diagnosed, they are advanced neoplastic masses. So Scuba and colleagues classified them as metastatic congenital primary osseous primary neurogenic. Wide resection is necessary for disease-free control for chemo and radio-resistant malignancies. And local recurrence rate of sacral tumors are generally high due to the complex anatomy and advanced diseases. Here is I'm telling you a series of unique cases with each different pathologies and how we have operated it. This one 59-year-old male came with history of low backache, radiating to left lower limb for 6 months, and complaints of difficulty in sitting for long durations, bending and standing. Uh, so neurologically, he was intact, and further evaluation showed a thyroid lesion, which was thyroids 5. So we got an MRI done, which showed a lobulated altered signal intensity lesion in the left ala of sacrum at S1 S2 level, and L5 S1 anterior resistus grade 1. So here we did a partial sacrectomy with a left lytic lesion removal, and along with fixation of left L5 pedicle and S1 LR, along with right L5 S1 pedicle and S2 anterior inferior iliac spine screws. So here S1 was preserved, and HP showed a metastatic lesion from the thyroid mets. So here, learning points from the resident's perspective, it's the third most common type of metastasis, and these are mostly osteolytic. Mets from breast and prostate are osteoblastic. So here, where by time sacral is involved, it is an advanced metastatic lesion. So surgery is done. Why? Because it is limited. It's mainly limited to the palliative decompression of the neural and pelvic structures, and along with posterior stabilization. These are generally more of vascular. So while operating, we had a lot of blood loss, around 2.5 liters for this patient, and took around 5 hours of surgery for this. Case 2, this is a 51-year-old male, case of CKD obstructive uropathy at with the PUJ calculus. He came with complaints of low backache and since last 6 months, and reduced urine output. So came to urology, and we have evaluated him for his low backache. He had hip flexion weakness, left knee ankle weakness, and bilateral EHL weakness. We got an MRI done which showed a lobulated mass lesion in the sacral region involving the S1, S3, S1 to S3 vertebra, bilateral sacral ala, left sacroiliac joint, and left ilium along with the foramen, sciatic foramen. Here we did a partial sacrectomy, but most of the since it's a lytic lesion, most of the sacrum was eaten up away. We did a bilateral L4-5 pedicle screw, right S2 AIIS with along with a modified PSIS screw, subcrestal screw, because initially introp it was not our preoperatively we thought to do a PSI subcrest, but we didn't get good purchase, so we had to modify it for PSI subcrest, which was a bit above. Here S1 was preserved and HP showed plasmacytoma. Right now the patient is post CT-RT ongoing. In residents' perspective, these are mainly into lytic expansile and purely destructive. This was a purely destructive lesion, and the standard fixation techniques are in jeopardized. So we need to modify a standard techniques for a good bony purchase. Here, total resection reduces the recurrences, and for this particularly, lumbosacroiliac tailoring for is needed for optimal stabilization. Case 3 here is a 54-year-old male came with complaints of right gluteal swelling since 3 months and right lower limb weakness, operated for sacral swelling with the right hemisacrectomy, previously operated. He had symptoms of frequency of nocturia and hesitancy. Examination, right ankle and EHL weakness was there with reflexes, deep tendon reflexes, right knee diminished and ankle mute, and ankle tone was lax. So MRI showed a large multilobulated heterogeneous enhancing altered intensity, T1 hyper and T2 heterogeneous enhancing lesion. Frozen section showed suggestive of a chordoma resection. So what we did, since already it was a previous resected hemisacrectomy, we did sacroiliac stabilization along with the scoliosis correction which was there, and HP showed a sacral chordoma. Here, though there was significant anterior part of the sacrum, we could take out all the tumor to the posterior approaches only, since it was a capsulated tumor. This was one of different point from the rest of the series which were published. These are slow going locally invasive lesions, and bowel bladder rehabilitation needs to be important for all these kind of sacral pathologies. Case for 50-year-old female complains of low backache since 1 year, which increase on ambulation. Neurologically intact. MRI showed a heterogeneous enhancing mass appearing hypo on T1, hyper on T2. Here a bilateral sacral LR and periarticular region, right iliac crest bony destruction was there, along with S2 nerve root encasement. Frozen showed a spindle cell lesion. Since it was a spindle cell lesion, we did a partial sacrectomy. Along with that, a intertumoral decompression. With that help, due to the decompression, we could separate out the S2 nerve root, where we could save the S2 nerve roots without being dissected or injured. So, learning points: primary neurologic tumors, they are rarely involving sacrum, though it is significant in the pre-sacral region. A posterior approach was feasible, and en bloc resection needs to be done for such cases. And intratumoral, as said, intratumoral decompression helped in saving the nerve roots at that point. Results and discussion are points. Predominantly, they were male, ranging from 45 to 60, and optimal strategies needs to be taken into consideration with the extent of invasion, neighboring structures, pathological diagnosis. So low malignancies, en bloc intralesional resection, metastatic lesions, debulking for palliation. Here only 4 distinctive pathologies are seen, respecting the Cuba classification. Here, unique thing about the study is we are taking all frozen sections, which helped us tailoring in all the approaches intra-op taking decisions. So a well capsulated benign tumor can always go with a posterior approach, though more of it is in an anterior, and extensive sacral resections for
See,
the
you have to conclude this. Yeah. No.
yeah.
It's over. It's over. Like, see, your time is up, sir. Oh, it's there. Oh, what you want? Oh, please. Yeah. Negative 40. Negative 40 already. Yeah, that's what you are exceeding your time.
Yeah,
So, okay, tell us what are the conclusions.
So conclusions: early detection avoids invasive sacrectomy. Posterior approach only is considered, that is failed to invade pelvic structures. We can go only posterior, and intra-op frozen will be helpful in tailoring the resections and avoid complications. Sacrifice of neural structures to be considered only to achieve local control, and we should always be open to intra-op modifications for posterior stabilization, which needs to be tailored every time, as we did in the previous case. And reconstruction stabilization is necessary if more than 50% of SI joint is involved, and preservation of the neural structures is important in more anterior approach for the bowel and bladder functions.
And nice study. So you said on basis of frozen section you decide, right? Then you tailored your things. So how?
So initially, uh, for example, we have one case, this one.
No, no, it's okay, not cases. I mean, you
Uh,
just answer the question, please.
okay, for a post
Yeah. In one of them, you got plasmacytoma, is it?
plasmacytoma, sir.
Plasmacytoma.
Yes,
So
sir.
how did you tailor your resection?
Plasmacytoma,
How did it change intraoperatively the plan of things that you have done?
plasmacytoma, it didn't intraoperative we got, but since it was significantly larger, it was the same, which was according to plan. One of the cases which had changed was the schwannoma, where frozen section was a schwannoma. So we didn't go for an extensive removal of the sacrum. We did an intertumoral decompression, which gave us space and which helped us to take out the whole tumor on the anterior part as well. So that way we could even save the S2 nerve roots also. And apart from that, one more for the fixation part, pre-operatively when planning was being done, CT does show some amount of bony remnant, although destruction was there. But introp, while we were putting screws and all, there was not good purchase, and it was more lytic. So we had to tailor it about to a different trajectory, and so
Okay.
that we get a
So
good purchase.
coming to see what is, I mean, what is your policy like? I mean, do you do a preoperative biopsy and go for these lesions, or you don't do a pre-op? How do you plan it like?
Uh,
See, because you said benign is this, malignant is this, and there are a lot of things. And in one of the cases, it's a thyroid
Thyroid met.
metastasis.
Since
Okay,
it's a,
so
so
what? Yeah,
since it's a thyroid met, generally in giant cell tumors and metastasis and all, mostly thyroid mets, there is more of a vascularity. There is more of a vascularity of the tumor. So while knowing that preoperatively or intraoperatively, we can either tailor either embolization or iliac vessels
no, but
ligation.
did you do biopsy in all these cases?
Yes, sir. We did
No,
intraoperatively.
preoperate, not the frozen
Preoperatively, we
section.
didn't do.
Preoperatively, did you do a biopsy to decide on the plan?
No, no,
Because that's
preoperative.
important. Like, I mean, as to the plan of whether to go in for surgery or not, like, to a lot of things are determined.
Though we do a preoperative biopsy or not, sir, we had to go for it because it needed stabilization.
No, is it by chance that you found out that the tumor is the metastasis, or you are aware preoperatively
No,
that it is likely to be metastasis?
we were suspecting it might be a metastasis due to the
In that
thyroid.
case, you would have investigated further with PET scan, something like that.
No, we didn't get a PET scan done, sir, that time. It was because patient
Because
was
the preoperative workup missed a lot of things. One is the biopsy part, one is the PET scan part. So, and that is one thing. And second thing, you said you have to go for stabilization. Okay, that's accepted. So, what is your what what are the factors? I mean, where stabilization becomes absolutely necessary in a sacral tumor? Or I mean, what are the factors which affect the stability at the sacroiliac joints?
sir, if the main pivot point will be the posterior end of the L5 S1 region, and the axial stabilization, more 80% of it is done by the anterior and 20% by the posterior. So that one invasion of the tumor by the axial thing is one point, and if it is affecting the sacroiliac joint, which is around more than 50%, so that will definitely destabilize the uh, S1, S2 we consider, sir. S3 below, we neurologically we take care while removing the tumor and all.
Some of your patients might have undergone postoperative radiotherapy and chemotherapy.
Yes,
So, what is the incidence of implant failure in your study? Number one.
we
Number two, what is the incidence of postoperative infection?
for this we didn't get any post-operative infection, sir. And the only thing we had to tailor was the incision. For the second case, which was previously operated for a right hemi sacrectomy, we had to take a T-shape incision to accommodate the amount of tumor which we had to debulk. So that was one which we had tailored. And coming to the pullback, sir, we used double thread screws. And post radiation CTRT, till now, actually, we didn't find any implant failure in such cases. Not only this, in yes, sir.
See, even you don't see. You could have just put a slide of a table of those 4 cases, characteristic, everything for the comparison. And second thing, there's not even a slide of review of literature in anyone. It's not just the work that we do. I mean, we want that you compare it what has already been done, is it? So because these are the works, I mean, which have already been done, bigger series are done. So you need to compare it with the existing literature too, is it? Okay, that's good. Thank you.
So the next presenter is Dr. Parthasarathi R. Laminoplasty versus lateral mass fixation, optimal surgical approach for multi-level cervical myelopathy.
Good morning, everyone. I thank the NSSA and the organizers for this opportunity. I'll be presenting on laminoplasty versus lateral mass fixation, optimal surgical approach for multilevel cervical myelopathy. I'll be covering the topics under the following headings. Coming to the background, degenerative cervical myelopathy comprises pathologies not secondary to trauma, infection, or tumor, which includes degenerative disc disease, spondylosis, ossification of posterior longitudinal ligament, ossified ligamentum flavum, and kyphosis. The management of degenerative cervical myelopathy is controversial as to whether to go for a non-surgical management like medical management, including NSAIDs or neuropathic medications, or going for a surgical intervention. When thinking of surgery, whether to go for an anterior fixation, anterior approach, or a posterior approach, or a 360-degree approach is also again a controversy. And once decided, there is also the option of fusion versus motion preservation, like either a artificial disc replacement or a laminoplasty. In all the procedures, either ways, the surgical goal is to decompress the spinal cord and to preserve or restore cervical lordosis as much as possible. So traditionally, people with myelopathy have had a laminectomy to decompress the spinal cord. The issues with laminectomy alone is that long-standing segmental instability and there is a chance of progressive kyphosis. For this, we needed alternative approaches, and we had lateral mass fusion, where we insert a screw in the lateral mass of the involved levels, and then we do a laminectomy to provide decompression of the spinal cord. And the other approach is to do a laminoplasty, where there are multiple methods of laminoplasty available. The one described here is a open door laminoplasty, where we do a bicortical opening in one side, while the other acts as a hinge to provide adequate space. There is also double door laminoplasty, where both the lamina are cut, and there is open door laminoplasty, where we open in the middle and fix it with plates and screws. Here, in lateral mass fusion, there is adequate decompression, posterior decompression of the cord, but the issue is there is limited neck flexion, extension, and rotation secondary to fusion. While in laminoplasty, there is canal widening without complete bone removal, which retains bone for muscle attachment and provides a slightly better range of motion compared to lateral mass fusion. But the problem is the anterior pathology, if it worsens, then the canal space is not adequate in laminoplasty as compared to lateral mass fusion. There has been varied outcomes reported in available literature, and there is scope for further research to fill the existing knowledge gap and implement for future patient care. So the objectives of our study were to compare clinical and radiological outcomes of patients undergoing laminoplasty and lateral mass fixation, and if possible, to try to formulate an algorithm for implementation and future research. It is an retrospective cum prospective observational study done between January 2021 to December 2023, and after the institute's ethics approval. And the study participants were subaxial cervical spine compressive disease who were symptomatic and diagnosed with MRI and did not respond to medical management and had compression involving more than 2 levels and were treated with posterior approaches. Patients who were excluded were who had already been operated and had recurrence. There is history of spinal trauma, infection, associated spinal tumors, or any other associated canal compression in dorsolateral spine, which may have issues with the outcomes. The outcome measures for neurological recovery were modified Japanese Orthopedic Association scores and modified neuric grades. For axial symptom severity, we used the Neck Disability Index questionnaire, and for radiological evaluation, we took plain lateral radiographs to assess cervical curvature as described by Ishihara, which is given here. In our study, there were 102 patients with subaxial cervical spine disease, of which 62 patients were operated by anterior approach and 40 were operated by posterior approach. In the anterior approach, we had 46 patients with ACDF and 10 patients with corpectomy and fixation and 3 patients with artificial disc replacement, which is not included. The patients included were 24 patients who underwent lateral mass fixation and 16 patients who underwent laminoplasty. There were no significant differences in demographics in age, gender, clinical presentation, or the number of operated levels. And the preoperative outcome measures of modified Japanese Orthopedic Association score or the Neck Disability Index, neuric grades, and Ishihara's cervical curvature were comparable preoperatively. The perioperative parameters like mean operative time was significantly less in laminoplasty with 139 minutes as compared to lateral mass fixation of 180 minutes. The mean blood loss was slightly higher in the laminoplasty group, but it was not significant. And the postoperative hospital stay was comparable between both the groups, approximately 5.4 days. And the implant cost is significantly less in laminoplasty, which was around just the implant cost, not the total hospitalization cost. Around 10,000 in laminoplasty, while it was around 16,000. Mean was around 16,000 in lateral mass fixation per level. The postoperative outcome measures, there was significant improvement in scores were noted in a modified Japanese Orthopedic Association score, neuric grade, and neck disability index after both procedures, and there was no improvement noted in cervical curvature after either of the procedure. The postoperative score in the JOA, you can see that in the preoperative, most of the patients were in moderate severity, while postoperatively they have become mild severity. In neck disability index as well, most of the patients preoperatively were of moderate severity in both the groups, while postoperatively they became mild severity. As to neuric grade, preoperatively most of the patient neuric grade came from neuric 3 to neuric 2 in lateral mass fixation group, while it was neuric 2 to neuric 1 in laminoplasty group. The outcome recovery rates were also comparable between both the groups. This is the X-ray given here. With the first one is preoperative and postoperative open door laminoplasty, while the second image is preoperative and postoperative of lateral mass fixation. There was significant improvement noted in clinical condition after both procedures in our study, and the rates of recovery were not significantly different. Most of the earlier studies have shown similar outcomes, and this is just a meta-analysis by Ivan et al. Which shows similar outcomes. And there was no recovery noted in cervical curvature in our study, and most of the studies in literature also show similar outcomes, and some studies show there is worsening of lordosis after either of the procedure. And in our study, laminoplasty was associated with lesser operative time and lesser cost of implant. And similar outcomes have been reported in multiple studies in literature. And one patient in both groups had C5 palsy in our study, which gradually recovered with physiotherapy. And the results are heterogeneous among various studies in available literature, and most studies claim that lateral mass fixation is associated with a greater risk of C5 palsy. Our study has limitations because we had some of the retrospective cases which had a variable follow-up period, and there is risk of selection bias since it is not a randomized trial, and there is risk of recall bias in the retrospective group of the patients, and the sample space is not adequate to comment on extrapolation of data for others. However, the outcomes are consistent with the available literature. To conclude, both laminoplasty and lateral mass fixation lead to significant clinical improvement, and there is no improvement in cervical curvature after either of the procedure. So I would like to tell that since laminoplasty has lesser operative time and it is cost effective, it can be preferred for patients without cervical deformity, and lateral mass fixation can be preferred for kyphotic or deformed cervical spine. However, further large randomized studies with longer follow-up are required to substantiate and implement appropriate management protocols. Thank you.
Jack. So, Dr. Partha,
Yes, sir.
some good points. Nice study. You have done nice analysis, nice literature review.
Thank you, sir.
Statistical method was good. You are almost done in on time. Your slides was good. No negative things about that, except it would have been prospective study.
Yes, sir.
It would be better. That is number one. Uh, what was your criteria? How you decide? Means you have taken all those patients only in which only posteriorly indicated.
Yes, sir. Only those who
So
were,
what was your criteria? You have not mentioned your inclusion criteria.
sir, more than 2 levels is our inclusion. More than 2 levels is our inclusion criteria.
So
Sir.
more than two or three?
Three, sir. That is more than two, not two.
Three. More than three
Three or
level,
more levels is our
you
inclusion
went
criteria.
posteriorly.
Yes, sir.
Okay. And what was the reason of C5 palsy in both the case? Means what you know about that?
Sir, actually, C5 has a shorter course, and there is the angle of exit through the foramen is also slightly acute. So the while doing a laminectomy, the risk of injury to C5 is more.
Okay. Your one statement, I'm wondering the advantage of lateral mass fixation, long segment over laminoplasty is what I believe, because you have a ability and you have a chance that you mold the rod. You
Yes,
have
sir.
mold the rod. You have a chance. You correct the curvature. You make it more lordosis, which is not in the case of laminoplasty. In your case, you said that the advantage, you not have any advantage of change in the curvature. All your patient had the same curvature. It's
Yes, sir.
equal.
There was no worsening, but we had some improvement in patients who had a deformed spine, sir. But the overall average of curvature was not significantly improving. Yes,
Yeah,
sir.
I mean, Jayesh has already told, like, I mean, it's a very well done paper. So the question here is, like you said, one of the conclusion slide you say where the kyphosis is there, you indicate a lateral mass. Otherwise, I mean, you are going for a laminoplasty.
Yes, sir.
That's what is your. So what is the overall? Okay, the other factors have been analyzed in the literature as you have shown. So what is the motion restriction that is coming? The neck movement restriction coming lateral mass versus laminoplasty.
Sir,
Was that analyzed?
yes, sir. We did not analyze the range of movement, sir, but the literature says that since laminoplasty has bony construct behind for muscle attachment postoperatively, the motion range of motion is slightly better, and we are not using in laminoplasty, so flexion extension is also slightly preserved compared to lateral mass fixation. So, semispinal is yes, sir.
Seeing your presentation, it looks as if you have done your homework well.
Thank you, sir.
Okay. Your presentation fits into all the criteria. Okay. Rest of the people, whoever wants to participate in any kind of conference where there is an award paper, I think there is a protocol, there is a procedure. He has adhered to all those criteria that have been laid out. Okay. That aside, in case if it is possible, feasible, you please continue this study and
Yes, sir. We are
include larger numbers and then try to come out with what to call a better, more definable results, right?
yes. Actually, there is a study going on in our institute, sir, right now, in which includes role of DTI and dynamic imaging in deciding in patients, which was presented yesterday here. The interim analysis was presented yesterday here, and that shows that dynamic imaging and DTI helps in deciding the number of levels and the outcomes are better. But the study is ongoing still. Recruitment is going on. And that will be maybe next year. It will be presented completely, sir, which is going on.
And one last question.
Yes,
The
sir.
cervical lateral mass, like what are the levels that are recommended and how many levels you have done? Like, I mean, it's based
Sir,
on,
used subaxial cervical spines only. We have done so C3 to C7. We did not include T1 also in our study because that becomes a junctional. So that will be a confuse. Only C3 to C7 patients. The average levels were 4, sir. Uh, in both
and
both.
what are the things that come out? I mean, people are including from C1 to C7. What is the controversy around the number of levels that are being that are required when lateral mass fixation is done in particular?
Yes, sir. Actually, with including C1 and C2, so C1 and C2, the motion movement possible in C1 C2 is significantly high compared to the subaxial spine, sir. Including that will have all these questionnaires, neck disability questionnaires will hamper the outcomes, sir. So we used only the subaxial cervical spine. C1 and C2 will have a different outcome as compared to subaxial cervical spine because of the range of movement affected is grossly different.
So any questions from the audience, like, I mean, because we have not been asking. So yeah, please involve yourself in asking the questions. Yeah,
Yes, sir. Yes, sir.
Only one way?
No,
Or
sir, we have done both single door and double door. We did not do French door. Single door and double door we have done. And studies have compared all these procedures, and there was no significant difference between what type of laminoplasty we use. And I have seen two meta-analyses which I have not put here, but there was no significant difference between the type of laminoplasty used. But we have, like technically, we are better with single door and double door than open door. So sorry, than French door. So we have done these two cases.
question. Generally, if we put a lateral mass screws for a post-laminectomy, people tell that it prevents post-laminectomy membrane formation so that the recurrence of cord compression is prevented. That is one advantage of putting lateral mass. Do you have any comments on that when compared to
Yes, sir.
lateral?
I have told in the initial slide that laminoplasty, if the anterior compression is worsening, then laminoplasty might have negative impact. But so far in our follow-up, it did not happen.
My question
But
is not that. My
sorry.
question is, we do lateral mass fixation post-laminectomy. The people tell that, as the literature tells, you can prevent the post-laminectomy membrane formation so that the compression of the recurrent symptoms will be less. Is there any advantage of lateral mass over laminoplasty in such thing?
I'm not sure, sir.
What
I could not get your question actually. Sorry.
Yeah, how about this? You're talking about C7. You prefer C7 lateral mass or pedicle, or you go for a transfacetal one?
Actually, sir, we have done lateral mass in all these cases. We have started doing transfacetal in the current study which is going on.
Okay.
After this study got completed, we started doing transfacetal. The
So which
outcomes we
one?
did not
Yeah,
know.
which one you think is has got more purchase? Is it the pedicle,
Actually, sir,
transfacetal, or lateral mass? I'm talking about C7.
yes, sir. From my point of view, for some four cases which I have seen, transfacetal has better purchase, but
Is it?
it is very less cases to tell,
Yeah,
sir,
yeah,
actually.
yeah. Transfacetal is easy, but pedicle has got better purchase, I
okay.
guess.
Yeah. Thank you. Thanks
Thank
a
you,
lot.
sir.
Yeah.
Thank you.
Next is Dr. Jagadish T.
So Dr. Rao rightly mentioned, because all the residents are sitting here in award paper, two things which is very important for all the judges. One is your originality of the content, that is your objective, and second thing, you don't lose the time to explain the background and objective. Just more give time. You have a time of 8 minutes. If you have 5 minutes, your result, your methods, and how you analyze by yourself, you know, that have a more impact to judge.
Good morning, everyone. Today I am presenting my research paper on the topic comparison between microcuff and wire-reinforced endotracheal tubes on postoperative complications in anterior cervical discectomy and fusion. So, ACDF is one of the most commonly done procedure for a single or two-level discredited pathologies of the cervical spine, accounts for more than 75% of all cervical spine procedures. Though considered less morbid, the overall complication rate is around 4.2 to 19.3% of the cases. The approach-related complications include dysphagia, hoarseness of voice, recurrent laryngeal palsy, and stridor. The various risk factors for these complications include long operative time of more than 90 minutes, female sex, revision cases, multi-level surgeries, corpectomy more than discectomy, and ETT cuff pressure of more than 20 millimeters of mercury. Though right side approach once considered as a risk factor, now it has been refuted. The various measures that can be used to reduce these complications include a meticulous exposure, wide exposure above and below, particularly the subplatysmal dissection, local or IV steroids, use of cuff deflation and readjustment after retractor placement, and to maintain the ETT cuff pressure to less than 20 millimeters of mercury. So just as an introduction, after GA is given, the endotracheal tube is inserted and the cuff is inflated. When the cuff is inflated, it comes in contact with the tracheal mucosa, and when the pressure is more than the capillary pressure of this tracheal mucosa, it leads to edema, congestion, and ischemia, leading to the complications. Such complications, the incidence being 11.2%. So basically, two types of ETT we use in spine surgery. One is the low volume high pressure cuffs, and the other is high volume low pressure cuffs. The low volume high pressure cuffs causing distortion of the tracheal mucosa leads to significant pressure related injuries that they are not in practice right now, and only the high volume low pressure cuffs, which conform to the tracheal lumen and significantly reduces the pressure related complications, are the one which are used right now. These high volume low pressure cuffs of mainly two types, the wire reinforced ETT and micro cuff ETT. I request everyone to please concentrate on these two slides because they form the basis of our study. The basic difference is the materialistic property, where wire reinforced ETT is made up of polyvinyl chloride, which on inflation of the cuff leads to the formation of longitudinal folds. These longitudinal folds leads to air leakage, thus it requires more pressure and more volume of air to achieve the tracheal seal. However, in case of microcuff ETT, which is made up of ultra-thin polyurethane, do not form these folds and thus helps in achieving adequate seal at lower pressure and low volume. In one of the in vitro study where the comparison was done between the microcuff ETTs were made up of polyurethane and the other PVC cuffs were made, it was found that on CT analysis, the longitudinal folds were represented by the hyperdensity, and shown by arrow is seen only in the PVC cuffs, which are A, C, D, E, whereas in B it is not seen. So practically speaking, the microcuff ETT should reduce the pressure-related complications. However, there was no study in the literature that has compared the effect of different types of cuff material on the pressure effect over tracheal mucosa. So the aim of our study was to compare the incidence of post-operative complications between microcuff and wire-reinforced ETT in single-level ACDF surgeries, with particular emphasis on pressure-related complications. It was a prospective randomized study done over a period of 1 year. All patients in the age group of 18 to 60 years of age who underwent elective single-level ACDF surgery between the C3 to C7 were included. However, patients with the preoperative symptoms of vocal cord dysfunction, deformity of neck, history of previous surgery in the neck, or patient who underwent corpectomy or multi-level ACDF were excluded. Based on this, we got 120 patients who were randomly divided equally into two groups, either group M or group W. Group 1 M were intubated with microcuff ETTs, whereas W with the wire reinforced ETT. The various parameters recorded include the baseline cuff pressure and the volume of air injected to achieve adequate tracheal seal both before and after retractor placement. At extubation, the vocal cord movement and airway edema was assessed, and post-operatively, hoarseness of voice, sore throat dysphagia, and stridor were assessed. I'm skipping this file. Appropriate statistical analysis were done. Coming to results, there was no statistically significant difference with respect to the demographic data. When the cuff pressure was compared between the two groups, it was found that the baseline cuff pressure as well as the pressure that after the retractor placement was significantly higher in wire reinforced group compared to the microcuff ETT. When the comparison of volume of air was considered, again it was seen that the volume of air injected was significantly lower in microcuff group when compared to the wire reinforced group. When the complications were assessed, it was found that at extubation, all patients had normal vocal cord movement. There was no airway edema. However, in the post-operative period, the hoarseness of voice was significantly higher in wire reinforced group when compared to the microcuff group. So, as we all know, the inflated cuff exerts a pressure over the tracheal mucosa, and pressure-related injuries are common. And with further retractor placement, it further increases the pressure and can lead to the complications. So, it is important that we maintain optimal cuff pressure to less than 20 millimeters of mercury. And from our study, we have found that there is certain advantages of microcuff ETT when it comes to the low baseline cuff pressure and volume of air, both before the retractor placement as well as after the retractor placement, and with significantly lower post-op hoarseness of voice. All this can further be explained based on the materialistic property where there is no longitudinal folds formation that occur in the microcuff ETTCs, resulting in no air leakage, thereby achieving adequate tracheal seal at low volume and low pressure, thereby limiting the pressure-related complications. And again, majority of the previous studies have found that the recommended cuff pressure to reduce the risk of pressure-related complications is less than 20 millimeters of mercury. And in our study, we have found that the microcuff ETT the baseline cuff pressure as well as the pressure after retractor placement was less than 20 millimeters of mercury. So our hypothesis is that we can use the microcuff ETT safely in places where the endotracheal cuff pressure cannot be measured, like in peripheral centers with financial constraints. Our study is further supported by other studies in the literature, where one study has shown that the polyurethane microcuff tubes usually generate less pressure, and in another study it was found that the hoarseness of voice and vocal cord palsy was significantly higher in wire reinforced groups. In addition to that, in our study, we have found that increase in cuff pressure from the baseline after retractor placement was significantly higher in both the groups, irrespective of which type of cuff we use. So we further emphasize the method of cuff deflation and readjustment after retractor placement. Some of the limitations include it was a single center study. The surgeries were done by different surgeons and only 2 types of ETTs were assessed. To conclude, with the use of high volume, low pressure cuffs, we have significantly reduced the complications associated with cuff rated pressure. Maintaining optimal cuff pressure through regular monitoring and adjustment, especially after a retractor placement, is crucial to reduce the complications. In addition to that, micro cuff ETT has got the advantage of low baseline cuff pressure, readjustment pressure, and volume of air, thereby significantly reducing the pressure related complications. However, we recommend a multi-center, larger prospective randomized study to further validate these results. Thank you.
Wonderful. Like, I mean, you're done on time, and it's a very well done paper.
Thank you.
Since the cervical disc surgery is now gradually turning into a daycare surgery, so
Yes.
all these things matter a lot. So in that sense, like even multi-level cervical disc surgeries are being done as daycare.
Yes.
So it's kind of one of the points, I mean, that is often ignored, but which is very crucial, because quite often people have dysphagia, hoarseness, and they stay in the hospital for 3 days.
Yes.
Patients have even the aspirations in older patients.
Yes.
Because the dysphagia is there. So there are deaths as well because of these things. So it's wonderfully done. I mean, well designed and well executed.
Thank you.
Yeah. So you said, like, I mean, this cuff, the tube that you use
Yes,
micro
micro
cuff,
cuff.
that's what it is called?
Yes, sir.
Yeah.
Micro cuff ETT made up
Micro
of
cuff ETT. So is it something like, I mean, which has been studied in other centers, or this is the only of its kind?
Actually, they introduced these cuffs for the pediatric age group, sir. When it was first introduced, they claimed that it do not form any longitudinal folds. The longitudinal folds are the one which actually allows the air to come out, or sometimes it makes the secretion to collect within those folds. These collections, when actually when compared in the ICU patients, this leads to the pneumonia in those patients. Though they actually concluded that when these microcuffs are used, the ICU stay was significantly lower when compared to the wire reinforced cuffs.
Okay. So what are the disadvantages of using this in the intraoperatively? Does it come out easy, or just
No,
the proof?
no, sir.
So,
It will not come out easily.
Mhm.
The cost of the both the cuffs are also same, but actually it was not studied anywhere. That's it. And a study has found that with the use of microcuff ETT, which is nothing but a flexometallic ETT, the flexometallic ETT, when we insert and we put the, I mean, if we are doing from the right side, and we place the tube on the right side, it pushes the trachea to opposite side. So internally, it produces a retraction for the trachea. That is one advantage of wire reinforced ETT, which cannot be found in the microcuff ETT. That sometimes they use.
Microcuff is the flexometallic one.
No, sir.
It's a
Wire
different one
reinforced is the
completely.
one which is flexometallic.
Okay.
If you are using both the tube and you compare,
Yes.
so if suppose you have not used flexometallic and the normal which is supposed to be used,
Yes.
if we are doing the same things but we deflate the cuff during cervical spine surgery, during surgery,
Yes.
is it same? It have a same effect, same impact after surgery, means it reduce the tracheal pressure. What happened if you just
Yes,
nothing
sir.
to do but just we reduce the that pressure during surgery, we deflate it?
You are asking only after the retractor placement. You are asking, right? After retracting.
Whatever.
Huh.
Am I saying we use the same tube,
Yes,
but
sir.
during surgery, if we deflate the cup, we
Yes, sir.
ask the NSSA, okay, deflate it for 2 hours.
Okay, understood.
Is it having the same impact in your study as at that conclusion?
But we have not done
Because at the
that
peripheral
way.
level, this tube may not be available, but this may be the simple idea. Your idea is like iconic. We just deflate the tube during the retractor. Is it
Yes,
okay?
yes, sir. No, after deflating, again we have to readjust and we have to inflate the cuff, because it has found that even just with the ventilator, even just with the ventilation, the cuff, I mean the ETT can displace from its normal position. There is one study on this. So
If
just
you-
a
if you-
deflation is not
So
adequate.
you are saying if you are deflating,
Yes.
there is a chance that it may,
Yeah,
extrude.
not completely come out, but it can displace from its original
okay, no?
position. Yes.
Does the duration of surgery has got any kind of bearing? Sorry. Okay, please, go ahead. Go ahead.
He's saying anesthetics will not allow. Study in the last meeting it was presented, and not same, but somebody has from foreign faculty has told this, that he is doing since last 10 years, and he has shown fantastic result. They just deflate the tube during surgery with, of course, help of anesthetics,
Yes.
and then yeah, please give him mic.
This study was done when I was a student in CMC Vellore, sir. It was 8 years ago. Georgian did the study, and they did that. We totally deflate the cup. We use a flexometallic only, and we totally deflate. Once the retractor is placed, we'll inform the anesthetist. We'll totally deflate the club, and it no migrations, nothing. And we did a randomized control studies, and even though the deflations we with reduced pressure and with no pressure, without the pressure, completely deflated cup and partially deflated cup, like that they did the studies, and they found that there is not much difference, and there is no migrations of thing once you fix it properly.
So by the way, this has nothing to do with your paper. This was fantastic. Out of box we are discussing.
Does the duration of anti-cervical surgery has
Yes.
got any kind of bearing on your study?
Actually, we have done the analysis of that also, sir. There was no significant difference in the duration of surgery between two groups, but I have not shown that situation.
The deflating cuff, like, I mean, is the biggest threat is, I mean, the tube displacement or tube getting pulled out during surgery is the biggest threat that you face during surgery. So if it happens even in 1 in 200, you don't want to take it. So our study may be like, since everyone is focused, like, I mean, everyone would be doing it. The moment it comes into wider adaptation everywhere, so that itself is something, I mean, which is a nightmare. Like, I mean, if it gets pulled out, so it's no one want to take that risk practically. So if someone have the cuff and still able to maintain it, it's definitely something, I mean, which go in a better way, securing everything and still delivering the results.
So supposed to be standard of care.
Yes.
Yeah, chalo, wonderful. Thank you.
Thanks.
Sorry. Okay. Please have
I mean, it's
How
computer
did you
based,
choose
sir.
the patient? How did you categorize the
Actually, all patients who were included were subjected to computer software based randomization, and we divided equally, sir.
So it's a double blind.
Double blind, yes, sir. Thank you.
Is there a possibility of aspiration if the
With-
cuff is deflated?
In our studies, we are not done, but
No.
okay, in
Have
general,
you encountered any kind of
no, sir.
aspiration?
We always, after deflation, we again reinflate immediately after cuff this retractor placement. Thank you, everyone.
We invite the next speaker. That's Dr. Mayank Mangwani. Yeah, please. Hope, I mean, your slide doesn't have the names of institutions and mentors. Yeah.
Good morning, everyone. I'll be talking about my paper on intraoperative neuromonitoring in cervical spine surgeries. So spine surgeries have become very common these days, and it has been shown to increase by 13.3% in last few years. So it is necessary to address all the areas of improvement, including the patient safety and complication avoidance. So why do we need it? Oftenly after cervical spine surgeries, patient will develop quadriparesis, leading them to be wheelchair bound, to bedridden, have bowel and bladder disturbances, respiratory insufficiency, and overall leading to the decrease in the overall quality of life. So the incidence of neurological deficits after cervical spine surgery is between 0.2 to 3.2%. Intraoperative neuromonitoring is useful to reduce major neurological deficits, but lacks conclusive evidence. It involves monitoring of somatosensory evoked potential, motor evoked potential, and electromyography. The use of IONM in non-complex spine surgeries is basically to prevent neurological injury, to identify possible intraoperative insult, and to avoid medical legal implications. But even today, IONM is not routinely used at many places because of lack of standardization in optimal modality and protocols for patient safety. So the aim of our study was to determine whether an IONM signal alert was clinically significant by comparing the two neurological deficit in different patterns of signal alerts. So all the patients with MRI proven degenerative cervical compressive myelopathy undergoing cervical laminectomy were included over the age of 18 years and willing to participate, whereas patients with other deformities, cervical deformities, traumatic spondylolisthesis, cervical tumors, other surgeries, and not willing to participate were excluded. A prospective study was conducted from June 2022 to December 23, and total of 50 patients were included in our study, in which the demographic data, along with the preoperative neurological deficit and the neuric grade, was recorded. Anesthesia considerations were given. All the patients undergoing laminectomy were induced with TIVA, total intravenous anesthesia, with no muscle relaxant. The mean arterial pressure was maintained over 60 millimeters of mercury. Hypothermia, hypocapnia were avoided. And we used routinely in all our patients BIS monitoring, that is bispectral index monitoring was done to assess the depth of anesthesia. A trained neurophysiologist connected the monitoring. A standard neuromonitoring system was used. MEPs and SCPs were both recorded on a graph. For MEPs, compound muscle action potentials were recorded from deltoid, biceps, brachioradialis, abductor pollicis, abductor digita minimi, and anal sphincter, whereas continuous SCP monitorings were done from median nerve using bilateral needle electrode. And a standard 1020 electrode system was utilized to place corkscrew electrode placement in the scalp. The surgery was performed by an experienced neurosurgeon using standard techniques, and if required, fixation was done in patients with loss of cervical lordosis. So the response to signal change, when a signal change occurred, neurophysiologists informed us, and a quick equipment check was done, followed by anesthetic considerations, as I said, to avoid hypocapnia, hypoxia, and then a field check and a possibility of reversal of surgical step was done. Sustained signal change was one that was persistent till the end of the surgery, whereas transient non-sustained drop would return to the baseline before the end of the surgery. Once that was done, post-operatively neurological assessment was done for the patients after the patient recovers from anesthesia, before discharge, and at 3 months follow-up. Coming to my results, a total of 50 patients were included. 86% of them were males. In 68%, 3 levels or more of laminectomy was done, whereas 24% had 2 levels laminectomy. The preoperative neuric grade, most of our patients were in grade 3 and 4, followed by grade 2 and 5. The signal change that we found in our patients, 10 patients had sustained signal change, whereas 4 had transient signal change, 36 with no change. This is one example of the our recording of the neuromonitoring. On the left is the left-sided electrodes, right side is the right-side electrodes from deltoid, brachioradialis, triceps, biceps. As you can see here, there is no signals on the biceps and triceps, and reduced amplitude on other leads, whereas same MEP recording from the same patient shows increased amplitude and latency from the all muscle groups bilaterally. So post-operative neurological examination was done for all the patients, which showed improvement in neuric grade of 8 patients out of 10 with sustained signal change, whereas 2 patients out of 4 with transient signal change had improvement in the neuric grade post-operatively, but it was clinically more significant in patients with sustained signal change. So the use of IONM in cervical spine procedures provides a comprehensive picture of neurosurgical integrity. It is being now used frequently due to its widespread availability and need for safe surgery to prevent post-operative deficits, along with need for prognostication of the patient. The hesitancy of use of IONM is because of the lack of standard protocols and reports of false positives, which is quite high, but still the consistently high sensitivity of 70 to 100% has been reported by several authors, including Fellings et al. In our study, there was no drop in the signal intensity. However, reported range of true neurological deficit post-operatively is corresponding to the signal drop has been reported to as 0.2 to 3.2%. The other major problem with IONM is the high variability of signal waveforms, which sometimes makes it difficult to identify true surgical change. And also with patients who have severe compressive myelopathy, baseline signals itself are severely reduced to record them. But this problem can be overcome as the IONM has been widely accepted for use in patients with deformity surgeries and tumor surgeries. So we can establish a wider database which can help us in doing surgeries when we are performing cervical laminectomies. Those database of wider signal change can be used to pick up those small changes when we are doing cervical laminectomies. Other than that, some authors have reported increased financial burden with use of IONM in cervical laminectomy, but it's justified to use IONM because of its use with both because of its use for both complication avoidance and its need for malpractice lawsuits avoidance. This was a paper published in US which showed over $6 million of paid because of the medical malpractices. No such study has been done in India, but I'm sure it is comparable. The limitation of our study was it is a small sample size, and we need to establish a wider database of signal pattern to pick up smaller signal changes that can help us to come up with a better prognostication for the patients. And in our study, D-Wave was not used, which increases the reliability of the signal monitoring and changes significantly. In future, a use of machine learning and artificial intelligence can also be done to pick up true signal changes, which can improve the specificity of IONM. And a lot of papers have already been published. People are coming up with machine learning and AI softwares to detect even smaller signal changes, which can convert to a post-operative deficit and help us to prognosticate. So to conclude, good clinical history examination with imaging is quintessential for the approach of cervical spine, and IONM should be routinely used to help detect adverse outcome, to prognosticate, and provide aggressive rehabilitation and for medical legal purposes. These are my references. Thank you.
Good presentation. Is there a situation where there wasn't any change in your intraoperative monitoring, yet the patient deteriorated postoperatively?
No, sir. Patients have not deteriorated. Either they have remained same or there was an improvement in the neuric grade. There have been patients out of 50, 20 of patients were there which did not have improvement in the neuric grade, but there was no patients with worsening of the neuric grade.
Which anti-cervical surgeries versus post-cervical surgeries, which one do you think deserve intraoperative monitoring more than the other?
Anterior cervical surgery, sir, but there is a lot of literature which is already published, and it has been proven that for anterior cervical surgery, IONM is very useful. Whereas for posterior spinal surgeries, it is still not proven that IONM helps us in preventing the complications to avoid deficits, and it's used for prognostication.
To tell you frankly, neurological complications are more with posterior cervical surgeries than anterior cervical surgeries, isn't it?
Yeah.
But
after turning, see, the baseline has to be recorded before turning, and then after turning, then they have a certain protocol. If your head is fixed, then you have to do an IONM stimulation. So anesthetist has to be informed very carefully during induction itself. So, and the posterior, the plunging rate is more, and then when you are using a garrison, the chances of damage to the thing is more, and the signal pickup, SSCP monitoring signal pickup is very more and better in posteriors.
So, but there's no literature actually proving that it is more beneficial. IONM is more beneficial in posterior surgeries.
No, that's a baseline actually.
It's for the baseline also, sir.
No, that is a baseline. So that baseline is, it's a rule, right?
So that's what we monitor for the while positioning also. Before positioning, we place the IONM electrodes. We measure the baseline. Once the patient is turned prone, we'll take again our MEP and SCP monitorings. Once they are stable, we go ahead with the surgery, and then interop monitoring is continued.
What I am telling is, you are searching a literature now. It is a baseline. You search a literature in 90s. It is already proven beyond doubt. Certain things are proven beyond doubt. So unless otherwise some articles which comes with a very good randomization and large series and tells that. So what you are telling is a statement. So don't tell a statement.
Everything doesn't require the complications are more in the posterior cabinet. That's where, I mean, by intuition, you want to have some more safety layer by setting up your
INM, yes, sir.
In your 50 patient.
A decompressive cervical laminectomy can produce more complications compared to anti-cervical carpectomy. Okay.
In your 50 patient, how many patient had power approximately less than 3 to 4 by 5?
Almost 10 to 12 patients, sir.
So what I believe, if somebody has power less than 3 by 5, IONM baseline signal.
That's what,
Will be
that
biased.
was the one thing, sir. The patients with severe compressive myelopathy, their baseline signals were very reduced. So that is where we need to have a wider database, even with patients who have
In your
significant.
study, how you manage then? It means that in your 12 patient, your baseline signal was weak. Then how how did you manage?
So those patients didn't have any intra-op signal change, sir. Most of those patients did not have any increase or decrease in the signal change, or that we could see that, or that could be picked up by the IONM monitoring system. So if you have a larger database of even smaller changes that we have collected, so those in future those signal changes could be picked up. But as of now, we couldn't. That monitoring system could not pick up the
So
changes,
you
sir.
should have done the analysis of the patients who have come in with a bad neurological status, and where probably the IONM is the reliability of IONM has already gone down. I mean, is very much less to begin with,
So
because the signal pickup in the to begin with itself is very bad. So someone with a very bad compressive myelopathy and already having very poor neurological status, like, I mean, nothing much would be picked up to our advantage, because quite often it happens that in laminectomies, so sometimes, I mean, with myelomalacia, like the signal pickup is poor, there's no change, and you come out thinking that okay, everything is going well. Suddenly the patient wakes up and you find that the patient is deteriorated. So this is quite common. So the anterior cervical surgery is okay. I mean, there are other complications, larger complications associated with it, but neurological deterioration rates are much less, because a posterior laminectomy, by very virtue of it, is being done in much degenerative diseases where the things are already pretty bad. Okay, thank you.
So what is your amplitude and latency? You are telling signal change alone, but you are not
for
specified a latency or a
For both of them, MEPs, we just saw the amplitude. There was increase in more than 50% amplitude increase. For SCCP, both amplitude and latency were increased by more than 50%, sir.
Increase or decrease means reduced.
We saw only increase, sir. Increase in amplitude and reduce in latency. For SCCP, reduce in latency, increase in amplitude for MEPs and SCCPs.
Thank you. Thank you. Nice.
Thank you, sir.
Dr. Arvind Mrani, retrospective analysis of concomitant spinal fusion in intradural tumor surgery.
A young female was operated for D10 D12 schwannoma, presented to us with neurological symptoms and post-laminectomy kyphosis with pseudomeningocele. A pseudomeningocele excision and a fusion surgery was performed. How could have been this prevented, and when to perform a fusion in intradural tumor surgery? Good morning, respected staff. Today, I'll be talking on the topic indications for concomitant fusion in intradural tumor surgery. Intradural tumor surgeries possess unique challenges due to the location and clinical symptoms. While the primary goal of the surgery is tumor resection, optimal stability is also crucial. Concomitant fusion involves simultaneous fusion of the destabilized posterior column during tumor resection. There is a literature gap on providing adequate guidelines for specific indications for performing fusion surgery along with tumor excision. The objectives are twofold, that includes to evaluate clinical and radiological outcomes in patients undergoing tumor excision and to provide a detailed analysis on indication for fusion. We conducted a retrospective study from 2014 to 2023. Patient demographics, tumor characteristics, surgical approaches, and pre and post-operative variables were considered. We included all patients who underwent fusion with tumor resection, and we excluded non-fusion and extradural pathology. We collected patient demographics, diagnosis, level of involvement, and other data. Preoperatively, we did the MRI and X-rays to see the sagittal parameters like pre-op kyphosis, pre-op instability, facet or pedicle involvement. And clinical assessment was done using KPS scores, that is the Karnofsky Performance Status Scores, VAS scores, and Nurix scaling. We also collected intraoperative data on duration of procedure, amount of blood loss, and a hospital stay. Post-operatively, X-rays were done to see the fusion rates, post-op kyphosis, and sagittal parameters, comparing the pre-op parameters. MRI was done in selected cases in case of incomplete tumor excision and aggressive tumors. Coming to the results, a total of 147 patients underwent tumor resection surgery, out of which 38 patients had a fusion surgery. We excluded 109 patients. In our study, majority of the patients were males compared to females. Also, most of the patients had an interdural pathology compared to the intramedullary pathology. Majority of the patients were under 40 years and majority were primary surgeries. Most of the tumors were located in dorsal spine followed by cervical and dorsolumbar and cervicodorsal. 50% of the patients had unilateral and 50% had bilateral involvement. Majority of the patients had a single level involvement and most common tumor in our study was neurofibroma followed by ependymoma. The duration of procedure, blood loss and hospital stay was significantly higher for the intramedullary tumors compared to the intradural tumors. Also, pre-op Nuric score, VAS score and KPS score was significantly lower compared to the post-op status. Coming to the radiological outcomes, there was significant improvement in the cervical lordosis and lumbar lordosis. Only one patient had experienced rod migration. There were no cases of implant breakage or wound complications. 3 patients had CSF leaks, out of which 2 were managed conservatively and 1 was managed with resuturing. Here is a patient who experienced rod migration who was operated for left recurrent neurofibroma. So the major indications for our study was extensive laminectomy more than 3 levels, more than 50% facet resection and junctional pathology. Coming to case examples, here is a young male who presented to us with right-sided symptoms and was diagnosed as right D12 to L1 dumbbell neurofibroma. So the major indications for fusion in his case were, since the tumor was exceeding into the neural foramen, the fascectomy was done and it was a junctional pathology. So significant improvement in pre and post-op scores. So second case where a patient presented with significant myelopathy and was diagnosed as a D3, D4 recurrent epidermoid cyst. So the indications for fusion in his case, since the tumor was a recurrent and pre-op significant kyphosis and significant myelopathic features. So 6 months follow-up and 1 year follow-up videos. So another case was operated for a C3, C4 recurrent arachnoid cyst. The main indications for him were, since it was a recurrent tumor, post-operative surgery kyphotic deformity, significant myelopathic features and pediatric age group. Another tumor extending from D12 to S3 myxopapillary adenoma, in which extensive laminectomy was done, facet resection and junctional pathology and pre-existing kyphotic deformity. So the traditional approach, which involves multi-level dorsal midline laminectomy for spinal tumor resection, but extensive laminectomy destabilizes the posterior arch of spine and causes post-op instability and kyphotic deformity. This is well published by Alexandre Vecchio et al. In his paper about the post-laminectomy kyphosis. In our study, only 8% of the patients with spinal cord tumors required fixation. Our observation study involved 25% of the patients who required fusion. Similar studies where only 9% of the patients had fusion surgery who underwent tumor resection. So this is a systematic review which tells us about the surgical criteria for fusion in patients undergoing tumor excision. So majority of the case shows that there was bony destruction by the tumor or there was a fascectomy and previous deformity. We also know that junctional pathology can lead to post-operative tumor in the junctional pathology can lead to post-op kyphosis, and pediatric population where tumor resection is done can lead to significant regional instability. Also, the presence of extensive syringomelia along with tumor is an indication for fusion. Severe pre-op myelopathy needs fusion as it provides immediate stabilization and provides improvement in the neurological outcomes. So fusion, it provides significant improvement in pain levels and neurological function attributed to added stability, and there is lesser incidence of post-op instability with better functional outcomes. So these are the main indications for concomitant fusion in tumor excision in our study, mainly being pediatric age group, significant preoperative kyphotic deformity, junctional pathology, extensive bony tumor resection that involves more than half of the body scalloping, entire pedicle damage, facet damage, extensive laminectomy more than 3 levels, severe preoperative myelopathic features, presence of extensive syringomelia, incomplete resection of intermediate tumors when the plane of cleavage is not present, recurrent tumor necessitating more bone excision and post-laminectomy kyphosis, and inability to remove the complete tumor. So fusion done for instability, immediate, and to prevent post-op kyphosis in the late phases. So the criteria needs to be considered individually for decision to fuse. Two or more criteria, there is a strong argument for fusion. It is better to individualize patient assessment and meticulous surgical planning is necessary. Further prospective studies are needed to compare. Thank you.
Are you an advocate for prophylactic stabilization to prevent further kyphotic deformity following interdural tumor resection?
In selected cases, yes, sir. In selected cases, yes.
What are the classical selection criteria?
Sir, when we are doing an extensive laminectomy more than 3 levels, when it's a junctional pathology.
See, you have done 4-level laminectomy.
Yes, sir.
But you haven't disturbed the pedicles.
Yes, sir.
Still, you want to go ahead with stabilization?
Also, I would like to consider other.
You want to go ahead with stabilization
no, sir.
in a 4-level laminectomy?
No, sir.
No.
No.
But that goes against whatever you have advocated right now.
More than 2 indications, I would like to. It is individualized patient characteristics.
Okay. Would you consider this procedure
Yes, sir.
prior to the occurrence of kyphosis or after the occurrence of kyphosis?
Prior to the occurrence of kyphosis.
Prior to.
Yes. We'll see whether.
I feel it's a little overzealous.
Yeah. So why is asking this question? Your study is about that you wanted to see that I was expecting the conclusion that the two group you have choose, one who is fused, one who are not fused.
Yes.
What happened after 10 years? Those who are not fused,
yes,
whether there was complication like there is an increase in kyphosis and there is some problem and there is a complication, and after you are giving conclusion, suppose that okay, this was poor, this is good, so I think we suggest fusion in this is the indication. But that part has, I think, lacked in your study.
Sir, I didn't compare the patients who underwent fusion and
So
non
how many patients which have not fused and become kyphotic?
Yes, sir. We had done fusion in 35 patients and all are doing better.
You know what I'm saying?
Yes,
Those who have not.
Yes, sir. Nobody developed kyphosis, sir. Nobody required fusion because yes, none of them developed, sir. So these patients had the indication for fusion, so we fused. Yes. Yes. Yes, sir.
Asking is the non-fused patient,
Yes,
you make a conclusion saying that fusion may not be necessary after 10 years of your study.
Yes, sir.
Is it acceptable or not? He's asking. You have done a 10 years of study.
Yes, sir. Yeah. Fused. Yeah. Yeah.
After 10 years of study, you advise that we should have fused them. That was the conclusion.
No, sir. All are doing well. We didn't. We
Okay,
don't
there was
provide.
no indications to fuse
No,
in those
no.
cases?
Yeah, yeah.
Okay,
So we
then,
didn't
I mean,
fuse.
you should have come up with some better conclusion, something new out of these patients where you fuse. But
Yes, sir.
anyway, so that thank you, Dr. Arvind. Like we are running beyond time now. We can't take
Thank you,
too many questions now. So can we invite Dr. M.K. Tiwari like to present his paper?
Good morning, everybody. Today I'm going to present my institutional approach of sacral tumors. There's a series of 3 patients, 1 female, 2 males, presented with features of low back pain and imaging suggestive of sacral masses. This is the first case. There's a 26 years old gentleman presented with a known case of rosette forming glionular tumor in 2016, operated. During that evaluation, his neuraxis MRI was done, which suggestive of no extra lesions. He had a trivial fall in 2021, after which he developed bowel bladder incontinence. He underwent emergency surgery and posterior decompression. Intraoperatively, these are the images which suggestive of a heterogeneously lobulated mass involving S1, S2, with a post-contrast enhancement and few hypointense lesion in between. He underwent emergency sacral laminectomy L5 to S1. Intraoperatively, there was a clear, well-defined plane between tumor and the soft tissue with intratumoral bleed. The complete excision of the lesion has been done, and patient recovered with partial recovery of the sphincter control, sir. This second case is a 35 years old female, a known case of non-insulin dependent diabetes mellitus, presented with pain left gluteal region and radicular pain left lower limb. Her MRI is suggestive of a well-defined mass in the sacral region with minimal presacral extension, as this can be seen in this MRI images also, sir. Uh, the patient underwent left pyramidal posterior incision, laminectomy, and widening of the foramina. Well-defined plane was there, and total excision was achieved. In the third case, this is a 65 years old male who presented with non-specific axial low back pain. Uh, his MRI is suggestive of bony mass with bony destruction, and this as can be seen in sagittal and the coronal image. There was pre-sacral extension with pre-sacral extension, and preoperative patient underwent stenting of the bilateral ureter, higher sacral resection done, combined anterior posterior approach. SI joint was not involved, and right S2 nerve roots were salvaged. This is the intra-op images of the patient. This is an anterior approach where pre-sacral space was defined, rectum separated, and the pack placed. The patient repositioned for the posterior approach. The plane is dissected, the tumor excised, and the sacrectomy has been done. This is the post-op images, pre and post-op comparative images where there is no residual lesion. In this image also, there's a pre and post-op when there is no residual lesion can be seen. To summarize, the three patient first patient underwent follow for almost 1.5 years. No adjuvant therapy has been given. Thus partial recovery of the sphincter function was there. In case two, 1 year and 4 month follow-up was done. She was also not offered any adjuvant therapy. She is asymptomatic. Third case received conventional EVRT, and presently he has no progression of the disease. So the sacral tumor presents with a varied variety of symptoms, with starting from non-specific local pain to the radicular pain. Painful restriction of hip movement may be there. The patient may have involvement of bowel and bladder function because of the sacral nerve roots involvement. There may be presacral extension of the tumor causing compression of the rectum, and neurological deficit because of involvement of the L5 to S3 nerve roots. So in the management, in that sacral tumor, we have to think as an oncosurgeon first, not as a spine surgeon, because the goal of the surgery here is to complete excision of the tumor rather than the neurological recovery, sir. Neurological preservation. Sacral tumors have some complexities, where the first two sacral vertebra is responsible for the weight bearing, and there is spacious canal which causes a late present, because of which the patient presents late and the symptoms take time to develop. Because of deep location and relation to the neurovascular structure, instrumentation becomes little difficult, and there is issues with the spinal fusion rates also, and patient often left out with the neurological deficit after surgeries. The investigation which we need to do pre-operatively before tailoring the management is except pelvis, the first and foremost investigation which can tell us about the erosive changes and any any masses related to the spine. CT and MRI always remain the cornerstone of the diagnosis, which tells us about the bony involvement and the extent of the lesion and its relation to the adjoining structures. Bone scan and PET scan can be used for the staging of the disease, and CT angio to assess the vascularity, and in case pre-op ambulation is required. So the differential diagnosis, there's a wide variety of tumor that can occur in the sacral region. The most common benign primary of the sacral region is chordoma, whereas the most common primary sarcomas can be osteosarcoma, or most common malignant is chondrosarcoma. The treatment can be it's a varied treatment starting from the FNSC biopsy, because we need to have biopsy for tailoring the surgical management of the patient. Surgical excision, the goals I've already mentioned, because of maximal tumor resection with neural preservation if possible. Approaches may be anterior, posterior, lateral, perineal, or combined anterior and posterior approaches. Stabilization by Galveston technique if required. So the literature supports that patient undergoing surgery for the sacral tumors may require stabilization, spinopelvic fixation with myocutaneous flap if there is the soft tissue deficit, The surgical technique which can be applied is sacral laminectomy, posterior sacrectomy, anterior-posterior sacral resection, synchronous abdominal sacral approach, and sequential anterior-posterior approach with myocutaneous flap. To conclude my presentation, the management should be individualized. It is a multidisciplinary approach. Optimize pre-op status of the patient. Look for the nutritional status, immune status of the patient, appropriate wound problem, immune status, nutritional status, as I already mentioned, and the coagulopathy has to be ruled out before surgery.
Yeah,
These are my references.
Thank you, Dr. Tiwari. Yeah, I mean, we appreciate you doing these complex tumors, like, I mean, with very extensive, requiring a lot of uh, surg kind of a very exhaustive and expansive job surgically to do this. So, what is anything that you have learned from these three cases that you presented? Like, I mean, apart from looking at the literature and all, like, I mean, are there any different analysis or something that you have come out with?
Sir, in our three cases, none of the patient required stabilization of those spines, sir, because all the tumor are below the mostly it is confined to sacral region. The third patient, which HPA was chordoma, the lesion was below at the level of S3. So generally, the weight bearing spines are
That
first.
part is fine. Like, I mean, see the fixation, not fixation. See, these all things have been done. So anything, see, the most of the patients treated with these in these region tumors have huge morbidity.
Sir.
So do you have any different approach for these lesions? I mean, in whatever. I mean, sometimes even just one case makes huge difference. Like, you don't need 1,000 cases to come a conclusion. So in your three cases, I mean, could you do anything differently so to minimize the morbidity neurologically and in other
Sir,
ways?
we used to have this biopsy pre-operatively so that we can actually tailor a detailed management program and post-op recovery plan if the patient is having malignant lesion, if the patient has metastatic lesion. So the surgery can even accordingly,
Okay, so we are running beyond time, Dr. Siva. Thank you. Appreciate you presenting this. Yeah. Can we call Dr. Soumya Ranjan Rana?
Uh, Good morning, all. Our study was role of SSCP and MEP as a predictor of post-operative outcome in spine surgery cases. It was a prospective observational study. IONM, as we know, guarantees patient safety in all the spine surgery cases, but it still has a risk of causing postoperative deficit by 5% as per literature, and it helps in giving real-time feedback, but it cannot prevent the injury directly. The most commonly used modalities at hospitals are SSCP and MEP, and the real-time feedback helps in early identification, early intervention, and thereby minimizing complications. It decreases the neurological deficits by 50%, but still there are limited literatures as per the prospective study assessing the clinical outcomes based on INM findings. And that was our objective, to assess the relationship of intraoperative INM findings and seeing the clinical postoperative outcomes. In the period from June 2022 to December 2023, we included all the patients for all the spine surgery cases, excluding those with motor power less than 3 by 5, spinal surgery cases below L1 level, and cases in which SSCP and MEP was obviously could not be performed. This is one normal MEP and SSCP trace graph. We routinely did MEP in deltoid, brachioradialis, abductor pulsus brevis, quadriceps, tibialis anterior, and extensor hallucis longus bilaterally. And the SSCP was done in bilateral median and ulnar nerve. So the anesthetic consideration and INM procedure was done as per the ASNM, American Society of Neurophysiological Society monitoring guidelines, and the instrument we used for that was NIM Eclipse E4 system. A significant reduction in amplitude for more than 50%, an increase in latency of more than 10% from the baseline were identified as significant change, of significant decrease in SSCP and MEP as well. And the post-operative follow-up was done after 48 hours of surgery and at 6 months. This is the 1020 system for scalp electrode placement in MEP, and this is for SSCP. Coming to the observation and results, the average age of the participants was 36 plus minus 19, minimum being 1 year and maximum being 69 years. Of all the patients, 66% were male. This was akin to the previous literature available. And in our study, the maximum patients we included were of CVJ pathology, followed by PIVD and IDM at various levels. This was one such case of intramedullary tumor, and we did MEP and SSP at various level of our procedure, starting from a dural opening, pia opening, and intratumoral decompression. And in this case, we found from the beginning of our procedure, the amplitude of MEP has decreased at the end of the procedure at all the muscle level, and thus was the postoperative deficit at all these muscles. Such was a case of C5 C6 PIVD, and we found the right abductor pulsus brevis had reduced amplitude during the procedure and at the end of the procedure, and we found there was decrease in the muscle power as well in the postoperative phase. The decrease in SSP, this graph shows, was on the right side upper limb, and this patient also had postoperative sensory deficit in the same limb. This was one of our cases in which, from the baseline recording, the MEP has improved from the baseline, and these patients we found had improvement in the post-operative power from their pre-operative assessment. So, of all the patients, 58 patients showed improvement, of which 50 patients had improvement from the baseline MEP recordings, and rest of these numerical shows the MEP changes, SSP changes, and the corresponding motor and sensory deficits in our patients. As per our analysis, the number of significant permanent changes in MEP, SSCB, and combined methods were found to be significantly related with the postoperative deficits in motor and sensory. And no intraoperative changes in INM was found in few patients, though they showed improvement in the postoperative phase. And the cause for the deterioration in one of our patient who showed no changes in the MEP and SSCP could not be correlated with any of the neurophysiological changes. As opposed to this, one of all patient, the 50 patient had a significant improvement from the baseline MEP and SSCP reading too. This is the diagnostic analysis of individually MEP, SSCP, and the combined modality, showing increased better sensitivity and specificity of using combined approach as compared to the MEP and SSP individually. And analysis of the therapeutic advantage of MEP and SSP had showed more sensitivity of MEP and more specificity in the case of SSCP as per our analysis. So coming to the discussion, SSCP, as we know, has a requirement of temporal summation, which makes its assessment delayed, and we get a late analysis of the impending injury. And as stated by Hardley et al. In 2017, INM in spine surgery cases have restricted diagnostic utility and no proven therapeutic use, was supported by 2015 and 2017 literature as well. And patients who were administered long-acting muscle relaxant due to any reason did not show any baseline MEP and SSCP, so they were excluded from our study. We had one patient who had significant change in INM trace from the baseline, but was associated with decrease in BP as well. This explanation has been given in 2024 paper of Ghatol et al. So transient MEP and SSP changes did not have any postoperative deficit. Those with permanent changes in both SSP and MEP had respective postoperative deficit in motor and sensory, and improvement in SSP and MEP from the baseline had postoperative improvement as well. So MEP had a better sensitivity and specificity with regard to identifying postoperative motor deficit, and combined approach was superior to both of them. Limitations of our study was smaller number of patient population, the limited duration of our study. We could have organized the cases into multiple subgroup as per the pathology to maintain homogeneity, and randomization trial can be a future for this study. Concluding, IONM has a definitive role as both diagnostic and therapeutic modality at avoiding significant neurological deficit and helping in postoperative improvement in power. Interdepartmental coordination is a must between neurophysiologist, anesthesiologist, and a neurosurgeon. Combination of all the monitoring modalities directly enhances the value of technical precision at IONM. These are my references. Thank you.
Good presentation.
Thank you, sir.
You're operating an intramedullary astrocytoma.
Yes, sir.
And you have found that during intraoperative monitoring, there has been some deterioration.
Yes, sir.
In SSCP.
Yes, sir.
Would you conclude the surgery? Will you stop?
No, sir. Sir, actually, the alert signs we took into considerations. The only procedures where fixations were done, and in those cases where deformity correction surgeries were done, in that cases we could stop
No,
the surgery.
we are speaking about intramedullary
Yes,
astrocytoma.
I'm coming to that, sir. In the cases of intramedullary surgeries, we could not stop the surgery then and there. We did pause the surgery to look for any improvement in the MEP reading or SSCP reading. But then, when it was not there, we continued with the surgery, sir.
But that may result in significant deterioration, neurological deterioration of the patient. No?
Yes,
Okay,
sir.
what is the purpose of your monitoring? To prevent neurological deterioration
Yes, sir.
because of the surgery.
Yes, sir.
Okay.
Sir, to decrease the bulk of the tumor, we did as much surgery as possible, and then we stopped then and there when there was decreasing amplitude and increasing latency of MEP.
Okay. You are operating a case of intramedullary hemangioblastoma.
Right, sir.
And there is a deterioration. Would you stop the surgery or would you go ahead?
Sir, that is case-based.
Astrocytoma and hemangioblastoma.
Yes, sir.
The philosophy changes significantly.
Yes, sir.
Okay. The way you look at astrocytoma is entirely different from the way you look at the hemangioblastoma.
Yes, sir.
Maybe one last question. So, in the intramedullary tumors, how many intramedullary tumors are there?
So total
intramedullary tumors.
Sir, 8.
8. So, what is the resection rate in that, and in how many cases you completely stop because there's a drop?
Sir, only 2 cases we had to stop the cases in between after intratumoral decompression was achieved, and in other 6 cases also
You do a
there
sub-analysis
was.
of these cases like
Sir,
sub-analysis of the intramedullary tumors.
no, sir, we haven't done it
Because
yet.
based on the generally, I mean, ependymomas, you generally
Yes,
tend
sir.
to have a complete resection.
Complete resection.
So, did MEP has using IONM has resulted in a subtotal resection in any of the cases?
Sir, only in the as I said, in astrocytoma we had 2 patients of intramedullary tumor, and other cases we did not have to make a subtotal resection. A complete excision was achieved. Sir, another thing, in the mid of the surgery, when the MEP was reduced, we waited for it, and when it came back to the baseline, we continued with our surgery. So
how many cases it happened?
Sir, 6 cases of intramedullary tumors.
So it dropped and again returned back.
Yes, sir.
Okay. So in any case, I mean, but a lot of times, I mean, it may not return back. So how long did you wait before it returned back?
Sir, we took all the steps of the alert procedures that are mentioned.
How long did you wait before it returned back?
Sir,
because I mean, sometimes you wait for 15 minutes, it doesn't come back. So
that we haven't documented, sir.
Yeah, fine.
For how long?
No, I mean, this sub-analysis is important.
Understood,
Because that's a learning point. Yeah.
Yes, sir.
Anyway, thank you. Thanks a lot. Yeah.
Thank you, sir.
Next is Dr. Astosh Kumar Shukla.
Good morning, sir. I'm presenting microlumbar discectomy and the functional outcome. That was just my personal introduction. This is a slide. I'm not presenting something very new because micro disc surgery already completing around 120th birthday, and this is the basic. It started from 1909, and now this is 2024. But among that, 1975 was one of the most important year in the history of Indian spine surgery when Dr. Ramani published his paper on microdiscectomy with 97.6% success rate. This is single center, single surgeon prospective observational study with 6-year follow-up. After ethical approval, the study sample size was determined using SAS 9.2 package. There is no financial support. I will include basic surgical technique and follow-up. In this image, we can see the position. In this surgery, position is very important because we do it in the prone position. First aim to prevent eye injury, and the patient is taken on the bolster with floating abdomen and will prevent all the bony structure to any compression injury. Second thing is the first we will take a pre-op X-ray to determine location. Second is the incision size. Normal incision size around 14 to 16 millimeter. Normal incision size is 14 to 16 millimeter. And third, after dissection, we will take another X-ray to confirm the label. This is concept was introduced by Dr. Ramani. Main thing is laminotomy, not laminectomy. In laminectomy, we remove the lower one third and of the upper lamina and the upper one third of lower lamina with medial one third of the facet. After removing that, now we are drilling the lower one third of the lamina and creating the space. See, now we can the ligamentum flavum here. After bone work, we will remove the lateral one third, lateral part of ligament flavum, not the entire ligament flavum. See. Well, when we will remove the lateral part of ligament flavum, we can see the roots and all the neural structure, our area of interest. Then we will remove the disc. When we are introducing all the disc forceps, this is a very critical step. Correct position of the disc forceps is very important to prevent any neurovascular injury. In my study, 40 to 60 years age group was most common, and the female were most common with this, and the 50% patient was free from all the comorbidity. Left side was more prominent, and the tingling is the most dominant symptom, along with the low back pain and numbness. We operated two type of patients, single level and two level. Among the single level, 5S1 was the most dominant, and the two level, 4, 5, and 5S1 level was the prominent. When I pre-op was the 8.3, and the post 6-year follow-up was 0.65, and the significant decline in the ODI also, and the 6.6% loss of didn't come for follow-up. Average duration of surgery for the single level was 50 minutes and double level for 81 minutes. This is comparison between different study. Summary. Microdystrophy, the gold standard technique for PIVD, short surgical time and then anesthesia time, minimal blood loss. In my study, blood loss was around 28%. That was the average. No minimal bone work, cosmetically better, early mobilization, less infection, and early discharge. In my study, there was no wound complication, no surgical site infection, and the all patient discharge after 24 hours because now due to insurance issue, because insurance company didn't pay if patient will discharge before 24 hours. Take home message: correct patient selection, clinical examination, diagnosis, and discipline, a sound surgical skill are the key to success. These are my references. Thank you.
Uh, Thank you, Ashutosh. I really appreciate. It's not easy job that single center, and you have tried to make it possible that you have collected that 60% data. You make a good video, and more important is you analyze also. You
Yes,
have
sir.
compared this study with three uh, other studies, and you try to analyze. Really appreciate it.
Thank you, sir.
Uh, any patient you need, means your message after 16 patient that okay, this is the things when I supposed to open,
Yes.
means conversion of minimal invasive spine surgery to open surgery.
No, sir. The only one patient undergo the for the pre-operation because he was a 21-year-old man. We operated, he got discharged after 1 day. He was perfectly fine. He was playing cricket. During his play, after 1 month, he was applying some pull shot, something. Suddenly, he developed the uh, prolapse again at same level. Only one patient reoperation. Otherwise, no complication, no surgery, nothing else.
My one suggestion is now you continue the study, you start over endoscopy, make a group of endoscopy and compare both.
Yes,
The
sir.
next NSSA meeting.
Yes, sir. Thank you, sir.
What are your indications for microlumbar discectomy?
PIVD, sir.
That is right, PIVD. Is it a lateral disc prolapse?
uh, indication of surgery for me is only failed medical management for anything. PFAD, any type of disc, if patient symptomatic, go for the medical management. Then if medical management fail, then go for surgery.
Central disc, central disc.
Generally, central disc is significant in the younger people, mainly in congenital canal stenosis and all. So I personally avoid any surgery in very younger people. Just go for the medical management. If medical management fail and patient
No, forget about medical management.
let
Okay, failure of medical management is one of the recognized indications, but
yes,
what
sir.
are your specific indications? Is it a unilateral radiculopathy, bilateral
Unilateral,
radiculopathy,
unilateral,
central disc or lateral disc?
lateral, lateral and radiculopathy, unilateral.
Okay, fine.
Yes, sir. Sir, first we check the MRI, patient name and all. No, you're asking my comments.
think
What about
we are running beyond time.
lateral recess stenosis and neuroforaminal stenosis? How are you going to address?
We do the IDSS, internal decompression spinal stenosis. We will remove the medial one unfair.
Yeah. Thank you, Dr. Ashutosh. Yeah.
Thank you, sir.
Thank you. We appreciate. So, Dr. Abhishek Gautam. If someone has to, a little quick, please, because we are running beyond time. So, who is the one? Like Nilesh Chaudhary? Oh, is there? Just please be here. Like, yeah.
Good morning, everyone. Today I'll be presenting on life-changing post-operative results in tethered cord patients. Tethered cord syndrome has been defined as a spectrum of congenital anomalies resulting in abnormally low position of conus medullaris that may lead to neurological, musculoskeletal, urological, or gastrointestinal abnormalities. Tethered cord syndrome occurs when a spinal cord is abnormally attached within the spinal column, resulting in neurological dysfunction. Aims were to evaluate clinical symptoms and signs, functional outcome after surgery, post-operative complications, and anatomical and technical aspects of tethered cord surgery. Our study was designed as a prospective cohort study conducted in neurosurgery department at Jawaharlal Nehru Medical College, Belgavi. The study spanned from January 21 to December 23. We included 48 patients in total, all diagnosed with symptomatic tethered cord syndrome, and only those who consented for surgical intervention were part of the study. A detailed clinical evaluation and neurological examination was done. Imaging studies involved ultrasound KUB along with MRI brain and spine, with CT whole spine, with 3D VRT and SSD recon. Urodynamic studies were done to assess the bladder function, along with pediatric neurology review and orthopedic review was done. All patients underwent detethering of spinal cord and neural elements along with phylum terminal release as indicated. Follow-up protocol was assessed at 3, 6, and 12 months post-operatively and annually thereafter using clinical examinations, MRI, and ultrasound, and SOS uroflowmetry or urodynamics was done. In the study, we included a total of 48 patients with a gender distribution of 27 females and 21 males. Among these patients, 41 were newly diagnosed while 7 were recurrent cases. These recurrent cases had undergone surgery within the first month of life. Presenting complaints, the main symptoms we saw in our patients were pain, gait, and lower limb abnormalities. Each of the symptoms appeared in about one-third of patients, which highlights how complex the condition and why it is so important to do a thorough assessment when diagnosing. What we also found was that early identification is absolutely critical, especially since most of our patients were newly diagnosed. Radiological evaluations revealed 83.33% had a low conus level, aligning with research that connects low-lying conus medullaris to symptoms of tethered cord syndrome. Additionally, many patients presented with terminal lipomas and tight phylum terminal. Postoperative outcomes had significant improvements in pain and motor function after detethering. These outcomes clearly show that surgery is effective as it greatly reduces the neurological issues caused by tethered cord syndrome. Additionally, over 80% of the patients experience better bowel and bladder function, which highlights the transformatives and improving the quality of life. Only 2 patients had CSF leaks in our study, showing that the risk from the detethering procedure is quite low. 46 patients had no major complication during the follow-up period. Out of 48 patients, there was one mortality, which counts to 2.8% of mortality rate in our study. Clinical implications: early diagnosis is crucial. A comprehensive multidisciplinary assessment is to be done. Surgical detethering is to be done by neurosurgeons. In our study, what we found was the study undergoes the cases operated by non-neurosurgeons often lead to recurrent tethering due to inadequate release of phylum terminal or improper closure of the meningocele or meningomyelocele sac. Such cases result in increased tethering of the nerve roots into the scar tissue, exacerbating the neurological deficits. Therefore, neurosurgeons with specialized training should manage these cases to ensure optimal outcomes and reduce recurrence risks. Post-operative monitoring for optimized outcomes is to be done. Moving on to the anatomical and technical aspects, plan the incision based on each patient's unique anatomy and consider involving a plastic surgeon for closing large defects. Assess the neural placode for its size, shape, and any contents like associated lipomas. Trim dorsally to the posterior rootlet, oversaw, and make sure it fits properly within the spinal canal. Examine the dura, checking its size and for any adhesions to ensure proper exposure of the tethered structures. Carefully dissect under an operating microscope, releasing arachnoid bands, adhesions, and rootlets to achieve full untethering. Pay special attention to rootlets at the sacral levels as they can be difficult to differentiate while arachnoid bands are usually thinner and more transparent. Intraoperative neuromonitoring is highly recommended for a safer surgical process. To conclude, the study highlights the transformative impact of early diagnosis and surgical detethering in tethered cord syndrome, showing significant improvements in motor function, pain, and bladder control. Importantly, recurrent cases were often linked to incomplete surgeries by non-specialist surgeons, specializing the need for experienced neurosurgical intervention. Along with a multidisciplinary approach and careful follow-up are essential to ensure lasting success in tethered cord management. To conclude, here is a case representing MRI spine sagittal view showing low-lying tethered cord along with its extension into the subcutaneous fat. Here is a case of tethering at 2 levels, and one is at the cervicothoracic level and one at the lower end. Along with, in the axial view, we can see the split cord malformation, also known as diastometomyelia. Thank you, sir.
Yeah, thank you, Dr. Abhishek. So your title is very flamboyant, like kind of life-changing. So, okay, I mean, a lot of surgeries that we do are life-changing for many people. So the question here is like, uh, and the conclusions are a little like, see, you won't be accused in the conclusions. Like, I mean, a lot of surgeries are done by non-specialist surgeons.
Yes, sir.
You will say like, I mean, it require expertise rather than accusing someone else. Like, okay,
Okay.
that's not the right thing to, right approach to do. And the third thing is like, so what are the improvements in bladder outcomes and motor outcomes? Like how much improvement has happened? Because did you use any scales to compare like the motor and
So
the
for
bladder
bladder
outcomes?
outcomes, we did uroflowmetry, and along with that, urodynamics was also done in some of the patients. That was decided by the urologist, sir. And along with that, the improvements were shown in the graphs post-operatively.
No, a patient who is completely incontinent when he presented.
Yes, sir.
So what is the chances of him improving his bladder functions like?
Sir, in our study, initially, in some of the patients, some patients were on catheter training, uh, which was done by urologist. So after that, usually at a follow-up of 3 to 6 months, their catheter was removed, and they were telling their parents that their micturition reflex had come back.
That's a miracle.
No,
What we saw, sir.
No, it's because a completely, I mean, completely flaccid bladders. Like, I mean, because the literature shows, I mean, they have not shown much improvement, even
Yes,
in
sir.
our experience too.
Yes, sir.
So I'm kind of would be very much more interested to know if, I mean, how it has changed because you are saying catheter has been removed, but a lot of these patients still will have bladder dysfunctions
Yes, sir.
and they're,
Sorry, sir.
yeah.
Actually, sir, in during when the child is small, most of the cases are new, and most of the patients were below the age of 2 years. or 1 year. So in those patients, they were not being able. These patients don't were are not being able to tell about their urinary
Sure.
reflex.
There is a profile of patients, I mean, who get better. Because a partial deficits are generally tend to improve. A complete deficits are generally doesn't tend to improve even after
Yes,
spinal
sir.
dystrophism.
Yes, sir.
So that sub-analysis should have come. See, the problem is you come up with a study, like, I mean, which has already been done, at least some kind of sub-analysis to show a specific point which has not been so much highlighted in the other studies in the literature would be more interesting to do. Is it?
That
Okay.
I'll be
Yeah.
adding in further
Yeah.
presentations.
Yeah, please do it. Like
Yes,
next
sir.
time,
Yes,
I think, I
yes,
mean,
sir.
good luck for that.
Autonomic disturbances presenting preoperatively is extremely unlikely that they will improve post-op.
Okay.
That's the usual way of, I mean, the usual way things go in the literature, right?
Yes.
Number one. Number two, I would like to ask you a simple question. How will you distinguish phylum terminal during surgery?
During surgery, so phylum terminal looks like a white band-like structure.
So is the nerve root.
That is thicker than the nerve root, sir. It is almost double in.
Sometimes they can be conjoined nerve roots also.
Could be, sir, but
You have to identify, no?
yes, sir.
For you to do deep
Why he was asking, because you said that INM should be used in all the cases.
Yes, sir.
So INM triggered EMG is the method in which you can identify the phylum terminal during the surgery.
Okay, sir.
Thank you so much.
Thank you, sir.
Would like to invite Dr. Nilesh Chaudhary.
Good morning, everyone. I'm presenting on. Okay. My title is the clinical and radiological outcome after the CV junction surgery and validation of the freehand technique for the atlas and atlas lateral mass and the axis pedicle screw placement. The common pathology of the CVJ is the congenital one, and the goal of the treatment is to stabilize the mechanically compromised CVJ. Major approach is the posterior surgical approach. The various techniques has been described, but C1 and C2 fixation is the most preferred one. The presence of the vertebral artery and the large plexus makes it a difficult terrain. Exposure to multiple fluoroscopic shots poses risk to surgeon and the paramedical staff. The safety of freehand technique for C1 is established by the several studies. Recently, there has been interest in the putting a C2 pedicle screws with the freehand technique. Now, among C2 pass pedicle screw has got the maximum stability. And the smaller size of the pedicle in Indian population makes it slightly more complicated. And the question remains that does fluoroscopy is absolutely necessary intraoperatively? Our aims and objective was to study the clinical radiological profile to assess the safety of the freehand technique of the screw placement in the C1 and the C2 and the clinical and radiological outcome. This is the prospective study was conducted in the Department of Neurosurgery from September 2021 to 2024 in a single institute. Patients who underwent posterior fixation for the CVJ disease were included. All the patients underwent the detailed preoperative evaluation, MRI, X-ray, CT scan, and the findings were noted along with the clinical parameters. The clinical outcome was noted as a using the Nurix grade preoperatively and postoperatively at the follow-up of the 6 months. All the patients underwent the preoperative evaluation for the CT and CT angiography and craniometry, and the C1 C2 morphometry was noted. And the craniometry in form of the Chamberlain's line, Macquarie's line, and the ADI was calculated. In this study, free-handed screw placement and fluoroscopy guided screw placement was analyzed. The C1 posterior, the technique of the C1 screw placement, the C1 posterior arch was subperiostally dissected. The screw entry point was defined as being in line with the 2 to 3 millimeter lateral of the center of the C1 lateral mass and was located on the middle of the posterior arch. And for the C2 technique was the trajectory of the C2 pedicle screw was determined under the direct intraoperative visualization using the superior and medial pedicle order. And the patients with having high riding vertebral arteries and the pedicle width less than 5 millimeter were excluded. The analysis of the postoperative scan for the C1 lateral mass, we have used the Gersman and Robin grading, and the grade A was defined as the perfect screw placement, and after grade B, C, D, according to they were extraosseous position. And for C2, we can see in the image that we have the A is the perfect trajectory for the screw, and M is the medial bridge, and B, C, D is the foraminal bridges. Appropriate statistical tests were used. A total 68 cases were analyzed in 3 years. For demography, maximum patients were like in the 14 to 45 years, and male preponderance was found. And according to etiology, the congenital etiology was the common in our study. And vertebral artery, the normal we have found in 53 cases and 14 which was abnormal vertebral arteries. The majority of in our study was posterior fixation was OC2 and followed by 30 cases of the C1C2. For the craniometry, we have analyzed that the significant decrease in the Chamberlain lines and mechanism BI was noted. And Nurix for clinical outcome, we have used the Nurix grading. In this, we have noted that the higher grade patient presented with the higher grades, they had less improvement in post-operative period. Coming the C1 screw placement, we have analyzed total 60 lateral mass was analyzed, and with fluoroscopic guidance was 21, and with the freehand technique, we have done 39. And we have found the 2 breaches in the freehand technique and 2 breaches in the fluoroscopic guidance. They were B and C breaches. For the C2, we have used 50 freehand screw was placed in 50 and fluoroscopic guided was 76 pedicles. And in breach, we have found free in freehand, we have found 5, and in fluoroscopic, we have found 12, which was more in. So these are the some cases of the C2 breaches that grade M medial breach and the lateral breaches, but no clinical deterioration was found in postoperatively. We have also compared our study with the other studies to it was comparable, and we found that it's in our study was it was slightly higher breaches. Yes. 2 vertebral artery injury was noted, and no deficit was found postoperatively. 2 mortality were noted, which was unrelated to the surgical cause. And 7 wound-related complications were also noted. And summarizing, the congenital anomalies were the most common. Majority of the patient had AED followed by the basilar invagination with the left vertebral artery dominance. And positives, preoperative and postoperative Nurix grade were observed at the 6 month of the surgery. And in craniometry analysis, also significant improvement was found. And screw breach was less in freehand technique, which is comparable to the other studies. Finally, concluding, the freehand technique for the C1 and C2 is safer, avoiding unnecessary fluoroscopic exposure. Our incidence of the breach is slightly more as compared to other studies, and still no Indian study has been published specifically focusing on the freehand technique for the C1 and C2.
Thank you, Nilesh. Good thing is good prospective study. Absolutely agree. There is no need of fluoroscopy while putting a C1 and C2 screw. I would be more happy if you have described the novel entry point for freehand technique, because this is the first study, as you said.
Yes, sir.
You have not described a single point on entry point, which is absolute necessary, which
Yes.
is absolutely novel.
Okay.
You just said in C2 you are going between, medial and lateral border.
Yes.
You said that there are so many occipitalized atlas. So in
Yes.
occipitalized atlas, now it become no C1, it become condyle. How will you put freehand technique in condyle?
Yes.
You know,
Yes.
and then you said that there are 60 cases you have
Yes.
put a C1 and C2,
Yes, sir.
you have analyzed, but
Yes,
in
sir.
condyle is different ball game.
Yes.
C2 now it's a different ball game.
Yes.
There is one limitation for that.
Yes.
Otherwise, I really appreciate.
Thanks.
Yeah, it's appreciable in terms of like, okay, your analysis and everything is okay. I think the neurological outcomes and other things should have been even more focused. And second thing, a little longer term follow.
Okay, sir.
And the third thing is like, okay, the freehand technique. Okay, you said your those breaches and other things are a little
Yes.
more than the other things.
Yes.
So the freehand technique is good. I mean, you should know your technique, but
Yes.
the technology has come because any errors here are devastating. So the technology only adds up to the to add more safety to your procedure.
Yes.
So
Yes,
that's
sir.
where the technology role is.
Yes, sir.
A technology doesn't mean that, I mean, you don't know your freehand technique. It's
Yes.
okay.
Yes, sir.
So it's okay. I mean, there are a lot of our centers doesn't have the required, I mean, the technology available in every center. So freehand technique is to be learned. We appreciate doing all these things, but I would still suggest that, okay, if you have technology, please use it.
Yes, sir. Yes.
Thank you so much.
Okay.
Thank you all the participants and yeah.
Thank you, Chairperson sir. So it's very nice. I think you are exhausted almost more than the time, and all the best for all the presenters. Okay, we'll join in Holly. Thank you very much.
Manik? Okay. Good afternoon, everybody. We're in the post-lunch session. So the topic is on minimal invasive spine surgery. Now I request Ravi sir, please chair the session. Dr. Manik Prabhu, please from the Care Hospital, please come and chair the session. Netrajan sir, sir. Savitar sir. Netrajan. Netrajan sir, please come on. Sir.
Good afternoon. We welcome to this important session on minimally invasive surgical spine techniques. Particularly, all the topics are covering on the spondylosis, the commonest problem. Today, MISS has almost replaced the conventional surgical techniques. And we are very happy to welcome all the delegates as well as the presenters. So, I welcome Dr. Maulik Vaja from Vadodara to present his topic on lumbar disc surgery, the transformation from conventional to MISS technique. Welcome.
So, thank you very much. So first of all, I would like to thank my professor and mentor, Dr. Manas Panigrai sir, who arranged this conference and gave us an opportunity to present our work. So today I would like to tell mainly about transformation from conventional technique to MISS technique, mainly for young neurosurgeon, those who are eyeing to heading towards. So nobody learn directly in minimal invasive technique. We have to first understand what is the anatomy. So all of us, we know that it is one of the most common surgery, lumbar disc surgery by a neurosurgeon. Conventional technique is associated with morbidity and mortality, instability. But microdiscectomy was the concept given by the modern neurosurgery father, Dr. Yasser Gill, which involves disc surgery from interlaminar window. So many neurosurgeon keeps on doing open conventional technique, but as you see that advertisement, how the medical field is going forward, everybody is forced to learn minimal invasive technique because it is better and expectations are more from the patient. So I would like to present a case of 38-year male presented with radiculopathy symptom and MRI showing large right paracentral L4 L5 disc prolapse, but facets are looking almost healthy. So we know different option, but at our center we do minimal invasive surgery by keyhole approach with a two-bladed tubular retractor system. It is a quadrant tubular retractor system by Medtronic. In the position we apply bolstered, but Wilson frame are also available, but we are comfortable with bolstered. So after putting patient in general anesthesia in prone position, the level is localized and tubular retractors are introduced over paramedian small incision, and the docking of the tube is done over the lamina at the disc level, and then the self-retaining retractor is applied and the microscope is mobilized into the field. So this is a short video of key surgical step. You can see this is a right paramedian approach. The interlaminar window is exposed by drilling and Carison punch. This is the caudal laminotomy. Once the laminotomy is done, ligamentum flavum is excised. You can see the stretched out nerve root is seen along with the thecal sac. So we have to retract it with gently. Here the root is under direct vision, so we can avoid injury to the root and control our retraction. So Dr. Ramani, Professor Ramani told that you cut the disc like a cake. So you have to cut it with the 11 number knife, and the huge fragmented disc fragments are delivered. You can see the suction is doing minimal retraction with the tip. No much retraction is applied over the neural tissue, and the remnant is delivered with the help of blunt tip probe. So the beauty of minimal invasive surgery is you do ipsilateral decompression as well as underlaminar unipod contralateral foraminotomy also can be done. So bilateral problem can be solved compared to endoscopy techniques where we can manage only unilateral disease. So very small surgical wound around an inch or length. So this is a post-operative comparison of MRI. You can see the disc is completely removed, whereas the facet is completely normal and healthy, which adds and helps maintaining stability on long term. So, and myelotomy is showing complete release. Another case is a 21-year girl presented with cauda equina syndrome and had a bilateral foot weakness. So we did MRI showing a large central disc herniation, but the lower level at alpha S1 also there is a left paracentral disc prolapse. So this case was managed by a single tube retractor and multiple level decompression. This is a standard laminotomy. Ligamentum flavum is exposed, and you can see the gentle retraction of the thecal sac and nerve root is done, and without applying any traction over the dura. So this is the point where maximum dural injury occurs while pulling out the calcified hard fragment, and it can cause injury to the under surface of the dura. So the disc fragment large nucleus is delivered. You can see the specimen, and it is delivered very gently by very minimal retraction applied with the suction tip. Once the decompression is done at the L4, L5 level, similar procedure can be done at the level of L5, S1 with the telescoping of the tube retractors towards the desired level. So the multiple level also can be managed. As compared to endoscopy, you can only manage at single level. A thin lamina is seen which is showing the preservation of the bony posterior column. So this is the small wound, similar single level or two level, the wound length doesn't change. This is the post-operative MRI where we are showing the complete disc removal, whereas the facets are completely preserved. So mainly it is important for young patients where they are having a very long life, and putting an implant is can be a problem in a later life. So the lower level also you can see the paracentral disc is completely removed, whereas facet is completely intact. A myelogram also showing complete release of compression. This is a girl who recovered after 2 months of physiotherapy because she had a foot drop, but it reversed, and a small surgical scar. Similarly, lumbar canal stenosis, we can do multiple level decompression, foraminotomy, laminotomy, and lumbar canal release. All of us, we know what are the advantage as compared to PALD. It is under direct vision, familiar anatomy, and shorter learning curve. But regarding the learning curve, there are challenges because for mainly young neurosurgeon, lack of exposure and experience is there. Non-availability of equipment like retractor, drill, microscope, case selection to begin MIS. So how to cut short these? I would recommend to minimalize the bony resection as much as possible and use microscope or other magnification. This is one example video of a T-leaf surgery where L4, L5 listhesis is there. You can see here we have done open surgery. The screws have been inserted, but the posterior column components are not resected. Rather than interlaminar window is open, the facetectomy is done to introduce the transforaminal cage, T-leaf cage. So once the ligamentum flavum decompression and discectomy is done, from the same small window you can introduce the interbody cage as well. So here you see that the screws are there. So anyone who is starting their surgery or journey toward minimal invasive, they have to start doing open surgery with minimal invasive techniques. So then it will be easy for anyone. So once you master you can do T-leaf as well. From the minimal invasive approach, this is a case of 55-year lady, L4 L5 facetal arthropathy with a synovial cyst, and dynamic X-ray showing instability in pars lysis. So the difference is putting percutaneous screws. No other difference compared to microlumbar discectomy. You can apply a tubular retractor system, and along with that you can insert T-leaf cage. So this is a cosmetic wound after surgery, paramedian incision. So at our center we are not doing surgeries under Yodna. So learning curve is showing that initial 16 to 16 surgery were done with the open technique, followed by 28 surgery from interlaminar window, and later on we have adapted completely minimal invasive approach. So complication rate will be initially higher, but later on as you master your skills, the rates will drop down. Similarly, T-leaf we have done, but here you can see the T-leaf numbers are less. The main reason behind that is the cost of implant. So the implant which comes for T-leaf is a minimal they are costly almost 2 times or 3 times compared to what we use in open technique, and where I use, we do not have any kind of support of Yojana, so we have to do it under payment. So the complication rates are also equivocal. So the take home message is MISS is new normal. Every neurosurgeon must master their skill. Changing technique is not as difficult as it sounds, and path from conventional to MISS can be reduced tactfully. So this is I would like to thank my hospital where I work, and I am supported for all kind of neurosurgery. And last but not the least, I thank my professor. You need someone taller to look up to always, and Dr. Manas is a similar figure for us. Those who have those who have trained under him, they still look. Many times we feel both kar liya, many things we have done, but then we remember Manas sir that what he has achieved, we have not done 5% of that, and we cannot stop ourselves at any point of time. Thank you.
Thank you. Any questions?
Comes from there's one thing two things I would suggest. One is for people to open the tubes up. Right? So you're using the quadrant system.
Yes.
Without opening the tube, the quadrant stays at 22 millimeters. Right? So you'll use the black dilator and put the thing in. The minute you open it up, you've made your incision size, which could be 22 millimeters, now 35 millimeters. In the long term, it does not make a difference. But if you're trying to evolve in MIS, the idea is to lessen the amount of collateral tissue damage that you're doing. So the first thing I would do is if you're doing a single level discectomy, don't open the tube at all. Right. The second thing is start looking at if you can do it to 22, then you start doing at least discectomies and decompressions with 18 or 16. Right. The second thing is you have almost all the instruments of Medtronics, but I didn't see the suction retractor. That is one of
So that we have, but I have used that technique. I have mastered myself that I don't require that suction retractor. Yeah.
And when you show the open T-lip where you're preserving the posterior, the ligament, the one of the concepts in MIS is not the posterior ligament or the interspinous ligament or the supraspinous ligament, it's the muscle. Right? So the minute you strip the multifidus off your lamina and spinous process, you kind of lost the battle in trying to be minimally invasive. Right? So in an open technique, if you want to master minimally invasive surgery, you should be looking at the Wilsey's approach, which is actually what a MIS TLIF uses. We just do the Wilsey's approach through a tube. Right? So if you want to migrate from conventional open TLIF to MIS TLIF, the first step is actually doing a Wilsey paramedian approach rather than reducing the amount of bony resection.
So my message to convey from these is many young neurosurgeons who come out from the institute, they do not learn all kind of technique on day one. So whatever they have seen in the government medical college or wherever they have trained, what type of equipment, where in our Gujarat there are MCH institute where spine surgery were not used to be happen till 5 years back. Now they have started afresh. So those young neurosurgeons who are not exposed for advanced spine surgery in their training, they do not have to hesitate to start doing minimal invasive. Somewhere they have to start doing it by cut shorting the path. That is the message.
If you add the Descendo system, probably you'll be able to decompress the other side, including the foramen with endoscope itself. You won't need to have you do any bone resection at all. Descendo system is better. Thank you.
Thank you, sir. Thank you.
We call upon Dr. Nimesh Patel from Vadodara again on minimally invasive spine surgery, technical nuances and spectrum of indications. Welcome.
Good afternoon, everyone. Thank you, organizing committee, for giving me this opportunity. As we know, the concept is very well known for everyone who is doing spine surgery and especially the minimal invasive spine surgery. Um, it is mainly for the less invasiveness of the entry point and the muscle, and that is the entire purpose rather than actually the size of incision, as we all know. Um, as you reduce the uh, muscle crushing, especially, and the muscle stripping, that is the major advantage of minimal invasive surgery compared to the open surgery. So, advantages are very well known to all of us. It reduces the muscle damage, less blood loss during surgery, reduce risk of infection and post-operative pain, especially because there is a reduction in the dissection. Faster recovery from the surgery, uh, decrease the pain and requirement of the pain management post-surgery, and obviously better cosmetic result, which is actually the collateral advantage. And the main advantage, as we all know, it reduces the multifidus muscle and the axial muscle stripping. So there are three ways of injuries, especially when we do the open surgery: direct injury, crush, and denervation. So as we go and master further more and more with the minimal invasive surgery, we reduces all these three particular component, which actually causes a lot of damage, and it adds on into the post-operative pain. As we go with the minimal invasive, tackling not only the standard paracentral central disc, but far lateral disc is also yeah, is much better. I regularly use quadrant set, and this is my entire assembly. I use 22 mm, 18, and expandable all. So marking is one of the most important in MIS, especially you look to the pre-operative scans and even the X-ray, especially the AP X-ray. But general consensus is that when you're going for the discectomy, you take at least a centimeter away from the midline, which you localize on the X-ray. When you are thinking for the T-leaf surgery and when you have to put a cage, you basically dock your tube over the facet, and that's why you take a couple of centimeter lateral from the midline. And for the screws, percutaneous screws, you basically take around 3 centimeter from lateral, but it still varies as you evaluate your preoperative X-ray. So these are the initial easy cases when you start to practice with the minimal invasive surgery. It is the large extruded disc patient, young patient with grade 3 weakness, and this is the pre-surgical marking. You can see you always look for the dead epi X-ray, check for the lamina, and the main important part of MIS is docking the tube. So you select the lower half of the lamina. I generally put the incision, open the fascia, and use a finger dissection, especially to put a tube. So that is how I am more comfortable. So once I do the finger dilatation, I introduce the tube. So this is some of the initial case where I use the 22 mm. I'm not able to fast forward here. Can I? So that's the lamina. The lower cursor is not coming. Cursor is not coming. Give it a full size. Have to fast forward the video. The cursor is supposed to come here. Well, it's unfortunate. I can't fast forward the video basically. This is the 22 tube. You create a small window, do a small laminotomy, go medially, open the ligamentum flavum, dissect the dura, and then you will be directly over the disc. This is the extruded disc, so you can see the tube and the extruded fragment. And that's the final picture. You can see nice relaxed root. As you master yourself for the 22 basically you go for the 18 because the entire purpose is to reduce the muscle stretching. And this is the 18 tube which I'm doing for quite some time. As you master with the 18 you actually can go further with the 16 and probably 14 which is almost like an endoscopic dilatation. So as I'm sorry. That cursor is not coming fast forward. Make a full. Okay. Hmm? Yeah.
another display उधर चली गई.
Go back to the previous episodes. Unfortunately, I can't fast forward because a lot of videos. So as you master yourself, you go for the 18 and then probably 16 tubes, and that reduces the muscle stretching. You regularly use for the, in fact, recurrent disc herniations are better indications because if it is done previously open, because you actually can navigate the anatomy better with the tube rather than going through the same incision. So you basically go a bit more lateral. Two-level decompression, we regularly do two-level decompression, and you significantly reduces the incision. You just navigate your tube with your last dilator for upper and lower level, and that really reduces the muscle stripping also, especially what you do in open surgery, and you navigate the instrument accordingly. So two-level decompression is very well done. In fact, we can go for the three-level also. You might have to increase the size and probably you can perform that. Over the top decompression, it is one of the major advantages, especially when you are doing open surgery. You basically have a difficulty in opposite side decompression. In fact, you can remove the disc opposite side with the same tube, especially when you have a bilateral disc herniation and bilateral foraminal stenosis. That is one of the major advantages, especially compared to the open, because in open you do have to strip muscles on both the side, while with the tube you just have to dock it in a correct way. And once you do the ipsilateral thing, you basically tilt the tube to the opposite side and you will have a nice angle. It is very useful for the bilateral disc on the opposite side also. So once you dissect, you can see the opposite side, that's a disc uh, prolapse, and through the same tube you can actually take out that large fragment, which was very difficult to get it through the same side. So that's the disc, and you create a small window. Unfortunately, I can't fast forward, so I'll just go quickly. Uh, T-leaf, very well known. It is one of the major, MIS has created definitely a major advantage, especially for the T-leaf. We all know the nuances, dead AP view, check for the pedicle. Once you are at the mid of pedicle with your Jamshedi needle, you're basically entering into the body from the pedicle. So learn your anatomy properly, understand the percutaneous techniques of the fixation, and for tea leaf, I generally use expandable tubes, but I try to avoid expanding the tubes. I just keep it because sometime while putting a cage, you might have a difficulty, you might not be able to get that angle. And for that reason only, for a safety measures, you try to use. But as long as possible, you basically avoid expanding the tube because then the entire concept of minimal invasiveness will go away. So once you do the lower end laminectomy, you reach up to the lateral angle, you will actually remove the entire facet. And once you remove the inferior facet of the superior vertebra, you will be exposed to the superior facet, which you undercut, and then you will create a space which will reduce the traction on the nerve. Unfortunately, I have not been able to fast forward, so I'll just go quickly. Once you do a facetectomy, the rest of the thing is standard, same. And prepare the end plate, take a size, put a screw. Previously, when I started a few years back, I used to put screws on one side and then decompression and then the screws on the other side. Now, most of the time, we put all the four wires first and then go with the standard way. So biggest advantage of MIS is more into the fixation. Um, and that's the fusion long term. Obtuse angle, it is very, very useful. You carefully place your patient, especially you keep the distance in the front because you literally have to angle your CM, especially when your alpha S1 listhesis angle is too obtuse. So such small points are very important, especially when you are doing a MIS fiction. The same patient, and you actually can get a better result. Grade 2 listhesis. The technical part in get when you have to reduce listhesis in MIS, you basically put screws all the way down into the body. So you change your polyaxial action into the monoaxial, and once you start putting the rod, it will automatically reduce. So you actually can reduce optimum listhesis even in grade 2 and grade 3. So same patient, a good reduction. Grade 2 listhesis with angle, you can very well achieve with the MIS techniques. Two-level MIS TLIF, it is very well. There is always a little controversy beyond two-level, whether to think for MIS or to go for open, but up to two-level, it's very well done. And it is really a blessing for patient because if you really go for open technique, you literally have to strip off the muscle. Choose your cage very carefully. This is one of my complication. Unfortunately, I had, realized later on that the size of cage was smaller and then there was a migration, so we had to revise the case. Posterior cervical foraminotomy, blessing, two-level foraminotomy I regularly do. Don't put a hamilemectomy retractor, and that's the same patient. Both the level, we did a foramin. The standard procedure of foraminotomy is same, but if you have two-level foraminotomy, you literally use the same tube. You just change the angle with the final dilator, and you are avoiding the muscle injury. One of the case which is odontoid fracture, I did anterior odontic, odontoid screw. Previously, it was a standard open. Nothing gross different in MIS except the skin size incision is lesser compared to the open surgery. So I put a very small incision and blunt dissection. Use a finger, then use a dissector. Localize from C4, dissect up to the C2 lower end, and then you use your retractors initially, and then I put a tube actually. So this is the pre-op. You can see there is a gap, and that's the follow-up case with a nice reduction in fusion. I think balloon kyphoplasty and vertebroplasty, very well known percutaneous techniques. Previously, now there is always a little controversy, but previously I was using bilateral pedicle access, but there are enough evidence now you don't have to go for bilateral. you can just use a unilateral pedicle and that will suffice the vertebroplasty. A hybrid, when you feel that your vertebroplasty is not going to be good enough and there is a little kyphotic component, it's always better to use a percutaneous pedicle screw. So this has revolutionized the technique, especially compared to the open. You literally are avoiding complete open dissection. Two-level, I'm sorry, the vertebral fracture, traumatic fracture, no need of laminectomy, as we all know, if there is no neurological deficit, just a percutaneous pedicle screw and fixation. This is one interesting case. I have actually used tubes and dilatation, and then eventually I converted into the open in the sense same incision, same dilatation, but I have put two retractors because it was actually a hematoma. And we pre-operatively evaluated with all the angio, it was negative. Later on, we came to know that the patient came post-pregnancy, and this was induced with the um, spinal needle injury. Actually, the anesthetist tried to give it on the upper area. So all this we can tackle with the MIS. Tumors, very well known. Now, as we grow further, we try to operate all intradural extramedullary tumors with the MIS technique. Here, expandable tubes are very useful because it is next to impossible to do any closure and everything with the standard 22 tube. So it is better you use an expandable tube.
Please conclude.
Yeah. So MIS is the present and future, and it is going to stay. There are multiple indications and pathology, and it keeps on expanding. People have started doing even C1, C2 fixation also with the MIS technique. There is obviously an initial learning curve, but I believe as a neurospine surgeon, we have to learn if we really have to compete with our orthospine colleagues. Faster recovery and cosmetic results are always a collateral advantage. Thank you.
Any questions? Thank you, Dr. Dimesh. I would like to call upon Dr. Amitabh Das from Kolkata to share his experience with microdiscectomy with X-tube, technical tips and pearls.
Good afternoon, Chairperson sirs. Good afternoon, audience. I'll be discussing about tubular lumbar microdiscectomy tips and tricks. Low back pain is a very common complaint which we have to deal with in our day-to-day life. And lumbar disc prolapse is one of the important causes of low back pain. Although conventional lumbar discectomy has been till now considered as the gold standard procedure, minimally invasive techniques are also coming up. And the uniqueness of minimally invasive techniques is that they use a paraspinal muscle space approach, preserving most of the posterior spinal ligaments and approaching the neural structures from a lateral aspect. In the preoperative setting, MRI is considered as a gold standard to look for the site of the disc prolapse, presence of any free fragments, the morphology of the disc, whether hard or soft, and multiple level involvement. Along with that, a dynamic X-ray gives information about instability. In the preoperative planning, I consider consent as the important portion or important part for discussing with the patient and to know what their expectations are and also to tell them what the reality is about micro surgery and also to discuss about the expected complications or probable complications which may come during this procedure. The OT should be informed about the special tubular retractors and the special instruments, including microscope and the drills. I use a Medtronic's X-tube system, Medtronic system, and where the serial dilators, the several diameter of the tubes are used with different length size and different types of dissectors, bayoneted upcut, Kerrison punch, bayoneted pituitary rongers, like that. And definitely for the fixing the tube, in proper place, we need a side attachment as well. Now, coming to patient positioning. This can be done either on a Wilson frame in a prone position of the patient or with bolsters, or it can also be done in a knee chest position. In the surgical technique part, I must say that I use general anesthesia for the surgery, and here I stand on the side of the pathology like most of the surgeons. The midline is marked first, then the incision is planned under C-arm guidance. I use a 1.5 centimeter paramedian incision, and the incision after checking on C-arm is carried down up to the fascial level. Then I put a sharp guide wire in such a way that if a line is drawn from the anterior portion of the guide wire, it cuts through the center of the disc. Then I put the initial dilator and wound it to palpate the anatomical landmarks. Then serial dilators are placed, maintaining a downward pressure, and finally appropriate size tubular retractor is placed and fixed to the tubule with a side attachment. Then the microscope is brought into the field, and the muscles that are protruding or the soft tissues that are protruding inside the tubular retractor is removed, and the laminotomy is performed with a drill. Initially I use a cutting drill, and once I reach the inner table, I use a diamond drill. The exposure should be done up to the superior insertion of ligamentum flavum. Then the exposure of the root. The flavum is first dissected off the dura with a ballpoint probe, and then it is gradually resected. This is a small edited video to show how actually I remove the disc. This is a root, you can see, and if there is any epidural bleeding at this part, you can control it either with a cotton or a bipolar cautery, and once the extruded disc is identified, it is removed and checked for any other free fragments as well as adequacy of the decompression in the area with a ballpoint probe. Now, coming to the complications and how to prevent them. CSF leak is still considered as one of the important complications of any type of lumbar spine surgery. The incidence varies between 7 to 10%. Although there is no difference has been found between the tubular discectomy and conventional discectomy, but I must say that a CSF leak in a tubular discectomy rarely forms CSF fistula. Because of this muscle space approach, there is little dead space left once you remove the tube. So rarely CSF comes out of the wound. Now, how to avoid? This is mainly for the young neurosurgeons who are thinking of starting tubular discectomy. The incision should be made around 1.5 centimeter paramedian, not too much laterally, not too much medially, and the tube should not be angulated too much for the initial cases. Otherwise, you will land up into either outside the canal or into the thecal sac. And definitely for the initial cases, use larger tubes. I started with 22 mm tube. Later on, I with increasing experience, now I am using either 16 or 18 mm tube. The entire operative field should come inside the tube. And the cutting drill, if you use, definitely should be changed before inner cortex, once the inner cortex is reached. And the flavum should always be freed from the underlying dura with a dissector before resecting it. And definitely I use 90-degree Cadison punch for the medial and inferior resections of the ligamentum flavum, and 40-degree can be used for the lateral and superior part. Any form of anatomy should be identified properly before doing any form of discectomy. Now, if there is a CSF leak, what will you do? If there is a small leak, tight wound closure is enough. But if there is a large leak, with prolapse of rootlet, you can change to larger tubes, or if it becomes very difficult to manage, especially in the initial cases, just remove the tube, increase the incision, make it open surgery, repair it under microscopic guidance. Second important, although rare but serious complication is the nerve root injury because it produces permanent neurodeficit. The incidence is around 0 to 3%. And to prevent a nerve root injury, the familiarity with the anatomy is very important, and for that, preoperative evaluation of the MRI is very essential. And clear identification of the root during surgery is needed before doing the discectomy. For large PIVDs, when it is difficult to retract the root or retract the root medially, you can increase the exposure laterally by doing a partial medial facetectomy and partial resection of the parts. And similarly, in recurrent discs also, where you encounter too much of adhesion, you increase the exposure superiorly and laterally to get a virgin field to start your dissection. Wound infection is extremely rare. I have not experienced a single case of wound infection in my series, and also this is because of the minimal dead space. I use a single dose of ceftriaxone at induction and no postoperative antibiotics, but a thorough lavage is given after removal of the tube. Post-op hematoma is a rare painful complication, often responds to analgesics, and after removal of the tube, coagulate any bleeding point if you can identify. And then comes the recurrent disc herniation. The incidence is around 2 to 11%, although again it is not different from the conventional discectomy. If you consider reoperation, you can use tubes again. To prevent recurrent disc herniation during primary surgery, remove all free fragments thoroughly, pass the ball probe, check whether there is any free fragment left behind, and lavage the disc space to look for any loose fragment. In the post-operative management, early mobilization, I always advise, and I usually discharge my patients within 24 hours and follow them up after 7 to 10 days. Just to a quick look at the what the literature says, when tubular microdiscectomy is compared with open discectomy, Clark et al. Has found no significant difference in safety profile, recurrence, length of surgery, estimated blood loss and outcomes between the two groups. However, they have found less analgesic usage in the tubular group and also the tubular group was more cost effective. On the other hand, Zhang et al. Again compared these two groups and they have found that in Oswestry Disability Index, microdiscectomy, rather tubular microdiscectomy fared better than conventional discectomies. And finally, Barber et al. Compared endoscopic discectomy with open and tubular discectomies and they have concluded that the outcomes in tubular and open groups are largely equivalent, although endoscopic discectomy fared better as compared to open discectomy, but they have suggested further studies to evaluate this. So, essentially, tubular discectomy and open conventional discectomy both are essentially same and comparable. So, whether to go for tubular microdiscectomy or not, the choice is definitely of yours and your patients. But to go for further increase in your micro surgery in spine or minimally invasive surgery in spine, this is considered as a basic step to go forward. Thank you.
Any questions?
in the intraoperatively. How
Yeah,
important is
I don't
for
get you.
how important is for you to detect these complication in your intraoperatively when you are doing a surgery, like a dural tear damage you are having. So how important it is for you to detect it in
Yes, it is very important. to detect your complication in the intraoperative period, because if you can detect it and if you can manage it in the same sitting with the tube in situ, manage it there. If you cannot manage it with the tube in situ, just remove it. Don't think anything else. Open the incision, increase the incision, and repair whatever complication has you done. Okay, because that is better to detect your complication by yourself rather than making a complication and later on it is detected by some other surgeons.
Do you think any kind of a device would help you to detect this kind of a means this kind of a complication?
I think microscope is enough to detect all these complications. Yes, sir.
Yeah, we can create some kind of a but
If there is a leak and if you cannot detect it introp, that means it is a very minimal leak. It is a very minimal leak. Exactly. Recurrent disc.
Moving on.
Thank you.
I request Dr. Vinu Gopal from Kottayam to present his interlaminar fenestration for spine pathologies, a novel approach. Request to speaker is please adhere to the time limits.
Yeah, sure. So good afternoon, all. Respected chairpersons, at the outset, I take this opportunity to thank Dr. Manas Panigrahi and Dr. Savitar for the opportunity and congratulate them for the excellent conductance of the conference. So this talk is regarding an alternative approach to multi-segment intraspinal space-occupying lesion, which I call a unilateral multi-level interlaminar fenestration. So as you all know, conventional laminectomy for long segment tumors result in instability of the vertebral column, leading to progressive spinal deformities. Even lesser invasive procedures like hemilaminectomies and osteoblastic laminotomies also interfere with spinal stability to a certain extent. So by using a high-end microscope, by angulating it cranially and caudally, we could get a comparable vision as compared to an endoscope, which is the procedure of choice nowadays. I don't know how much relevant this talk will be in the era of endoscopy. So, as you all know, the posterior tension band helps in maintaining the vertebral column stability, and it's a unique structure composing of the articular joints, paraspinal muscles, and the ligaments. And removing the posterior tension band, posterior complex, can affect the motion and load bearing characteristics of the adjacent segment, leading to instability of the adjacent segment. So we thought of doing this technique, interlaminar fenestration, where the bone removal is minimal and we will be sparing the vertebral arches and ligaments, and the forces can act in the normal way, can prevent instability in future. And we will be preserving a part of bone near the transverse process and the pedicle area also, and we can angulate the microscope cranially and caudally to reach these blind areas. So it almost looks like a multiple spinal keyhole surgery, and that can be done from one side itself. And importance, the preserving the junction of the lamina and pedicle is particularly important because many of the muscles and ligaments are attached at this point. That will help in maintaining the stability also. And this interlaminar fenestration can be done at various levels: cervical, thoracic, and the lumbar. And also, if you have a good drill, also we can drill the laminar area and raise a spinoperiosteal flap also, so that we can achieve a bilateral decompression amounting to a laminectomy also. So this approach was used for degenerative conditions, so multiple level degenerative spine diseases, also for evacuation of spinal hematomas. So I was thinking, why can't it can be done for a multi-level intraspinal tumors? This is my experience, limited experience of this for lumbar canal stenosis, for evacuation of spinal hematomas, long subsequent tumors, and ventral spinal meningiomas. I had few complications like CSF leak and a transient weakness which improved later. So I will demonstrate it by a representative case. This patient, 45-year-old manual laborer, presented with gradual onset of backache and a pain, radiating pain right down the right lower limb, and he had multiple element findings with an intact bowel and bladder functions. So this is my MRI picture showing a long segment tumor, and you can also see the posterior vertebral body scalloping also. So sorry for not giving the videos. I have only the picture. So you can see that the midline is preserved. There are multiple fenestrations, and the area of the pedicle and transverse process is preserved, and multiple dural openings are made, and tumor is decompressed, and the dura can be closed with the help of a Liga clip, or even can use a tissue or tissue glue for covering the dura. You can reach the blind areas by tilting the microscope cranially and caudally. So in the immediate postoperative period, patient has decreased power of the right lower limb, which improved later, and the dynamic X-ray showed there was no instability. And you can also see the CT showing the interlaminar fenestration. This is the dynamic X-ray showing that there is no instability. So to conclude, this multi-level interlaminar fenestration is a useful neurosurgeon's armamentarium for removal of long segment intraspinal tumors, and it retains the functional stability, eliminates the need for fixation, and decreases the hospital stay and cost. Also, it is relatively safe with the aid of an operating microscope. We have published this in Journal of Spinal Surgery as a technical note. Time permits, please go through. Thank you.
Thank you, Dr. Binu. Is it very safe for intradural tumor in the cervical spine, particularly when you have to
I have not,
move the cord?
yeah, I have not
Lumbar
done,
is okay, caudal is okay.
I have not done any case like that. It will be difficult. I just want to present this as an alternative approach in the era of endoscopy. That's all. Nothing. This is still we will have to do that. I am just sharing my experience. We'll do that. Very little only for tumors. It was done for degenerative conditions. There is no study like that. Yeah. There is some Korean and Japanese studies, but the long-term follow-up they have not given.
Thank you, Dr.
Yeah,
Binu.
please.
Do you use intraoperative neuro monitoring or
Something like that.
Yeah, I am
What
from
could
a
be the reason of neurodeficit in your case?
well, it should be done. Intraoperative neuromonitoring should be done, but this case, the patient was very poor. I am from a government hospital, so we are not able to afford that. I have not done that. Anyway, patient improved post-operatively. So,
Thank you.
yeah, thank you.
Next, we call Dr. Abhay Kumar from Mumbai. Talk on the complications in MIS TLF procedure and management.
Respected chairpersons, colleagues, good afternoon. Firstly, let me thank Dr. Manas and Savitar for inviting me. The topic given to me is the complications in MIS TLF. As we all know, MIS TLF is the most commonest minimally invasive fusion procedures done now. This is what we try to achieve radiologically. What we try to do is in the procedure is, depending upon the case, unilateral or bilateral facetectomy, plus or minus bilateral, decompress both traversing and exiting nerve root. If you want to do an ideal TF, these are all good disc preparation, good size, one or two interbody case insertion, maintain the normal lumbar lordosis, and good pedicle screw placement. That's what an ideal. And what we try to achieve is this one at the end of either 6 months or the 1 year. This is what try to achieve good fusion with good cage in right place and screws in right place. Now, what are the complications? Basically, they are classified into early perioperative complications and late perioperative complications. Apart from the general complications, which includes infection, wound site infection, lung issues, neurological injury, incidental duratomies, these are all the early. The late are basically implant failure related problems, which can get if there's adequate fusion has not happened, pseudoarthrosis, implant loosening, cage subsident, and adjacent segment disease. When you go through the literature, these are the commonest complication we need to know of. The least reported is the radiculitis, which is the most commonest complication we come across in MIS TLIF, dural tear, discitis, graft extrusion, gauge subsidence, screw malposition, and neurodeficit. So even if you see the literature, this is one of the articles which had come up with a systematic review of about 31 articles. Among all the complications, they had reported radiculitis, cruel malposition, and incidental duratomy as the commonest complication. Another paper, which is a single study, which are more than 500 cases. Again, they had mentioned as a duratomy infection, and next is the cage extrusion as the commonest side effects. So let me share my experiences with you. First is the radiculitis. Risk is around 10%. This is the most commonest complication which happens in MIS TLIF. Why exactly this happens? It's because of you injured the nerve during the procedure. Prolonged retraction of the nerve compared to when you do a discectomy or a decompression, retraction of the nerve is significantly more when you do a MIS TLIF, because you're operating in this V of the exiting and the traversing nerve root. You have to retract to do a good case, because you have to prepare the disc well. So you will take a little more time. You will have to retract the nerves, take it more time. You put the trail inside multiple times, then put the cage size, and cage size should be adequate. Sometimes the cage size is bigger than thing. It doesn't go inside the thing. So the retraction of the nerve is significant in a case of MIS TLIF, and that's one of the commonest causes. It produces significant inflammation and causes radiculitis. Patient complain for weeks together with the pain at that site. Second combination is inadequate decompression. When, in an exuberance of putting a proper screws and proper cage, you might leave a disc fragment there, and sometimes the bone chips, what you try to fill it inside, it will go outside and lie in the foramen, and they come with a pain as well. That's one of the commonest cause of radiculitis. Early case dissolvement, cautery, too much cautery, inadequate hemostasis as well. Even the blood there can cause inflammation and cause radiculitis in this patient. I don't have experience of the BMP, but literature did say that use of BMP has increased risk of radiculitis in this patient. Early infection and contralateral leg pain. You put a graft on this side, you graft it not properly placed, and the opposite side is not decompressed well. The opposite side foramen gets narrowed, and they come back with the pain on the opposite side. So these are the commonest reasons why the radiculite. So let me show you one example of this nerve injury, what happened. See here, while doing, I've caught the nerve here. While trying to ligament, I've caught the nerve. Before I could cut it, I would have realized that I've caught the nerve with this thing, but I didn't cut it. And this is what you see after. So the nerve is damaged. It is not totally cut. There's a partially damaged thing. So this patient had a significant pain. He didn't have any deficit, but significant pain post-op for weeks together, yet complaining of pain. No numbness, no weakness, but definitely pain. So these kind of injuries can cause significant problems. So we need to be very careful about them. Yeah. So next thing is durotomy. There was a lot of discussions about the durotomy. Durotomy is the second most commonest complication in an MIST. The risk is around 3 to 8%, especially more in a revision cases when there is tight stenosis, there's calcified disc and the ligamentum, improper technique of our excision of the ligamentum, and when you're basically drilling the base of this thing, if you want to access the opposite side exiting nerve root, you have to drill the base of the spinous process. As you are drilling, can cause a dural tear as well. As even Dr. Amit Das had shown I think the proper technique, what our seniors have always thought it is to separate the ligament, either using a ball probe or a dissector, separate the disc from the dura well, and then use the Carrison punches. Either you can use a 90-degree or 45-degree, whatever is this thing, and covering that dura with a patty. That's an ideal technique done, followed by everyone. If you follow that up, chances of durotomy are much less. How do you treat it on the table when you get a dural tear? Based upon the literature and my experience, I put this chart here. If it is a small one, basically classified into a small one. If it is a small one, if it is repairable, put a clip. This is an MIS, it's not in an open. You put a staple there, use a muzzle patch. Even if you don't use TCL also, it's fine. Even just clip it and put a muzzle patch, you're fine. If it is not repairable, the edges are very ragged, you cannot bring it forward together. If it is not repairable, just put a muzzle patch there and TCL. Definitely the chances of you developing pseudomeningocele or a CSF leak are much less. In a larger dural tears, if it is repairable, if the edges are coming in, put the clip, staples there, or if suturing, if it is possible, suture it, put a muzzle patch. Even if you have repaired, if you put the clip well, even a dura patch will not require a muzzle patch and a TCL. If it is not repairable, then obviously you have to take in 3 layers, muzzle patch plus dural patch and a TCL. This is a standard algorithm which is followed. I'll show you with some cases. This is a patient who had a very small leak. You can see there's a very small leak. Just fast forward for the lack of time. So you can see I couldn't put the clip. I was trying to put the clip there. I couldn't clip it. I just abandoned. I didn't put the clip at all. I just took a muzzle patch from the surrounding there. You can see that I just took a muzzle patch and placed the muzzle patch, and I didn't use a TCL at all. This patient didn't come back with any post-op problems at all. Okay, so that's about a small leak. So what happens if there is a bigger? Am I showing the same one? Yeah, sorry. Yeah, so if there is a little bit bigger leak, look here, this patient. See, there's a leak, but the arachnoid is still intact. Most of the place arachnoid is done. At the edges can be seen very well. Then you put the staples like this. Just put the staples, put a muzzle patch. Even if you don't use TCL also, that will seal off. Just put a muzzle patch over it and you're done. So what happens if there is a bigger one? Like for example, this one where already you can see there's a collapse of the nerve roots there. So bigger leak, but again, it's repairable. The dural edges can be seen. Put the staples there, apply the staples. I use some Surgicel over it. Again, put a muzzle patch. Because it was a very long thing, I put it in 3 layers. That's a muzzle patch there, and then dura patch, and seal it out. So that's for a longer one. Now see this one. It's a bigger one where the whole thing is stone. So you cannot suture it at all. Either you cannot suture it, you'll have to convert it into an open. So what I did in this patient is just took a muzzle patch, placed the muzzle patch over it all around, didn't suture it at all, put him on a bed rest for about 48 hours, put the seal there, and patient didn't had any problem. So all of our experience, all who have done minimal invasive for more than 10 years, we are experienced because of this tubular retractor being potentially the cavity is quite like this is a universal now. Everyone knows by now that the chances of they having problem is much less. So I don't think we should worry about this too much. Okay. Next is the discitis. The second most complication is the discitis. The risk is around 3.7%. Commonest, as you know, patients with diabetes, obese patient. This high risk of suspicion should be there when a patient comes back to you after 4 to 6 weeks, severe back pain. I had experienced 3 patients with fungal discitis. So I just wanted to share patient. This is a patient who had a T-leaf, came back after the severe pain. We did a CT guided biopsy. It was grown Candida parasitosis. There's 2 other cases who are shown aspergillosis as well. So you have to always biopsy these patients. If they come back, better do a biopsy before you starting this. So we don't know whether you're dealing with a bacterial infection or a fungal infection. So just to share my experience, always biopsy this patient. So next complication is a intra-care migration. It can be early or late. The risk is around 1-2%. This is one of my cases. You can see this is immediate post-op. 3 months later, the graft has come out. You can see just there, it has come out. But this patient is totally asymptomatic. So I'm just observing this patient, not done anything. There's another patient of mine. Patient after 3 months, the graft has totally got rotated and has come out. Why is this happen? Posterior located cages and unassigned cages are prone to form. That is, your procedure was not correct. You have not done the disc preparation properly. You have not put the cages well ahead. So important to avoid placing the cage. Always important, avoid placing cage. The center of the cage shouldn't be beyond the center of the disc center. And always use a larger cage size than the trial. Use a trial compared to the pre-op X-ray. Use a larger one. This thing. So stop me if I'm taking more time. So I have the other problems, pedicle screw malposition. These are all my complications, screw pull out of more than 400 cases by now. And here is a patient with the cage also has come out, plus the screws are also gone loosened out. This after 6 months of surgery, we had to revise it. Here's a patient with a rod breakage. You can see this is immediate post-op. The rod has broken here. I'm sure Sudhir will tell us about the sagittal balance. These are the problems when you are not correct the sagittal balance. If you assess, not assess, these are the problems which happens. So we need to adhere to the principles of screw placement is when we are doing through the fluoroscopy itself, we knew all these 3 points. All these 3 points. With the advent of all the fluoroscopy, we have forgotten this, but this principle has to be followed even now. And now, with the advent of all image guidance, which is possible, all this can be avoided with the image guidance now, placing the screw like this. And these are, with my, I did a small study to find out once I moved on from C-arm to O-arm, about 150 cases. I saw definitely the screw, the pedicle perforation rate from 9.8% had come down to 1%. So if you have the technology, please adopt it. Yeah. So I won't go to the detail in this. I'll stop this. Thank you very much.
Any questions?
Yeah.
Basement where it can impinge on the nerve root.
Yeah.
Commonly, if you see the Indian cages, though they call it bullet shaped, they're not actually bullet shaped. They don't
Yeah.
have that conical thing. So it doesn't go into the disc space and progressively enlarge the disc space as it goes in.
Yeah. Yeah.
So most of the time, you will see that it's either injuring the end plates, or if you put a smaller cage, once it goes in, it's inadequate.
Yeah.
So how do you
So
tackle
Rakshit,
this?
what do you do? See, the cage you'll be putting, after putting the cage in this position, try to hit it to bring it in the
No,
center position as
that
well.
is
Yeah.
for the banana shaped
But
cages.
yeah,
I'm talking about the P-lift cages or the
even
bullet
P-leaf
shaped
cages as well. You can hit it in such a way that it comes in the stand. If it is in the center, like in the center, and it is not this way, there's chances of always the opposite side, this thing will be there. If you put it all the way center and rotate it a little bit, it will produce.
I was suggesting to these implant people the way they make the endoscopic cages. If you see, it's very conical in front. So it goes into the disc space and progressively enlarges if they can do something like that.
Yeah. Or you can use both 2 cages on either side. You can use the bilateral facetectomy and do this.
Right. Thank you.
Yes.
Question. That Liger clip you used,
Yeah.
what size?
There are 3 different sizes, small, medium, depending upon the thing, how much you can, this thing, because of the size of the dural tear, you can use it. I use medium size. Most of the time it's medium.
Advice preparation of nerve root because numbers, there are n number of roots you don't you
Yeah.
you apply the margins.
Yes.
You don't see whether any root has perforated.
Correct. If it is protruded out, just put a patty and try to push it inside with the suction slowly. If not, increase the size of the durotomy. Increase the size of the durator. Don't hesitate to increase the size of the durator. Then you can push the whole nerves, everything inside, then place a patty over it, and slowly assistant can just keep a suction over the patty and you place on putting the clip. Use a tooth Bennett forceps on one hand and put the clips and keep coming down like that. Yeah.
Thank you, Dr. Abhaya.
Yeah.
We're already running 10 minutes late. You can take it later.
Yeah. Thank you. Thank you very much.
Thank you, sir. Thank you very much. Next, we call Dr. Anil Kumar Sharma from Raipur. Huh? Dr. Rakshit Srinivas from Bengaluru on MISS in infections.
Good afternoon, respected chairpersons and my dear friends. At the outset, I would like to thank Dr. Manas and Dr. Savitra for giving me this opportunity. My topic for today is MIS in disc. This is not moving. Sir? Yeah. So my topic for today is MIS in discitis. I'll cover it under these following subheadings. So discitis is basically an infective pathology involving the disc space when it's called as discitis. When it involves the disc space, end plate, and the vertebral body, it's called as spondylodiscitis. And when it involves the vertebral body, it's called as vertebral osteomyelitis. And if the infection goes posteriorly into the spinal canal, it is called as epidural abscess. And when it proceeds laterally, it's called as paraspinal abscess. The pathophysiology is basically based on the arterial supply from the segmental, interosseous, and the capillaries supplying the vertebral body and the end plates. The disc in an adult is an avascular structure. The commonest etiology is spinal procedures and spinal surgeries and procedures which have increased in number in the present day. The hematogenous spread can occur from infections in any part of the body, be it urinary tract infection, dental caries, or subacute endocarditis. Contiguous spread is very rare. The bacterial infections is the commonest cause of discitis, followed by tubercular, and fungal and brucellosis are rare causes. We have just seen 2 cases presented by Dr. Abhay sir. The commonest pathogen isolated is Staphylococcus aureus. Now, the diagnosis is based on 3 cornerstones: clinical presentations, the commonest presentation being pain, fever is seen in less than 50%, and neurological deficits is seen in less than 30% of the cases. The image modality, MRI with gadolinium, is the gold standard with very high specificity and sensitivity. And once we have a clinical suspicion with supplemented with imaging, we need to get a biopsy, which is done with either a CT guided biopsy or a surgical open or MISS biopsy. We have adequate literature to support that surgical biopsy gives a far more yield of organism. Now, the investigation protocol, ESR, C-reactive protein, and blood cultures need to be done. Plain X-rays and CT scans helps us to identify reduced disc height, vertebral body destruction, or malalignment. An MRI with GAD will show the spread of the abscess. In cases with negative MRI, you can proceed with the radionucleotide FDG PET scans. ESR and C-reactive proteins can be used as a serum biomarker to help assess the response of treatment. Now, the treatment algorithm that we use, any patient presenting with neurological deficits, epidural abscess, intractable pain, or failed medical treatment, surgery is the first choice. Surgery helps in decompression, collecting adequate samples, and stabilization of the spine. In patients with none of these symptoms, you can proceed with a CT guided biopsy. In 50% of the time, you get a pathogen isolated and start with targeted antibiotic therapy. In those where CT guided biopsy is negative, you can go ahead with a surgical biopsy. Now, so the indications for surgery in discitis is neurological deficits, epidural abscess, instability, failed medical treatment, and intractable pain. Now, surgical strategy is based on anatomical localization. In cervical spine, anterior approach with debridement, With interbody fusion with bone graft, and anterior plating is a surgery of choice. If it's multi-level, you can be supplemented with posterior fusion. In some cases where there is no vertebral body destruction, only a posterior approach can suffice. In the thoracic spine, stability is well maintained with ribs. If there is only epidural involvement with no vertebral body destruction, a posterior decompression and posterior instrumentation, the MISS technique that we can employ is a percutaneous pedicle screw fixation 2 levels above, 2 levels below, with either a mini open decompression at the level of involvement, or you can use an MISS tubular or an endoscopic decompression at the level of involvement. In monosegmental involvement with no posterior element involvement, an anterior decompression by a transthoracic or a posterolateral approach is used. The MISS technique is MISS thoracoscopic approach. In advanced cases where there is kyphosis and significant vertebral body collapse, a combined approach can be used. In the thoracolumbar segment, if patient presents with neurological deficits and epidural abscess, decompression, debridement, and stabilization, the MISS technique again is percutaneous fusion 2 levels above and below with midline decompression using either tubular or endoscopic. In monosegmental spondylodiscitis with moderate vertebral body destruction, only posterior lumbar interbody fusion in the form of MIS TLIF can be done. When there is extensive vertebral body destruction and kyphosis, an MIS OLIF or ALIF with posterior fusion can be done. Coming to the interbody substitutes, the preferred interbody substitute is tricorticate iliac graft. Some people have also used structural bone graft along with recombinant human bone morphogenic protein. And there are various studies which have shown in infection, metallic implants can also be used. So the role of MISS is in decompression, debridement, evacuation of epidural abscess, adequate sampling, percutaneous pedicle screw fixation with mini open or MIS tubular decompression, percutaneous pedicle screw fixation with interbody fusion in the form of MISS TLIF, OLIF, or ALIF. Now, there's sufficient literature to prove this is a study by Mazda et al., which has shown effective decompression, pain reduction with MISS decompression, and effective sampling. There's a study by Joshua et al., which has shown that in antibiotic resistant cases, MISS decompression can be useful. The endoscopic people are not behind. They too prove that percutaneous endoscopic discectomy and drainage is an effective modality. Now, in patients with unstable spine or vertebral body involvement, MISS pedicle screw fixation can be an approach. And in those patients with significant vertebral body involvement, MISS OLIF with percutaneous pedicle screw fixation is the option and effective. And in patients with single level lumbar pyogenic spondylodiscitis, probably at alpha S1 level, MISS ALIF with percutaneous screw is effective. Similarly, Duan et al. Has proven that percutaneous endoscopic decompression can be done with percutaneous pedicle screw fixation. Now, going to some of the cases, this is a 65-year-old patient with diabetes with severe low backache. MRI shows features of discitis at T7, T8 level. So this is an MIS tubular approach. The tubes have been used to dock at the T7, T8 level. The lamina and the facet is drilled out, the yellow ligament removed, and the epidural space is reached. And once you reach the epidural space, once you reach the epidural space and you go down towards the disc space, the abscess from the disc space can be removed effectively, and a good amount of sample can be sent for isolation of the organism, and the disc space is debrided and irrigated with amikacin saline. Not able to forward this. So in just a minute, you will see pus coming out from the disc space. I'm sorry, I'm not able to forward this. Yeah, so now you can see there's pus coming from the disc space which can be collected. The patient did very well. The next case is a case 48-year-old who underwent UBE for a neurogenic claudication. 10 days later, the postoperative MRI shows very good decompression, but 10 days later presented to us with severe back pain. An MRI with GAD showed enhancement in the muscular plane and epidural space. We re-entered through the same incision using the tube, did good decompression, irrigation with saline and amikacin and antibiotics, and patient did well. The last case is a patient with discitis at L1, L2, where we did pedicle screw above and below fixation with a mini open. Patient did well. The take home message is we need to have a high level of suspicion because the signs and symptoms are very non-specific. MRI with GAD is the investigation of choice. Where possible, medical line of treatment is the way to go with good cover of Staphylococcus aureus. Surgical indications are neurological deficits, epidural abscess, intractable pain, and deformity. MIS is the gold standard surgical procedure for debridement, pedicle screw fixation, and interbody fusion. Though the incision is small, it can provide us with golden results. Thank you.
Thank you. Any questions?
Thank you, sir.
In case of epidural abscess, where there is a Staphylococcus aureus is present, so would you advocating for the fixation and implant?
So not in all cases. If it is localized, just epidural abscess, you can do a posterior decompression. You can evacuate as much pus, send for analysis, and nice irrigation with saline and amikacin and antibiotics is good enough. Only if there is vertebral body involvement, some amount of destruction of the vertebral body, then and patient has severe pain, then you can go ahead with percutaneous fusion above and below an antibiotic.
My question is whether you will wait for the get the infection control then fixation, or simultaneously you will
Simultaneously, sir, it depends on the vertebral body involvement or not. If there is no significant vertebral body involvement or destruction, then you can just do a decompression, which is adequate.
in the presence of aureus, aureus.
What do you
So-
mean by significant?
Pus is there,
You mean
epidural abscess
kyphosis?
is there.
Sir, if there is more than 50% destruction of the vertebral body and kyphosis, significant kyphosis, then you go ahead with interbody fusion along with percutaneous fusion. But if there is some amount of destruction, you're seeing that end plates are eroded, vertebral body is eroded, but still the alignment is well maintained, then you can go ahead with 2-level above below fusion and antibiotics. But if there is only the discitis and like the case that I showed, where there is only involvement of infection in the epidural space, then just decompression would suffice.
That is the question I was asking.
Yeah.
When there is no collapse or destruction of the body,
Decompression is enough.
put pedicle screw fixation.
No, not required, sir. Decompression is enough, especially when you're doing minimal invasive. Decompression is enough. Yeah. So,
Thanks.
yes, sir. Yes, sir.
Clearly says in all my 3 patients, we had to ultimately do a fusion itself. Initial 2 to 3 weeks of antifungal once proved it is once proved
Okay.
compared to a bacterial infection.
So, but
So
how
there
did you prove it with a biopsy, CT
Biopsy, all
guided?
3 patients we did a CT guided biopsy confirmed, and one patient it was candida as I showed, and 2 patients it was aspergillosis.
Yes, sir.
Long-term antifungal treatment is required, but they will require fusion. The long-term studies have shown they will definitely have significant problem. Even if you give long-term antifungal treatment, they had to be fused.
Which
So,
was simultaneous or sometime?
After 2-3 weeks, it's up to them.
See, the other advantage probably of fusing is early mobilization. We don't have to put them in bed rest. They can immediately start mobilizing. Right. Thank you. Thank you.
Thank you. We call up Sudhir. Talk on MIS strategies for surgical balance correction.
Respected chairpersons, Manas, Savitar. So, my topic is sagittal strategies for managing sagittal balances all people who undergo fusions, around literature shows that 40 to 60% people will have pains in the post-operative time because of various surgical errors, and one of them is not adequately understanding the sagittal balance. So to understand that, we have to understand what is alignment, what is lordosis, and why it is so much important, and what options we have to uh, attack it. So the first thing is we have normal alignment in three planes. The sagittal alignment is the most important because this is where how when we became bipedal in walking, we got these three curves in a cervical, thoracic, and lumbar spine, and that determines everything. In the end, our ear has to come over our hips. So something like that for all persons, it's applicable. And alignment is also important because the muscles can be stretched to certain extent. So there is a zone of economy around which a body can adapt to itself. So if you are beyond the zone of economy, you will have persistent back pains, neck pains, and even knee pain. So a wrong done cervical surgery in which you have caused a kyphosis because of cervical spine can give you a knee transplantation patient in a few years' time. So we have to be so much cautious when we are doing even a cervical, thoracic, or a lumbar spine. So evolution of sagittal plane from birth in the fetus, when it is C-shaped, when you start sitting, then it becomes kind of a L-shaped, and then a mature adult comes at 18 years of age. Coronal malalignment normally gets adjusted. The sagittal misalignment is something which is going to cause you pains and aches at all the three junctions area, cervical, lumbar, and the knee area. And as we age, we tend to become more kyphotic in the thoracic spine, and also our cervical spine will become more, we will lose lordosis, but certain people, due to compensation, may increase lordosis in the cervical spine as they age. So this is like what does to the age. We lose the lumbar. You can see a flat back in which the lumbar spine is straight. You have lost the thoracic kyphosis to compensate that, and the cervical lordosis has increased in this case to compensate all these things. So all the adjustments happen to keep your gaze in front, and so you are able to walk. Beyond a level, a decompensation will set in, and if a decompensation set in, then you have frequent falls in old age. So old age, if you're having frequent falls, it's not physicians, it is we who have to address it. It's because of two, three reasons. One is sarcopenia, where the muscles tone and strength goes away. Second is osteoporosis, and third is your altered balances which have happened over the period of over a period of time. And this is what happens if gets uncurtailed, and you will have a person who is really stooped forward and has become stooped forward and has frequent tendency to fall. So with increasing age, the lumbar lordosis decreases, thoracic kyphosis increases, and the sagittal vertical axis also increases. I will go through all of these as I do this presentation. Sagittal imbalance is the most important thing because our ears should be above our hips. So that's what we have to remember if we don't go into the scientific detail also. And even if we are doing a short segment, it can have a long-term bearing on the pain of the patients. So that is also very important. So this is an old lady picture which has stooped forward. And if we find that this axis, which is from the T1 vertebra and going down, if it is shifted more than 5 centimeters, these people will always have back pain, which will be there. And it can be disabling, cause fatigue, pain, poor osmosis, functional limitations, mechanical back pain, and also lead to further on neurological symptoms. The important parameters is one is this lumbar lordosis. This is at the L1 and the S1 where the two lines are there. This angle is pretty important, and this is pretty important for having no back pain if we are fusing these patients. And as this lordosis increases, the pain decreases and even the disability decreases. The second is pelvic incidence. This is something God has given us. it will remain the same for all patients. But in this, the sacral slope determines everything. So if you have a person who has a horizontal kind of sacrum, then you have a large pelvic incidence, and then a small pelvic incidence happens when this is there. So all people will have unique of these things. So we have to plan our surgeries depending on this. Pelvic tilt is angle which we between the sacrum and vertically if you take the line, and this varies. Pelvic incidence remains the same, but pelvic tilt will remain just will change according to how the sacrum is positioned. And pelvic tilt will have inclination on the upper thoracic vertebrae also, how they are aligned, and will also have effect on outcomes. And if they have lower pelvic tilt, then the outcomes are better compared to this. And similarly for truncal inclination. Sacral slope is also important because this will determine amount of lordosis, which will this will also, all parameters are related, so it will also change with pelvic incidence and pelvic tilt. So that will determine this. So it's related to both the factors above. And this is the most important, sagittal vertical axis. So this is in the from the P1 plumb line, it should be just above the femur, it should go. And this is also one important thing. For those neurosurgeons who don't understand this, they should always understand that our head should be above our hip joint. So that is something which basically when you are trying to achieve anything, you should try to achieve this, and this is called principle of conformity. So the back is in a conformal shape. And if the SVA is this line which is from C7 centroid to the posterior superior end plate which is there. There are certain alignment objectives which we have to achieve, and good fusion can become very bad. 30% do become bad because we have not taken care of these things. When we are putting cages inside, we will put a cage which is narrow and it may reduce the lordosis of the patient. You have jacked up posterior behind more compared to the anterior space. You are likely to have more pains in the post-operative periods. Now the goal of with this lordosis we can achieve. Lordosis is something which we should strive for, and we can achieve with all these minimally invasive options around the spine, which can be from anterior, oblique to posterior lateral, and even posterior approaches can be done in a minimally invasive way. Our aim is to achieve the best lordosis, which with whatever technique we are familiar with and we are comfortable with. All techniques differ according to the surgeon's comfort, but most of the surgeries which are from behind will be able to address the nerve compression more. The side strategies will give more lordosis, more disc space, and but will not be able to address directly the nerve compressions which are there. So this is what happens in various things. Missed T-lift is a technique in which you go from behind. The most important thing in missed T-lift is that whenever you go inside, you should put a center cage. More anterior cages will lead to more lordosis, and the angle of the screws which you put should be oblique, and the rods which you are putting should be curved. So anteriorly placed cages are cause greater lordosis and greater sagittal imbalances which are there. So this is what happens, and you can achieve in T-lift. This is a good amount of decompression lordosis which is achieved. Even a high grade listhesis, we can do the same thing gradually. If you work on the high grade listhesis, you can achieve quite a good lordosis. The most important mistake which people do at L5S1 is they jack up, and the jack up reduces the lordosis in the post-operative time, which causes disabling pain. This is a patient where the options for T-lift, O-lift and everything exist, but because there is a severe canal stenosis and congenitally the canal is less, a T-lift approach will be preferred compared to O-lift and other approaches, because this has given canal decompression along with the lordosis which is present. So lordosis, if we do with a T-lift procedure, we achieve around 4 degrees of increased lordosis. while other strategies will give more lordosis compared to a TLIF strategy. This is intraoperative views. When you do the surgery, you compare. What also happens is immediately when you do the X-rays in the postoperative period, patients will have spasm. So 5 days post-op period also people will have some amount of deformity which is there. You should do a TLIF after 1 month, and if you do that, you will find that the X-rays become much better. And this is after 1 month when the amount of things also come up, because canal stenosis itself causes a kind of a stoop posture which takes time to correct. OLIF is better compared to TLIF in these patients because you are jacking up anteriorly and you have a lordotic cages prefix, so the angle which you can cause is quite better compared to a TLIF approach. So you can intraoperatively only achieve a good amount of lordosis with TLIF cages. Even the coronal balances also becomes better, and you also lead to indirect decompression which gives the canal a good space. You can also put percutaneous screws at the same time. In our studies, in which we have studied more than 2000 TLIFs and 300 OLIFs, we found that VAS scores was better in the OLIF compared to the TLIF patients. We also found that the radiological outcome was slightly different for our TLIF cases. What we OLIF cages, we were able to achieve the disc height quite significantly more, and our lumbar lordosis angle was quite significantly more, 4 degrees to around 11 degrees, and from disc height of around 0.23 increased to 1.71. But with adaptic cages, we have, compared to the ceramic cages we used to use before, we have found better results, and with increased lordosis, that is much better. And all other angles improve compared to this. So these are the minimally invasive strategies which are used to do this. So in the end, to conclude, respect sagittal balance, do the procedure which you are most comfortable with. Do not correct very aggressively, be more anterior. Aggressive correction can give you a proximal junction kyphosis, and it is better to correct less compared to being very aggressive. And MIS techniques do achieve a lot of lordosis and less amount of pain in the long-term outcome of the patients. Thank you for your attention.
Thank you. Any questions?
Um, as more and more sagittal balance is coming in picture, do you really think that OLIF is getting more and more popular, or we can still manage those sagittal balance even with the TLIF in
So
your
I
view?
told the criteria: if you have posterior stenosis and if you have a quite significant canal stenosis, congenital primary canal is narrow, or you have significant ligamental hypertrophy, you can undergo TLIF before. And OLIF you do when there is some amount of canal which is there. Some people have gone on to do OLIF with simultaneously canal decompression at the same time. Definitely, there will be better sagittal balances with OLIF. Even the coronal deformity becomes better. Even the fusion rates are better in OLIFs compared to TLIFs. So OLIF is the procedure of choice. For L5S1, you have to either modify the technique of OLIF or you do ALIF. So simultaneously to do at other places becomes difficult. But if you are doing at multiple levels, TLIF, it is better to do a OLIF with decompression because you save a lot of time.
All your cases, do you measure all these parameters?
Yeah, we have to do
Using
that.
which software or?
No, we do it angle wise, but there are software, spine wave software, which are available free of charge, which you can
Okay, sir. So second
measure.
question is, what is the incidence of graft subsidences in your cases?
Around 30 to 35% on long-term follow-up, we have graft, even in TLIF and OLIFs.
And how about your experience with regards to expandable cages in these cases?
Expandable, I've not used, so I won't have this experience. But directly, I've used titanium. I've started changing my preference from ceramic to titanium because I think the subsidence is less with them, and the stiffness of that thing is more well maintained compared to a ceramic cage.
Thank you.
Thank you.
Thank you, Dr. Sudhir. I call upon Dr. Mukesh Kumar from Kangra to present his topic on how to reduce high-grade spondylolisthesis by MIS technique.
Good afternoon. My topic is how to reduce high-grade spondylolisthesis using MIS trial in situ technique. I am Dr. Mukesh from Himachal. Spondylolisthesis means displacement of one vertebra over other. High-grade means slippage more than 50%. Degenerative is most common variety. As per Wilsey classification, from type 1 to type 5, so type 3 is most common, that is degenerative one, and followed by ischemic, that is type 2, which is seen more commonly in younger patient. This is made in classification from grade 1 to grade 5, and we will be talking on grade 3 and above. For reduction of high-grade spondylolisthesis, we need to stick to certain surgical principles, like we need to put patient in hip extension position and do good bony and soft tissue release, do nice distraction, sharp medial angulation and bicortical purchase, contoured lordotic rod and cantilever mechanism. We will be discussing one by one. So in standard positioning, this is standard positioning for any MIS TLIF surgery. But for listhesis surgery, we need to put patient in more lumbar lordotic position by putting extra pillow or cushioning below knee joint so as to make hip in more extension position. Now you will see in standard positioning, this is the amount of listhesis here. When the same patient is put in more lumbar lordotic position, the amount of listhesis has reduced significantly just by putting in correct positioning. Skin marking, as usual, 2.5 to 3 centimeter of midline. I personally prefer to put guide wires first because I believe there is virgin area and there are less chances of slippage of guide wires. And secondly, it gives precise length of incision also, as you can see, the precise length of incision. Then we need to secure guide wires proximally and distally and make an incision, palpate facet joint and put serial dilators, check on C-arm, and this has to be your final docking, which is more or less on facet joint. Then we will go for bony release by means of facetectomy, and we can start facetectomy initially by chisel and hammer. So as to get a good bone graft. Then we can finish our facetectomy by high-speed drill, and then we can put shavers, trial, and finally cage. So this is cage first technique in which we are putting cage first, then we are going to contralateral side and we will do facetectomy and discectomy in similar fashion, and then we will put all the 4 screws as you can see in this picture. Then we can go for distraction. This is external distractor so as to distract the listhetic segment, although I am not a big fan of this external distractor. Then we can tighten all the 4 screw heads. Now you'll see all the 4 screw head, they will come at the same level. That means listhesis has been reduced. This is AP image. Now this is a result. You can see complete reduction. This is a pre and post op image. And skin incision is quite small in size. Then comes another technique, that is trial in situ technique, in which we will keep trial in situ. Initial steps are very same. Once we have put trial, we will keep trial in situ. Because trial has got smooth surface as compared to cage. In cage, there are few serration on its sides. Now you will better understand in this pictorial diagram. This is both the techniques are there. This is cage first technique and this is trial in situ technique. Once cage is in, because of if you want to reduce this listhetic segment, because of few serrations on its sides, it gets anchored firmly to both the end plates and creates some sort of resistance while you are reducing the listhetic segment. So it results incomplete reduction in some of the cases, not in all cases, but in some of the cases, maybe just because of resistance. Whereas in other technique, because of smooth surface all around, there is no resistance and you will get complete reduction in majority of the cases. So this is the philosophy behind it. So coming back, once you have put trial in situ, you will go to contralateral side, do facetectomy and discectomy in similar manner and put screws on contralateral sides. We will not put all the 4 screw, we will put only 2 screws on contralateral side, and this trial will remain in situ on ipsilateral side. As you can see in this picture, on contralateral side, screws are in place and a trial which is there in ipsilateral side. Now this trial will keep both the segment nicely distracted while you are putting contralateral screws. So now you see you have done everything. We have done distraction by means of trial. We have done discectomy. We have done facetectomy bilateral, but this is still the amount of listhesis remaining. So how to reduce it? There comes the role of cantilevering. So we will put a nice lordotic rod and we will start tightening distal screw first. Then we will go to proximal screw and tighten slowly and gradually. So this listhetic segment will gradually come up and there will be complete reduction. So this act as a beam of cantilever, this act as a wall of cantilever, and this act as a load of cantilever. So which is a basic physics of cantilevering. So now you see after tightening, there is no listhesis. All the both the screw head attachment are at same level. That means there is no listhesis. Now we will come to ipsilateral side. We will take trial out and put cage in, and we will put remaining 2 screws through these guide wires. And after tightening, you will see again all are at same level. So this is the result. You will see complete reduction. So skin incision again small in size. So this is a pre and post op image showing complete reduction. This is a closer view. Then another principle which we should follow is sharp medial angulation and bicortical purchase. We should put a long and deep enough screw so as to get bicortical purchase, and we should also mind medial trajectory also. Another thing is complete bilateral facetectomy. I personally prefer to do complete facetectomy. As you can see, left-sided complete facetectomy, right-sided complete facetectomy. Similarly, cage placement has also to be anterior enough so as to provide nice lordotic curvature. So this technique, trial in situ, has been accepted in one of the prestigious journal, that is Asian Spine Journal, and most likely it will be published by next month or so. Now there are certain challenges also, like sometimes pedicles are dysplastic one, and secondly, you are not able to see the pedicle of listhetic segment on C arm because of overhang. So how to get rid of this? We need to open up the tube and we can put guide wires under vision like an open case. As you can see, both the guide wires are coming from within tube. So it means I have put it under vision. In another case, again, this is tube and you can see this is linkage probe and which again I have put it under vision. In another case, as you can see, there are 3 guide wires. So obviously 1 or 2 out of them I have put it under vision. So this is how you can get rid of this. Again, skin incision after maybe 6 months, giving aesthetic value of this surgery. Now taking few examples. This is L4, L5 listhesis, which was done by trial in situ technique. As you can see, complete reduction. Another L4, L5, again by same technique, nice reduction. Another case L5 S1 listhesis done by cage first technique. You can see there is decent reduction, but if you see carefully, there is slightly incomplete reduction, most likely because of resistance caused by cage, but this is still acceptable. Another case L5S1 high grade spondylolisthesis done by again trial in situ technique, again almost complete reduction. Another L5S1 with pars fracture done by trial in situ technique, almost complete reduction. So another case, L4, L5 listhesis. Now you'll see there is not only complete reduction in this case, but loss of lumbar lordosis, which was there preoperatively, has also been corrected. So I think this is one of the main beauty and main objective of this surgery, to restore sagittal balance and to restore certain spinopelvic parameters also, like lumbar lordosis, sacral slope, pelvic tilt, etc. So I think this is one of the biggest advantage of this surgery. So to summarize, we should really focus on hip extension, bony release that by means of complete bilateral facetectomy, soft tissue release by means of complete discectomy, and distraction by means of trial in situ technique or cage first technique. I personally prefer trial in situ technique, and finally cantilevering by means of putting lordotic rod and tightening distal screw first. So thank you, and this is my college, and which, as you can see, this is snow laden mountain all around, and this is Dharamshala cricket stadium. So anybody who is interested in cricket and cricket lovers, so they can come and enjoy cricket as well as this scenic beauty of this cricket stadium also. Thank you.
Any questions?
Sir, all the cases which you have shown are high-grade listhesis, and the literature says that in all high-grade listhesis, when you tend to reduce, the chances of nerve palsy is very high. What is instance in your cases?
Yes, there is no nerve palsy as such, but yes, there may be nerve palsy, because most of the time what we do, we don't decompress exiting nerve root completely. That is the main problem, especially in high grade listhesis plus degenerative cases. In degenerative cases, there is neural foramen narrowing of exiting nerve root. So we have to decompress bilateral exiting nerve root completely. So that is the main key. No, I have not done any osteoporotic cases. But yes, we can do. The only thing is that we have to put cemented augmented screw. That is how we can do it. That's not a big problem. Thank you, sir.
Fixation, the construct was ending at L5, L45. So it was not mandatory to reach the construct up to S1 because it finished at L5.
Sorry,
your
sir,
last case.
I didn't get your point.
In your last case, the fixation was between L4 and 5.
Mhm.
So will it suffice?
Yes, sir. Of course, it will suffice, because the main objective of this surgery is to maintain sagittal balance, as Dr. Sudhir has nicely demonstrated the
But in
importance of
our
sagittal
traditional
balance.
teaching, it was when your construct is stopping at L5, we have to reach up to S1. Similarly, if it is up to T12, one should reach up to L1. This was our teaching.
Yes, sir, we can go up to S1 also, but I think even going up to one segment, monosegmental, that is good enough.
Patient has an intact L5S1 disc and only a segmental issue at L45. They will probably do better long term if you can reduce L45 and bring back sagittal balance. There's enough, if there's an L45 kyphotic angulation because of the listhesis, a high grade listhesis, it'll make more sense to go superiorly to L3 to achieve the same amount of sagittal balance. But an intact L5S1 disc need not be violated unless a patient decompensates in the future. Because if we fuse to S1, the next joint that's going to go is the SI joint, the next joint that's going to go are the hips. So same thing
Exactly.
in scoliosis. You want to preserve as many mobile segments as possible if they are not diseased. Right? So if there's a disease segment at L5S1, if that segment is also collapsed, then it makes sense to move down. But if there is no active disease in that segment, the current issue is if you can fix the maximum problem at L45, get the kind of correction that you need, that will suffice.
Thank you, Dr. Mukesh.
Thank you, sir.
I would like to call Dr. Vishal Salve from Karad to present on clinical outcome of minimal invasive TLIF using tubular system.
Good afternoon, everyone. Thank you for giving me this opportunity. Myself, Dr. Vishal, I am working as a resident in the Krishna Hospital, Karad. My topic here is clinical outcome of MIS TLIF using tubular system in our institute, basically. Lumbar spine disorders such as degenerative disc disease, spondylolisthesis, and spinal stenosis significantly affect a person's quality of life, causing chronic back pain, nerve compression, and mobility issues. Degenerative disc disease involves the breakdown of spinal disc. Spondylolisthesis occurs when one vertebra slips over the another, and spinal stenosis involves the narrowing of the spinal canal, compressing the nerves. The traditional TLIF has been a standard surgical treatment for these conditions, but involves extensive muscle dissection, greater blood loss, and longer recovery times. In contrast, MIS TLIF offers comparable clinical outcomes with reduced tissue trauma, shorter hospital stays, and faster recovery, though it requires advanced surgical skills and technology. The primary objective of this study is to evaluate the clinical outcomes of MIS TLIF using a tubular system at our center. Specifically, the study focuses on assessing perioperative metrics such as operative time and blood loss, post-operative recovery in terms of pain, reduction and hospital stay, complication rates, and long-term outcomes including functional improvement and symptom recurrence. The methodology is this study was designed as a retrospective observational study. The focus was on evaluating the clinical outcomes of patients undergoing MIS TLIF using the tubular system at our center. The study was conducted in KIMS, which is located in the Karad, Maharashtra. The study was carried out over the period of last 1 year from the March 23 to Feb end 24. The inclusion criteria was participants aged above 40 years who having a degenerative spondylolisthesis and who failed conservative management. Exclusion criteria was patients with severe osteoporosis, ischemic spondylolisthesis, previous lumbar surgeries, or systemic conditions that could complicate the surgery. Participants were selected using a convenient sampling method from the pool of patients who were operated for TLIF at the center during the study period. Study included total number of 15 patients who met the inclusion criteria and consented to participate. Key parameters assessed were operative time, intraoperative blood loss, duration of hospital stay, post-operative pain levels, which were measured using a visual analog scale, functional outcomes, which was assessed using the Oswestry Disability Index, complications, and symptom recurrence. All the patients underwent MIS TLIF using a standardized surgical protocol. The procedure was performed by the same surgical team to ensure consistency. The surgical approach involved the use of a tubular retractor system, allowing minimal disruption of the surrounding tissues. Data were collected preoperatively, intraoperatively, and postoperatively. Pre-op data included patient demographics, baseline clinical characteristics. Intraop data included operative time and blood loss, while postoperative data focused on hospital stay, pain levels, functional outcomes, and complications. Long-term outcomes such as symptom recurrence was assessed at follow-up visits at 6 months post-surgery. Data were analyzed with SPSS software version 26 and study was approved by the IRBs. Here are some pictures of one case of a 55-year female who underwent who had grade 1 anterolisthesis at L45. This is our introp picture. The first one is showing the insertion germ shedding needle, which is confirmed on the lateral CM shoot, and this one. This is the tubular system. In the second pic, you see this is the cage we use. This is the post-op picture. So the results were total number of first demographic and baseline characteristics. The number of patients were 15. Average age was 58 years. Male to female was 8:7 ratio. Duration was 13 to 30.5 was the average month of symptoms. We found that our operative time was around 240 minutes, and blood loss was around 180 ml. Total length of hospital stay was around 3.5 to 5 days, 3 to 5 days average. And the was score was preoperative 7.8, day 1 5.2, day 7 3.8, and approximately 6 months it reduced to 2. And ODI pre-op 52, mean 3 months it was 27, at 6 months it was 18. We had 2 complications in these 15 cases. One had superficial wound infection and one had a hardware failure. So long-term functional improvement was calculated with this 5-point Likert scale. Approximately 80% patient had good satisfaction. So coming to the discussion part, the study was aimed to evaluate the clinical outcomes of MI sterile fusion tubular system at our center. So the in the especially these cases of degenerative spondylolisthesis. These are the some papers I took for the reference and for the comparison of our results. One is from the Dr. Hitesh et al. Published in the International Journal of Spine Surgery. Second one was published in the Asian Spine Journal by Hamid et al. That was the Yan Wang in the International Journal of International Medical Research. So coming to the discussion part, study involved 15 patients with a balanced male to female ratio and an average age of 58 years, aligning the typical demographics for degenerative spinal conditions. Intra blood loss was our result was around 180 ml plus minus 50 ml, which is compared to the results of Hamid et al. Who had around 126 plus minus 107 ml, which was comparable. So the average operative time was 240 minutes, which was slightly more than literature, because we believe that we are still learning. So with experience, we can improve. The average length of hospital stay was 3.5 to plus minus 1 days, which was for Hitesh et al. It was around 4.9 plus minus 0.8 days. Post-op pain relief was measured by the visual analysis scale, showed significant improvement from a pre-op mean score of 7.8 to a post-op mean score of 2 at 6 months, which according to the literature was a pre-op 8.4 to post-op 2. Functional improvement, ODI scores improved significantly from 52 to 18 at 6 months, which was for Wang et al. It was 59 to 22. 59 to 17, indicating substantial gains in functional capacity and quality of life. The complication rate, our study reported are 2 complications. One case of superficial wound infection, which was treated successfully. One experienced a misplaced pedicle screw, which we reoperated and fixed. No other complications like neurologic injury, adjacent segment disease, or CSF leak were observed in our study. So only one patient experienced symptom recurrence. So the conclusion is the study shows that minimally invasive TLIF using a tubular system at our center gave comparable results to literature in terms of blood loss, pain reduction, functional improvement, and complications, while slightly increased operative time, which we believe will reduce with experience. Further research with the larger sample sizes and longer follow-ups were needed to assess the fusion rates and the cost effectiveness. These are my references. Thank you.
Thank you, Dr. Vishal. Definitely experience will make you more better.
Yes.
And more comparable.
Yes.
Thanks a lot. And with this, we come to the conclusion of this session. Thanks for the very productive interaction between all of us, the speakers and the listeners. And thanks a lot for Manas and his team for this opportunity.
Thank
Thanks a
you.
lot.
Thank you very much, chairpersons. Thank you, sir. No. So Vidya sir wants to have some announcement.
Hi, couple of announcements. The certificates are available at the Torrent stall, so if you haven't yet collected them, you can do so. And we will have the general body meeting in Hall A after this session of NSSA. And everybody who's signed up for the workshop tomorrow, you've been given a set of scrubs. If you haven't collected them, you can get them from the INTA stall. If you don't bring the scrubs, you will have to use the hospital scrubs, and there's no guarantee on how clean they are. So you have a new fresh set of scrubs, please use those.
We'll start the now today's last session. I request all of the presenters please kindly upload it and stick on to the time. It's we are almost delayed by half an hour. The next session I request the chairperson Dr. Sukriti Chavan Dr. Suresh, is it? Dr. Praveen? No, I request Dr. Maulik from Baroda. Please come on to take the session, and Dr. Sai Kalyan from AIG Hospitals, Hyderabad. Thank you very much. Please start the session.
Good evening and a very warm welcome to everyone. We shall start the session with the first talk by Dr. Praveen Kumar Tripathi from Bareilly. He'll be talking on clinitubular microdiscectomy with 18 diameter tubular retractor for lumbar disc herniation, a prospective study. Huh? Not there. Huh? Okay, the speaker's not there. Second speaker, Dr. Raghu Samala. He's there, no? He's there. Dr. Raghu is there. Rest of it. Huh? Raghu's there. He'll be giving a beginner's perspective and clinical outcomes of the wrist and do endoscopic technique in spine surgery.
Good evening, everyone. I'm presenting. I started recently doing endoscopy discectomies with the Destandu technique. I am presenting my beginner's perspective and experience. So I'm working as a consultant neurosurgeon at AIG Hospitals, Hyderabad. We know various modalities. The open is very well established. We are all know. Now we are moving to the MISS, and in that we have two categories: one the microdiscectomy using microscope, and the other is endoscopic discectomy. Even in the endoscopic discectomy, there are two varieties we can call: the dry system, where there is no irrigation fluid, in which the Destandu system and Easygo system are there. In the wet type, we can use the UB system and uniportal endoscopic systems. So why we are moving to the endoscope, or for that matter, is the minimally invasive. So I'll come with the three things. The first and the foremost is this: the less smaller incision, less tissue damage, less blood loss, less pain to the patient in the post-operative period, and less need for the analgesic medication and the complications. The second, this was the initial. The blue thing will show the initial microscopic open, the type of exposure we need. With the microdiscectomy or tubular or Distendu system, the area needed to approach the pathology has decreased further. For the monoportal or UB, we further decrease the amount of incision and the area needed to be exposure. So one advantage is the less tissue damage. The second is the optics. So when we look at the naked eye, it is far away. We cannot see the crevices. The light will not go. There will be shadow effect at all, and that will be circumvented by the microscope. Again, the microscope, we have the limited by the angulation, and if the surface, the corridor reaching to the pathology is small, then our instruments will come in the path of light, and we cannot see. The third is the endoscope, where your eye is taken to the area where we operate. So that is more magnified and more view, and usually the instrument will not come into way of your optics. The third is the ergonomics. The advantage of endoscopic is, in the microscopic view, we have to beat a tubular system, the where you need the long binocular instruments. Otherwise, you cannot operate. The optics will come in your way, and the tubular fixed tubular retractions. So this one. So if the standard length tube is used, your area of approach is, the manipulation is small. So if to increase your surface area where you have to operate, either your tube should be wider enough to reach those areas. If the patient is obese and you have to increase the long length tube, where the manipulation again becomes a difficult problem. So these things are circumvented by the Destin tube technique, where the angulation is constant based on whether the patient is obese, whether your scope is deep inside or outside. When the thin patient, the angulation is 12 degree. So this is one advantage. The second is endoscope. This where your optics are much better and the less incision. So these are the instruments which usually have one outer scope, outer tube, and the inner tube with endoscope. And the endoscope is 18 centimeters with 0 degree. And with some people say this is a 12 degree angulation is there. So it will act as a angled endoscope. So the inner tube fits into the outer tube. So based on your degree of operating thing, if you want to clear the muscles, you can keep the inner tube a bit outside. And when you reach the pathology like disc, we can completely put your inner tube which contains all the instruments more inside. So the outer tube is usually it's an elliptical tube. It's not circular. So usually in case when we are operating disc, we do one hemilaminotomy, which is in a vertical direction, and that involves the path of it, so that we don't need to many manipulations with this tube. So it has 4 channels, one for the suction cannula, one for the telescope, each 4 mm, and the surgical instruments, there's one channel, it's 8 mm, and one fixed nerve root retractor. So if you see the angulation, we can manipulate in either way. You see the left and right and all the directions, the angle between the working channel and the instrument is the same. So for the surgical reps, we usually do under general anesthesia on some cases in the spinal prone position with the knee chest position with the maximum elevation of the concerned area, and localization, that is docking the device, and under the direction of the fluoroscopy we dock the instrument, and the skin incision around 15 to 18 mm, and aponeurosis is inside and the paravertebral muscles are spread out, and then we place the scope. These are the steps. So initially we put the marker, then take your fluoroscopy and wear the concerned disc, and then mix skin incise, then aponeurosis incision, then followed by your paraspinal muscle dissection, which is laterally, and then we put the outer tube with the trocar and remove the trocar and place the instrument. So the docking is important based on the level of your disc or the pathology area. If the disc is central, where extruded disc, and your scope docking is exactly over the area. But if it is moved down or up, then you have to keep the scope according to that. You can keep it in cranial or caudal to the disc area based on the disc migration. So this is standard procedure. So the upper, this is the paraspinal muscles and the fat dissection. Then upper part. So this is the removal of the lamina. Then we are incising the outer layer of the ligamentum flavum. And after that, the ligamentum flavectomy. Is after placing the medial retractor, not root retractor, and we are incising the annulus. And this is a disc removal. It is similar to microscopic, but except that we are at the disc place, and you can see the decompressed traversing root. So this is another case. So similarly, we are doing the hemilaminotomy, then flavectomy. Then we removed the discectomy, and it was not decompressed properly. Then I was at the beginner. Then we called our senior, and he did the over top decompression and disc on the other side. So this how the thicals act. So till now we operated 32 patients, predominantly L5S1 for the beginners. There's more space there, and predominantly paracentral discs. And there was one dural tear and one CSF leak. And microscopic conversion was there in 2 cases, which migrated disc and central disc. And within the 30 days, like 29 people have returned to their work, and 29 patients had excellent results. So the results were comparable with the literature. So what lessons we learned is from the beginning, we should start with L5S1 and gradually progress to the more complex cases. Right. Thank you.
Wonderful presentation. Any questions?
Yes, sir. It's the beginners. So it is because of my 2 seniors, like Dr. Subodh, he has done around 400 cases of Destandu, and Dr. Sai is also doing. So with them, I'm like learning.
So
Right.
thank you.
Thank you, sir.
Next presentation is by Dr. Sukriti Chauhan from Gangtok. A spectrum of simple discectomy complications. Dunning-Kruger effect in microlumbar discectomy.
Hi, good afternoon. Good evening, everyone. My talk, the topic itself makes you intrigued, keeps you intrigued as to what am I going to talk about. It is basically, well, this is the place I come from. I'm from Sikkim. So like the Himachal slides, I got one slide from the state also. So what exactly is the Dunning-Kruger effect? It was given a Nobel Prize. They say something called the IgG Nobel Prize in 2000. Now, IgG Nobel Prize basically means a Nobel Prize for something very quirky, but something innovative and something very intriguing. And the amount that is given is 40 cents. So that you can imagine less than maybe 40, 50 rupees or less than that. Yeah. But it came into very much in being and how much we can implement it in our life. So what exactly it is? These are the two gentlemen who got the Nobel Prize. Because when they say Dunning-Kruger, we always think of the top Nobel. So this is my outline of my talk. It is basically that it reveals how individuals with limited experience tend to overestimate the skills. The moment you're out of general surgery, you say, oh man, I can just do an appendix, just close one eye and do it. Once you're out of neurosurgery, oh, disc is such a common thing. I used to do it in PG life in final year. So that is means you're in the first stage. So what exactly are the stages? So the first stage is being you have the highest amount of confidence with the least amount of competence. Then comes, oh God, everything I do is wrong. Because when you try to implement that, you fall into the ditch and then you understand, yes, I know what I don't know and I need to learn more. So basically, you go from a stage of being not knowing what you don't know to something that you know. And the confidence levels initially are the top end, then your confidence just go down, and as you learn and gradually learn, you come to a stage where you say, yes, I am confident, but yes, you always sound less confident than the gentleman who's just passed out his MCH or DNB. So this is where it says and most of us right now must be in phase 3 or phase 4. So this is my story when I felt I'm in phase 4. That is the last, neurosurgery, lumbar discectomy is the back of my hand. I can just close one eye and do it. So, but they say an expert is rarely as confident as an ignorant person. So, as usual, we have the standards list of complications: pain, CSF leak, nerve irritation, meningitis, DVT, the common ones, and my experience. So, I retrospectively thought I came across one very unique complication that made me think actually what went wrong. So, I thought of my cases, that is the past 50 years which I have done, past 50 cases which I have done. Not the ones during my neurosurgery training, not the ones in the after my completing my training, but those cases which I have done independently, individually, with absolutely zero help. So this is something all of you can think about. And there is no help available also nearby. So you're the only person doing it. So I didn't know. I thought I'm not in the genius or the Einstein, maybe somewhere in between. So my complications were standard, which all of us get, and those complications percentage was also very low, maybe one or two cases. So as such, I had no problems doing those cases. It's a normal microlumbar discectomy I'm talking about. Then I came across two complications. One was a nerve root mimicking an extruded disc, and the second was a number 11 blade breaking. So this nerve root mimicking, I used to say, how can you miss a nerve root? But yes, it really mimicked a disc. It was so thick, it was so wide, it was so fibrous, and yes, but luckily patient just had paresthesia which resolved, so things were good. Second case was a simple disc, extruded disc. You can see that. And this is the anatomy of the L4, L5, the problem area. And over here, and then inside, when I have put my number 11 blade inside, it breaks. You can imagine my situation. Nobody to help. We are there alone. Okay, fine. I said, okay, fine. It's only broken. We'll just put the, disc punch and take it out. The moment I put the disc punch, what happens? It went in further. Now we are scared. That is why I showed you these anatomy slides. You don't know where it's gonna go. So, and the second question that came to my mind is: the more you press it, it might go and get stuck in the annulus ahead. Then what? Now, am I going to turn the patient and search for that blade? So finally, we tried, and you can see there are a lot of pointers down there. You can see a lot of pieces of the disc of the blade. Okay, so one is which one is pointer? So one is One is this piece, long piece, which was easily seen to everybody, and this is the small piece. Here, it's this piece and this piece. So I thought there are only two pieces. We tried, we recovered with great difficulty. By God's grace, everything came out, only to realize we had one, two, three, and four pieces. The only piece which came out initially was this, and these two came out in one shot. That made me question myself. Am I really confident? So my observation was, the unconscious competence is the last stage, which emphasizes that you've mastered something. So I would like to highlight that all of us who are working in tier 2, tier 3 cities, working alone, we need to think of mastering the art of every small surgery that we do. Why? Because 90% of work needs just 10% of our skills. Nobody gets a brainstem carcinoma every day. Nobody gets a spinal tumor every day. It's not that they're not common, but they just don't come. The simple surgeries come to us. So we need to always introspect and see what we can do better in them, because in this 90% of our work, if one case goes wrong, it breaks both the confidence. Maybe you go back in the Dunning-Kruger in the graph to the previous one. So the take-home message is know yourself. There are multiple memes about Dunning-Kruger effect. This is my place. All welcome. And if you have any doubts, I'm there to clarify.
As usual, very excellent presentation, ma'am. Any questions?
And if anyone has come across a unique complication, we'd like to hear.
Even similar complication has occurred with us when we were doing Destendo, me and Raghu were doing, and we have done the discectomy. As you said, we couldn't differentiate the disc from the root, and the 11 number blade was exactly on the on the disc space, and we were being more laterally, and suddenly we saw some small worms popping out.
The noodles had come.
The noodles have come out. So what we did is we just called Dr. Subodh. He came, he said, do nothing, just pack it with fat and come out and pray God. And we were fortunate enough that patient has come out with just paresthesias.
Yeah, that's what the paresthesia takes long, and it it increases the heart rate for the next 1 week at least. Then
You
it's
don't
on.
sleep. Yes, sir, please.
And you need to accept. We all should accept this thing if we don't know anything when we passed out. Number one. Number two, the same complication I had. The blade was inside the disease space. But I want to know, how did you remove that?
So we were just doing X-rays left and right. And what happened is I thought as per that it is more in the center part. That is the soft area of the disc. So as usual, getting it on the softer area is always easy. We put the, when I put the punch, it went inside. It actually got stuck in a part of the annulus and the nucleus pulposus area, mix area. So second when I did is I went a little bit scraping the annulus laterally, and then it came out. It's like
I'm
it
just
was
sharing
very
my experience like that. Just so
It's
everybody
luck,
will
correct? It's luck.
please. There was one piece of the blade remain inside. I tried to remove it. That was going inside.
Correct.
From this side, that side, this side by CM, but it didn't come. Then what we did, we packed the patient and postponed for next day. And we took the magnet, which can go inside the disease space. We sterilize it and we put the magnet that came.
That all that we thought, sir. Actually, post procedure, we thought of multiple possible. I
And
called
it
the
was
medical
clear,
guy.
and we said to the patient, yes, this was a complication, we will remove tomorrow.
But
So,
sir, that was a
Yes, sir.
steel blade.
Yeah.
Steel
sir,
blades do not come with magnet.
my take on to this is to avoid these kind of complication. Like your blade is flush to the end plate, where more cartilage and more tough tissue is there. Your aim is to incise the disc in the center. So if you go more onto the end plate, where the more cartilaginous part and bony part is there, and the another thing is when you try to twist it, you
I
cut
used
it,
too much power.
you twist it, you think that you will enucleate and you deliver it. So in that point of time, where you saw that blade is having in center part only two flanges is there. In a laterally flanges centrally open. So it is a very fragile part. It will break when you twist it in a tough structure.
That is like more mental
So
actually.
never like we do in ACDF. What we do is you curve the blade at the edges. So here you shouldn't curve. You should just cut it. You cut it parallelly to upper end plate, lower end plate. Do not try to twist it within the disc space.
That's what, see, all retrospective, everything is right. But that time, that day, that is how my hand moved. I couldn't help it. And see, and the magnet, it wouldn't work because the blade was steel. We went to that and we checked which company the blade was. It was standard company, which we all use. So I still don't know why did only that blade break. We told the hospital and we changed the company of the blade. That's the only thing I did after that.
Afraid I got on that.
Yeah. Thank you, Dr. Sukirti. Next speaker, Hearing the Zebra's Hooves When Tuberculosis Isn't the Answer by Dr. M. Sanjay Raj Kumar Reddy from Hyderabad. I would like to request the speakers to stick on to the time.
Good evening, everyone. I would like to talk about 3 unusual case presentations which were diagnosed as TB. When you hear the sound of hooves, think horses, not zebras. This was told by us to sir? Yeah. Sir. Zebras hooves means full. This was taught to us in medical field continuously to emphasize that we should not miss the most common diagnosis, but not in these cases. 32 years female patient who was having a low backache and flaccid paraparesis with sensory disturbances since September 2023, and another female 16 years female who is a known case of hydrocephalus who had underwent VP shunt in 2019. Patient has again come with headache and vomitings. And another male patient, 50 years male patient, he had headache and visual disturbances. He was considered to be having the IAH, and Diamax treatment was given. On CSF workup, the 32 years female patient has lymphocytes, 75% lymphocytes, and proteins were elevated. In all these 3 cases, we found that the proteins were elevated, and ATT was started at various point of time in all these 3 cases. In the 50-year male patients, we also found that the opening pressure was very high, and the intracranial pressure monitoring, we have seen that the pressures were continuously high, greater than 20 mmHg. So the patients were started ATT in the outside hospitals, and they were referred to us because they were not improving and their symptoms were worsening. So this 32 years female patient, she had worsening lower limb weakness, and this 16 years female patient, she had developed new backache and lower limb symptoms like sensory disturbances. And this 50 years male patient, he has a lower limb weakness and headache and other seizure episodes even when he is on ATT and anti-epileptic. So the patients were started to assume to be having this TB meningitis, and they were started on ATT. I will go into the imaging. This is the first patient, 32 years female patient. So you can see in T1, I could not appreciate the lesion actually, but in T2, there's a hyperintense lesion at the D8 to D10, and it's a contrasting enhancing lesion. We can see there is diffuse leptomeningeal enhancement. Also, the CSF space below the lesion is enlarged. There is a enhancement of the pachymeninges and leptomeninges uniformly. The same patient in the sagittal view, we can see there is diffuse pachymeningitis and pachymeningeal enhancement and leptomeningeal enhancement. This is the lesion at the section, at this section. On T2 it is hyperintense, and contrast it is enhancing, well defined. This is another patient, 16 years female patient. These are old scans when she came to us, done in outside hospital. There is a ring enhancing lesion, and T2 sagittal spine showed the central hyperintensity from cervical craniocaudal junction to the dorsal region. We had repeated the spine screening, and we had noticed that that there is a lesion, that there is pachymeningeal enhancement. Along with it, there is a arachnoiditis at the D10 to D12. These are the axial sections of the same patient. We can notice that the lesion at the D8 to D10. So these are the scannings done in our hospital. We have noticed another lesion in the intraventricular region, which has evolved over time. This is the 50 years male patient scans. We can notice the there was only mild hydrocephalus in the T2, but we could notice periventricular white matter hyperintensities in this patient. On contrast, there is pachymeningeal enhancement of this patient also. On spine, there was a L2 IDM at the. We can notice the IDM. It was well defined, and in the sagittal sections and coronal sections, we can notice that the nerve roots are exiting and the traversing nerve roots are also enhancing. So assuming TB, they have started these patients on ATT, but they are not responsive. Why TB? Clinically, they have considered TB. They might have considered TB because the non-specific nature of the symptoms and chronic nature of the symptoms. And imaging, there is contrast enhancements, diffuse leptomeningeal enhancement that might have led to the conclusion that it might be TT, and they couldn't find suitable DD. And coming to why not TB? So when to rethink TB? So normally we'll think it might not be TB because non-improvement to treatment. So how to diagnose? So we have started these patients on TB without a tissue diagnosis. So when the patient is not reacting to treatment, we'll have two doubts: whether it is TB or even if it is TB, if it is resistant TB. We can't prove it because at this point, even if you try for a tissue diagnosis, you will have a doubt that we have started on ATT and the microscopic imaging might not have showed these bacilli. So how to diagnose drug resistance when TB wasn't proven in the first place? So uncertain until proven, and response to. So we are using starting ATT as a proof of diagnosing the TB rather than treating it. So tissue diagnosis trumps assumption. We have come to this conclusion, and all three cases underwent laminectomy and biopsy or excision of the lesion were suitable. So here comes our zebra. So this is the DLGNT, the diffuse leptomeningeal glioneural tumor in all three patients. So the histopathology of the 50 years male patient, we could this is the 22 times zoom. We can notice the same image 68 times zoomed. We can notice the uniformly monomorphic oligodendral morphic cells, which are with very less cytoplasm. This is in another patient, 32 years female patient. We can notice the microvascular proliferation here, and same oligodendral glial monomorphic cells. All three patients, the cytoplasm was synaptophysin positive. And DLGNT in WHO classification comes under gliomas, glioneural, and neuronal tumors. And so it's classified as a separate entity in 2021 WHO classification. DLGNT is again having three classes: DLGNT with 1Q gain and methylation class 1 and methylation class 2. Clinical presentation. This is based on the largest published series in 2022 by Rodriguez et al. Often acute onset of symptoms and signs and symptoms of raised intracranial pressure, sometimes chronic, ataxic, and spinal cord compression signs like that, like we seen in our cases. CSF workup shows raised proteins and grade and prognosis. Majority of the DLGNT are well differentiated low-grade lesions. A subset is present where we can see anaplasia or molecular alterations like 1Q gain or methylation class 2. Conventional DLGNT and DLGNT MC1, they react like a grade 2 tumors, and these anaplasia, DLGNT with 1Q gain and DLGNT MC methylation class 2 tumors, they react as grade 3. So in our cases, we found that the Ka67 was 21% in the 32 years female patient, and the 16 years female patient, it was 3%, and 50 years male, it was 12%. So if the Ka67 is greater than 4%, there will be poor prognosis in DLGNT cases. In the first female, it was similar to grade 4 tumor. Our pathologist has reported the anaplasia changes are similar to WHO grade 4 changes. As of now, there is no given WHO grade for these tumors. So there are no proper treatment guidelines. Actually,
Can you conclude?
Yes,
Can
sir.
you conclude?
Yes, sir. Actually, carboplatin and vincristine are given in pediatric patients, and temozolomide and radiotherapy is used for adult patients. This is another paper that shows that the pediatric patients given the chemotherapy had better outcome than other patients, but there are no proper treatment guidelines. In our outcomes, the first patient right now radiotherapy underwent, patient is stable, KPS score is 60, and 16 years female, she is unwilling for treatment, KPS score is 50, and the 50 years male patient, he had underwent temozolomide plus radiotherapy, patient is stable, and KPS is 40. So I would like to conclude that even though the uncommon diagnoses are rare, but zebras exist. So we should be able to do the timely diagnosis and treat them. The tissue diagnosis terms, whatever we assume. Okay. Thank you, sir.
Thank you. Any questions from the audience?
I would like to ask, did you involve neurophysician in these cases
Yeah,
using?
sir. Actually, all these three cases were.
So were they convinced when you told about surgery or?
Actually, we went to spine screening only when they had low backache symptoms and weakness of the lower limbs.
So who initiated the process of thinking about going surgery and doing biopsy when AKT not responded? Whether it was your department or it was neurologist?
No, we neurosurgeons are initiated.
Okay.
So you mean to say that in the first case there was progressive weakness of both lower limbs?
Yes, sir.
Yeah. So they didn't get an MRI done at that time.
No, when they in first case you mean this Rajesh, 32 years female patient.
yes.
They have got MRI, sir, but they suspected TB meningitis. They thought it is a TB meningitis case. There was no definitive lesion when they have done MRI.
Thank you. So we'll move on to next speaker.
So next is management of spinal tumor, institutional experience, Dr. K.N. Somesh. You are? Sorry, spinal tuberculosis, unmasking the unusual, Dr. Shubhadeep Nandi, Madurai. Please stick on to the time.
Good evening, everyone. Myself, Shubhadeep Nandi from Neurosurgery Department of Meenakshi Mission Hospital, Madurai. Today, we are going to discuss spinal tuberculosis, unmasking the unusual. So here we start with the cases. Case 1, 31-year-old male. He is already known case of miliary tuberculosis. He was started on anti-tubercular drugs. He presented to us with complaints of urge incontinence, increased frequency of micturition, and erectile dysfunction. Also, he had occasional intermittent headache and diplopia. So on neurological examination, extraocular movements were all normal. He was having spastic paraparesis of grade 4 power in both the lower limb. Along with that, he has decreased sensation below T10 level and exaggerated deep tendon reflexes and plantar extension was there. So with that, we started the patient to examine and followed. We went with MRI brain along with spine screening. So in MRI brain, we can see there is a thick wall contrast enhancing lesion mass at 2.5 cross 2 centimeter in the left tentorial apex, which is compressing the pons. Along with that, there was a focal thickening of dura at the tentorial cerebelli, and diffuse contrast enhancement was seen in the meninges and the cerebral convexity and the basal systems. Along with that, the spine screening was suggestive of there is an extradural mass which is compressing at the T5 and T6 level. There was diffuse leptomeningeal enhancement was also seen. Following that, we proceeded with the surgery of T3 to T6 laminectomy and excision of this intradural extramedullary mass. Here we can see this mass is excision first to the dural. We will go with the dural ties. Following that, we can see there is a mass which is exposed there. And then after the exposure, intraoperatively, it was very much difficult for us to find the location of the lesion. So we have used ultrasound also. And we can see that the abscess is there, and we can see frank pus which is coming out of the abscess. We have sent for TB PCR along with all the other abscess wall cavity for the histopathological examination, and it came out to be TB. So post-operatively, patient was improved clinically and spasticity reduced, sensory disturbances and bladder symptoms improved, and he was discharged with anti-tubercular drugs. Similarly, case 2, here 20-year-old male, he came with intermittent fever, headache, vomiting for 1 month and admitted under neurological department. There they have evaluated the patient, and following that we did a MRI brain suggestive of leptomeningeal enhancement of both the cerebral hemisphere. CSF analysis was also done, which was suggestive of glucose of 29 and protein of 157. Gene expert for Mycobacterium tuberculosis was positive, and he was started on anti-tubercular drugs. he was discharged. After 1 month, he presented with itching and he was diagnosed with ATD-induced hepatitis. So he was actually like isoniazid, rifampicin, and pyrazinamide was stopped. And then second-line drugs, ATD drugs were started. And then he was again improved and he is discharged. 3 months later, he again presented with the same. Now the complaints were different. Now he came with backache, leading to the left chest wall with paresthesia of the lower limb and difficulty of walking in 2 weeks. On examination, there was spastic paraparesis with grade 4. Along with that, there is decreased sensation from T6 below, and there was exaggerated deep tender reflexes and plantar extensors. So then we evaluated, and here we can see there is a diffuse multimodular enhancing lesion in the cellular and supracellular region. Along with that, there is a focal thickening of the dura from T3 to T6 level, and there was significant cord compression, and there was then end-plaque epidural tuberculosis. We can conclude it. So with it, we proceeded with T3 T5 laminectomy, and then we have gone for the excision of this intradural extramedullary mass. Postoperatively, he improved the clinical features, and the spasticity in the lower limb was there, and sensations got improved. He was in regular follow-up with continuing ATT. So with this, we plan for the discussion. So spinal tuberculosis, if we think there are 4 categories. One is pot spine. Along with that, we have non-osseous spinal tuberculoma, which are categorized into 3 parts. One is extradural, but one is intradural extramedullary and intramedullary. And then we have tuberculous arachnoiditis and tuberculous meningitis. So non-osseous spinal tuberculoma are extremely rare. So this was one of the article which was written in 1983 by Dr. H.M. Dastur from the Department of Neurosurgery, Jaslock Hospital. Here they have 74 cases for spinal tuberculomas that was analyzed, and 5 were intradural extramedullary, and 8 was only intramedullary. So with this, again, one single case report was given from the Korea. So there they have treated the patient with medical management first, but once the symptoms improved, so then they again went for surgical dissection and immediate decompression of the spinal cord. Muthukma sir also has put up 2 cases in 2002. There he has presented 2 cases of intramedullary tuberculomas, and they have located, and most of the common location is in the thoracic cord with common symptom of subacute cord compression. Surgery is generally indicated when there is no response to chemotherapy, there is diagnosis in doubt, and there is a large lesion which is rapid deterioration in the neurological function. Again, period of 16 years for 10 cases of intramedullary tuberculomas were found. In that, 2 patients were treated conservatively. Apart from that, rest others were treated with surgery followed by diagnosis. So this is the basic pathophysiology where the rich foci we all know develop in the meninges and within the brains of the spinal cord. Human microglia are the responsible for this complete pathogenesis in the tuberculosis. Microglia play the central role in pathogenesis of the tuberculosis. So this is the tables which summarizes all the cases which are reported, and we can see that from 2000 to 2018, most of the cases that went for surgery. Only one of the study in 2008 where they have given IV dexamethasone and intrathecal methylprednisolone, and they have mentioned the outcomes, but that is also like not completely. We cannot rely on the findings. All are like a case report only. So now the active tuberculosis of the spine, what are the guidelines now? Currently, the imaging modality, everything we have to follow, blood investigation, skin test, everything we can do. But the gold standard now, we have to go for the molecular testing as a form of gene expert. And we can go with the line probe assay for second line, like if drug resistant TB, which have a good sensitivity and specificity both. So what are the indications for surgery in spinal TB? If the patient is having neurological deficit, there is severe neurological deficit at presentation, then we have to go for surgery. And then new onset neurological deficit with anti-tubercular drugs, worsening of existing neurological deficit with anti-tubercular drugs, no neurological improvement after 6 weeks of ATT, and spinal tumor syndrome, if it's there, then we have to go for surgery. Without neurological deficit, if there is one vertebra in the thoracic spine or 1.5 vertebra of the lumbar spine, kyphosis of more than 30 degree, posterior lesion in the pedicle destruction, lack of clinical response with 6 weeks of ATT, recurrence of disease with ATT. And other indications are like large paraspinal abscess, prevertebral abscess causing respiratory disease, and uncertainty of diagnosis. We have to definitely go for surgery. So the takeoff points, intradural extramedullary tuberculomas are very rare. Intramedullary tuberculomas are seen only in 2 in 1 lakh cases in tuberculosis and 2 in 1000 cases of CNS tuberculosis. Intramedullary tuberculomas 0.2% to 0.5% of the CNS tuberculomas. Intradural extramedullary tuberculomas are very rare entities, and if extradural mass are not seen during surgery, we can always use a USG to localize the lesion. This is my team. Thank you. Thank you.
Thank you. In view of time, we'll keep the discussions at the end, so you can speak to the speakers yourself. Our next speaker is Dr. Satyabrat Sahu from Hyderabad. He's speaking on case series on rare spinal IDM and the surgical outcome.
Good evening to all. We have encountered a few case series on rare spinal lesions. I'll discuss in our institute. I'll discuss some of them. My first case is a 43-year-old female who presented with a swelling over neck since birth, and she complained of neck pain and paresthesia of all four limbs in 6 months. She also complained of difficulty in walking and slippage of chapel while walking. There is no complaint of bowel and bladder disturbances. On examination, we found a soft tissue swelling over the nape of neck, which was compressible, non-pulsatile. On motor examination, we found that tone was increased in all the four limbs, and power was somewhat decreased in all four limbs. The reflexes were exaggerated in both upper limb and lower limb, and the plantars were extensor. We evaluated the patient and did the MRI. MRI showed there is a lobulated mass extending from C2 to C3 to C5, and is protruding out of the spinal canal to the outside tissue. The tissue contains the neuronal cells, and the lesion is hyperintense both on T1 and T2, and is non-contrast enhancing. Done the CT scan, we have found that posterior element defect that is being noted extending from the C2 to C5 vertebrae. We have done cervical laminectomy, and this is the intra image showing the lipoma, and we have done the gross total excision. This is the post-op images, and the biopsy was the lipomenincocele. The incidence of the occult spinal dysraphism is around 3 to 6 in 1 lakh population. The most common location is the lumbosacral lesion, but in the spine, cervical spine, it is the percentage is 2 to 4%. Less than 10 cases have been reported in the world so far, and the most commonly they are asymptomatic. They gradually present as the age progresses. So, if the patient is symptomatic, then we go for surgery. My second case is the 56-year-old male who is known diabetic and hypertensive, presented with neck pain since 1 year, and complained of paresthesia in all the four limbs. And he also complained of weakness, progressive weakness in all the four limbs since last 1 year. He had similar complaint 3 years back, for which he was operated in the outside hospital, and they have done cervical laminating and subtotal excision of the lesion. The histopath was melanoma. They have advised for the post-op radiotherapy, but the patient had not opted for that. On examination, the tone was increased in all the four limbs. The power was decreased in the, both upper limb and lower limb. He was able to walk with support, and the reflexes were exaggerated both in upper limb and lower limb, and the hand grip weakness were also noted. So we have done the MRI. It showed multiple lesions both in the CVJ, cervical lesion and the dorsal lesion. That is hyperintense in T1 and hypointense in T2, and is contrast enhancing. And in CT, we have seen the cervical laminating prior defect, and there is no bony or any scalloping of the bones were noted. We have done the cervical laminectomy, and we have found that hemorrhagic patches were noted in the cervical around the cervical cord. The biopsy of the lesion was there are melanin deposit found both intra and extracellular deposition, which are positive for HMB45, melanin, and SOX10. The features were suggestive of the melanocytic neoplasm, and the possibility of primary or secondary melanoma to be ruled out. The incidence of primary malignant melanoma is less than 1%, and treatment is mostly primary surgery. And the post-op radiotherapy is usually recommended for most of the patients. My third case is the 17-year-old female who presented with progressive axial backache pain. There is no history of radiculopathy or any weakness of the limb. On motor examination, it was within normal limit. Is that we have gone for the MRI, and it showed the isolated lesion which was extending from the D12 to L2 vertebrae, which was both isointense to hypointense both in the T1 and T2, and was compressing the cord.
The lesion was mostly non-contrast enhancing with some peripheral enhancements being seen. And we have done the CT scan which showed the canal widening at the D12 to L2 region. And we have used the done D12 to L2 laminectomy, and this is the intra image of the lesion. The lesion was firm and suckable and cushable and mildly vascular. We have done the gross total excision of the lesion, and the biopsy showed lesion with ectodermal, mesodermal, and endodermal components, which are features suggestive of the mature teratoma. The incidence of teratoma is less than 1%, and most common location is in the thoracolumbar. So our patient presented with them in the thoracolumbar area and with the complaint of axial pain. We have done the gross total excision, and with postoperatively the patient had no other deficit. My fourth case is the 8-year-old male child who presented low backache since last 2 months. There is no history of radicular pain or any weakness of the lower limb. There is no complaint of the bowel and bladder disturbances. On examination, the motor region also were within the normal limit. MRI showed the lesion that is present in the L2, L3 vertebrae, which is compressing the cord, and that is a hypo to isointense in the T1 and hyperintense in T2. The lesion is non-contrast enhancing with some peripheral enhancement. The CT scan showed no bone scalloping or any bone erosion. We have done the L2, L3 laminectomy, and this is the intra ultrasound image. We showed the cystic lesion with some hyperdensity noted. This is the intra imaging of the lesion. There is some cystic part was seen, and we have done the gross total excision. The microscopy feature showed cystic wall lined by ciliated pseudostratified columnar epithelium, which also contains smooth muscle, hyaline cartilage, and few minor salivary glands. The features are suggestive of the bronchial cyst. The bronchogenic cyst, the incidence is around 1 to 1% around of the total spinal cord tumors. The most common location is in the cervical and upper thoracic region. This patient had presented with axial backache, and the lesion was in the lumbar region. We have done the gross total excision with no added deficit. My fifth case is the 15-year-old male with no known comorbidity, present with the left upper limb weakness since last 6 months. On examination, the tone was decreased in the left upper limb, with all other limbs have normal tone. The shoulder power was decreased in the left upper limb, that is in the left 3/5, and also weakness were noted in the left elbow and left wrist. Reflexes were exaggerated in bilateral lower limbs, and plantars were extensor. The MRI was done, which showed lesion in the cervicomedullary junction, which is isointense in T1, or heterogeneous hyperintense on T2 with some flow voids. And some serings were noticed, in the cervical and dorsal lesion, which is extending up to D6 vertebrae. The contrast was done, which is brightly enhancing. We have gone for the angiogram, and the angiogram showed it has feeders from both the posterior artery and anterospinal artery. We have done the embolization, partial embolization could be done only of the posterior artery. This is the intra image of the tumor, which showed feeders from both the posterior and anterospinal artery. We have gone for the gross total excision, and this is the post-op images. Biopsy showed the features of the hemangioblastoma. The incidence of hemangioblastoma is 2 to 10% of the spinal cord tumor. The most commonly they usually present between the age group of 30 to 60 years. Primary treatment is surgical resection. Some may require pre-op embolization due to vascularity. We have done the partial embolization of the posterior spinal artery and have gone for the gross total excision. Thank you.
Thank you. It was nice collection of cases.
Okay, thank you, sir.
Thank you. Next is IDEM, a comprehensive review of surgical approaches and outcomes by Dr. Burgula Sandeep.
Dr. Burgula Vishwasandip, MCH second year resident from Ballari Medical College and Research Center. Here I am going to present IDM or account for approximately 2/3 of largely benign intraspinal neoplasms. These are amenable to gross total excision and usually carry a good functional outcome. As ours is a tertiary institute, an observational study we have carried out based on Frankel and Nurix grading. Study design, this was a prospective cohort study. Study population, patients diagnosed with spinal IDM and are willing to participate. Exclusion criteria, patients who are not willing for surgery or denying consent. And routine investigations we have carried out. And MRI spine with post-contrast study. And here is a case of 52-year-old male who presented with tingling and numbness of both lower limbs for 3 months. MRI showed C7T1 level IDM. We have done C7T1 laminectomy and microsurgical excision and grade 0 Simpson. Post surgery, patient was relieved of his symptoms. And this is one more case of meningioma. And another case, a 44-year-old male presented with weakness of both lower limbs. On examination, his power in both lower limbs is 3/5. Reflexes were exaggerated. MRI showed C7T1 level IDM. Same like the previous case, we have carried out C7T1 laminectomy and microsurgical excision. Post-operatively, power was improved to 5/5. One more case, a 33-year-old male presented to our emergency department with paraparesis and urinary incontinence. His preoperative power was 2/5. Sensations were diminished and he had urinary incontinence. We have done on MRI, he has found to be having L2 and L3 level IDM, and we have done L2, L3 laminectomy, and tumor was seen attached to the lower border of L1 of cord. We have carried out microsurgical excision, and post-operatively, patient's power was improved to 5/5, but still he is having urinary incontinence and is catheterized. So far, we have operated 11 cases of IDM over a period of 18 months. Most of the patients were in the age group of 30 to 50 years, and only one female was at the age of 66. She only presented with tingling and numbness of both lower limbs. After post-surgery, she was improved. We have so far cases we have come through. We have operated on 5 schwannoma, 4 meningioma, and 2 dermoids. And at cervical level, we have operated 3 cases, and dorsal 4 and lumbar spine 4. Results: most of the patients had Frankel's grade D in pre-op, which went on to grade E post-op, and modified Neurick's grading. It was grade 3 pre-op and grade 0 post-op. Discussion: this study aimed to evaluate the outcomes in patients with spinal tumors using the Frankel and Neurick's grading systems at BMC and RC Ballari. Our study found that the post-operative outcomes after microsurgical excision improved in patients with minimal complications, corresponding to the following studies. Thank you.
Good presentation. Thank you. No questions, please. Next is Dr. Dilip Kumar, intramedullary tumors.
Thank you. At the outset, I thank Dr. Manas sir and organizing team for giving me this opportunity. Here I am going to present our institutional experience, the outcomes after surgery for low-grade intramedullary spinal cord tumors. Intramedullary tumors, they constitute around 10 to 20% of all spinal cord tumors in adults and 35% in children respectively, and 2 to 4% of all CNS tumors. They predominantly found in the thoracic region, followed by cervical and conus regions. Astrocytomas and ependymomas, they constitute the bulk of the tumor up to 75 to 80%, followed by hemangioblastomas. Primary aim of the treatment is to optimize tumor control to the gross total resection whenever feasible, and adjunct radiotherapy when if it is necessary. Outcomes are significantly depend on the tumor histology, extent of resection, and preoperative neurological status. Surgical resection in intramedullary tumors is challenging because of significant risk of transient or permanent neurological deterioration, which is described in the literature ranging from 11 to 64%. We have analyzed if in the lower, if having lower WHO grades 1 and 2 and better preoperative neurological status as defined by the lower McCormick grades had a significant impact on the outcomes of patients who underwent surgery for these tumors. It's a prospective analysis of 78 consecutive patients who underwent surgery over 8 years from 2010 to 18, and then later followed up for next 3 to 5 years. They are histologically proven WHO grade and grade 2 tumors, and they have evaluated before surgery and in the post-operative period and during outpatient visit during the follow-up. Baseline status, neurological status, and postoperative outcomes were analyzed during the McCormick scale. This is modified McCormick scale in which the neurological status is graded from grade 1 to grade 5 in the increasing order of neurological deficits. Grade 1 tumors are intact, patients are intact neurologically, whereas as the grade increases, patients' neurological deficits worsens. WHO grade 1 and grade 2 tumors were only included in the study. And the patients were average 33 years of age with predominantly males. Most of the tumors were located in the cervical region, followed by thoracic region, and then in the conus. 12 cases were patients were tumors were in the cervicodorsal junction, whereas 7 in the dorsal spine extending to the conus. Here we have analyzed if having a lower having the impact of preoperative neurological status and WHO grading on the outcome during the long-term follow-ups. The surgery is standard dorsal approach with laminectomy and a midline or lateral mallotomy depending on the tumor location. And intraop monitoring and QSA was used to maximize tumor resection. So the study was patients were graded into groups of WHO grade 1 and grade 2 and then analyzed. In our group, predominantly in grade 2, ependymomas were most common, which are up to 36%, followed by diffuse astrocytomas and oligodendrogliomas. In grade 1, hemangiomas, epidermoids, and epidermoids are most commonly seen, followed by cavernomas and lipomas. So tumor recurrences was observed in 9 patients, of which 5 patients were deteriorated functionally, and the recurrences were most commonly seen in the ependymomas, followed by epidermoids and lipomas and pilocytic astrocytoma. Here in the analysis, when we did a multivariate and univariate analysis, in the WHO grade 1 and grade 2 tumors, there is no significant difference was seen, except for the number of spinal level were involved, which is slightly more in the WHO grade 2 tumors. In the recurrences also, there is no significant differences was noted in the WHO grade 1 and grade 2 tumors. Obviously, in those patients who have had recurrences, deterioration, functional deterioration was more marked during the long-term follow-up. Here it is when we compare these grades of McCormick grade 1, 2, and 3, 4. So most of the patients who remained in whatever the grade before surgery and immediately post-operative period, they remained to be during the long term also they remained to be in the same status. That means functional outcome did not alter much. So most of the patients who remained in the lower grades of McCormick, that means lower functional neurological disability before surgery and immediately they tend to be in the same way during the immediate post-op period as well as in the long-term follow-up. Here we have an ependymoma. We have this gross total resection was done. Here there is a good plane of cleavage was noted. In the post-op period and during the long-term follow-up, there was no recurrence was noted. Here one more ependymoma. It's a WHO grade 2 diffuse fibrillary ependymoma. So in spite of here at one plane there was at one point there was no clear plane was noted. After 4 years there was a slight recurrence was noted. Here hemangioblastoma, despite of being totally resected after 3.5 years, a slight enhancement was seen. A small enhancement was seen. Here it's a large hemangioblastoma. However, there was no recurrence was seen in the long-term follow-up. So in the study, 78 patients underwent surgery in this study. Preoperatively, around 74% of the patients had a lower McCormick score. That is, they could able to walk independently and had mild neurological deficits. So those with the lower scores showed improved postoperative or functional outcomes. Those with bad scores, they did not improve. So that is so patients with lower better functional outcomes, functional grading preoperatively, they demonstrated the better outcome following the surgery. The WHO grading did not impact any outcome. Thank you.
Thank you, Dr. Dilip. As always, a nice presentation. We would like to go for next presentation by Dr. Dasarathi on spinal arachnoidosis, a case series, a single center experience.
Good evening. So my topic is on spinal arachnoid cyst case series. So spinal arachnoid cyst account for 1 to 3% of all spinal canal lesions, and these are rare lesions which present with pain and have been with challenging and controversial managements. So why we need a study? Because there are only few case series and there are only limited number of cases. So these are the case series list where you can see around only close to 20 number, not more than that. So in materials, we have a total of 23 cases, and over past 13 years, that is retrospective study, and all are we have analyzed demographically, clinical symptoms, location, and surgical outcomes. So results in coming to the age distribution, most commonly seen in female age group out of 23, 14 patients were females, and in age-wise distribution, almost patients are in between 21 to 50 years, and the mean age of diagnosis is 37 years. So this is the comparison between various other case series which are having higher number of cases like Garg et al, Pham et al, and Kalsi et al. So we had more or less like a similar demographic data. So coming to the etiological or history related things. So in 3 patients, we had the prior history of trauma who had cysted the only in the dorsal region, and it is all 3 cases are intradural. And one patient had spinal injection prior, and he had extradural arachnoid cyst. And prior spine surgery for one case, which is also having intradural uh, in nature. So no significant history was found in almost 18 patients. So symptomatology, back pain is the most common symptom, that is close to 52% of the total people, that is 12%. And weakness, patients presented with weakness and incontinence only in less than 10%, that is only 2 patients. So in comparison with the other studies, it is similar, close to that. Pain is the back pain or thoracic pain is the most common symptom, and weakness in incontinence are almost like only close to 40 to 10% only. So coming to the location and type, in location wise, as we know, the arachnoid cysts are more common in thoracic region, that is purely dorsal. So that is 15 patients, that is 65% of the patients, and the rest all dorsal lumbar, purely lumbar, and lumbosacral. So all these levels, when we see the average vertebral levels are close to 3. So in out of this cyst, the 12 patients had intradural cyst and 11 patients had extradural cyst. So arachnoid cysts are classified based on Nober's classification. So he has given 3 types. First one is extradural, second one is extradural with involvement of spinal nerve root fibers, and third one is intradural. So we had in each category in type 1 5 cases, and type 2 6 cases, and in type 3 12 cases. So we can see intradural are more common, and almost all the intradural cases in the type 3, they are in the thoracic region. So below are the MRS that you can see with the, here you can see it is extradural, and here extradural extending into the canal close to the root fibers. And this is the third one, intradural. So this is 3 cases pre-op MRS where you can see the extradural cysts. And this is 2 cases with the intradural cysts. So when compared with the other series, we didn't had any cervical case, but we had 15 dorsal cases. But rest of the other series, they are having at least 1 or the 2 cervical or cervico-dorsal cases. So coming to the surgery. So for intradural arachnoid cyst, we almost have done marsupialization only. And for extradural cases, we have done excision. So when in extradural cases, in out of 9 patients, we had the communication. We have observed the communication with the dura, the pedicle which is there, and we have ligated it. And for 2 patients, we couldn't find any communication, and we couldn't delineate it. So here is the comparison with the other studies. So like in the similar cases, so we have done laminectomy and laminoplasty as per requirement. So when complete excision was done in 11 cases, that are completely extradural, and marsupialization in 12. So in other cases, they have done various other procedures like fenestration and along with the cystoperitoneal shunts as well for recurrent cases. But fortunately, we never had any recurrent case. So follow-up and outcome, post preoperative compared to preoperative symptoms, motor symptoms have completely resolved, and only the sensory symptoms, they are persistent, or there is only mild improvement. So the results are also correlate with the other 2 studies. So here, this is the slide. So where we can see the complications of all these three. So in our case series, there is one case which had transient weakness, which has improved subsequently, and two patients had CSF leak, and both are associated with extradural cases, and the communication was not found. One was resolved with conservative management, and the other required resurgery, and only one patient had recurrence. So here you can see the pre-op scans and the post-op scan for the intradural cyst. We have removed completely. So this is the extradural cyst, pre-op and post-op scans. So this is one pre-op scan where when we have operated, we have identified there are two communications with the arachnoid cyst. So there are two separate arachnoid cysts in this case. So the important point here is when we find the extradural arachnoid cyst, we should observe for there is always a possibility of having a, multiple connections. So we have to see the whole extent of the lesion, and we have to find out if there are any multiple communications intradurally. So this is the video. So this is the type 2 cyst that we have operated, which is associated with the nerve root. So here we are trying to remove the arachnoid cyst. So closely from inferior above we are dissecting. So here we can see that the nerve root there. So generally what happens in these type 2 cases which are associated with the nerve fibers close to it, they have a close association with the dorsal root area. So we have to find a area where there is a communication that is always close to the dorsal root. So this is one intradural case, intradural arachnoid cyst. So the takeaway points are for extradural, particularly for extradural cases, we have to find the communication, and there is always a possibility of multiple communications. And the outcomes are similar for both extradural and intradural cases. Thank you.
Thank you, Dasrati. With this, we would like to conclude the session. I would like to thank all the speakers for sharing their different spectrum of cases. Thank you.
Thank you, Chairperson. Thank you very much. We'll close for the session. Thank you, one and all. Once again,